1 to 1.5% of people in industrial nations suffer from chronic wounds, such as pressure ulcers, vascular leg ulcers, and diabetic foot ulcers. Besides being a high burden on the patient, these wounds can also generate high costs for the healthcare system. But why are chronic wounds such a challenge? Wound infections are a major factor. It is estimated that more than 50% of all chronic wounds are infected. Wound infections are caused by microbials such as bacteria, which do not only like to multiply, they also produce biofilm. Biofilm forms when free-floating bacteria adhere to surfaces and grow a colony. This colony excretes a thick and slimy substance, an extracellular polymeric substance which consists of polysaccharides, protein, and other elements. Biofilm can also release bacteria which form new colonies in nearby areas. The biofilm acts like a shield for the bacteria and protects it from many antimicrobials, including antibiotics, and from the host's immune system as well. So there can be a constant threat of a chronic wound infection. To prevent the development of wound infections and to promote wound healing, it is important to remove the biofilm and achieve an effective wound bed preparation. The Prontosan range provides a smart solution to effectively cleanse the wound of biofilm, slough, and debris. Moreover, the special combination of ingredients reduces the biofilm and also impedes its reformation. The two main ingredients in Prontosan solution are polyhexanide and undecyleniamidopropylbetaine. To keep it simple, we call it betaine. Betaine is a surfactant. Let's have a look at how a surfactant works. A surfactant molecule basically consists of a hydrophilic, water-attracting head and a water-repelling, hydrophobic tail. Since the tail doesn't like water, it searches for another place to go, which here is our biofilm. The polar heads of these surfactant molecules have the same electric load, and therefore they repel each other. This is how the biofilm breaks up. Several of these surfactant molecules bind to the biofilm and build micelles, which can then be removed from the wound bed much more easily. In this way, betaine has in essence opened the door for the supportive effect of polyhexanide in Prontosan, which can now act against the bacteria. Polyhexanide, or PHMB, is used as an antimicrobial substance. It is able to attack and destroy various types of microorganisms. Gram-positive and gram-negative bacteria are protected by a cell wall, whereas human cells are surrounded by a cell membrane. These bacteria A bacterial cell wall has a negative charge, while the PHMB molecule has several positive charges, which makes PHMB act like a magnet, attaching itself to different areas of the cell, starting with the negatively charged outer cell wall. PHMB binds itself to the cell wall through electrostatic interaction,
Шановні колеги, запрошуємо всіх до залу.
Dear colleagues, we kindly invite everybody to join us in the hall.
Доброго дня, шановні колеги.
Good afternoon, dear colleagues. It happens so that we have a small delay due to an issues with getting into the territory of the hotel, but in the future we are going to eliminate this issue, and I hope that in the future we are going to be able to start on time. I'm extremely happy to see all of you on this first Congress of Trauma Ukraine, Trauma Congress Ukraine, which is conducted by the Ukrainian Association of Injuries and Rehabilitation. We are going to ask why it's on 17th of October and why it's called trauma. In case you're going to open Google, you're going to see that 17th of October is the Worldwide Trauma Day. This is the day which is dedicated to increased awareness about different traumas and its prevention. The goal of the day to inform the public societies about trauma and about safety in everyday life. That's why we have decided that annually on 17th of October we are going together and we are going to conduct Trauma Congress. To open Trauma Congress, the first Trauma Congress, we are going to invite the first Deputy of Minister of Healthcare of Ukraine, Professor, Doctor of Medical Sciences, but also practical anesthesiologist who works in polytrauma unit and who is well aware on polytrauma issues, Dubrov Serhiy. Good morning, dear colleagues, dear friends. I'm extremely happy. I'm extremely happy to have participants on this Congress. We have more military representatives. 42% of the military representatives had 2 or more anatomical regions which were injured. So we're talking about trauma. Right now, talking about the high quality care to patients with trauma, we need to talk about highly qualified specialists which know how to deal with trauma, injuries and surgeries. And mortality among patients, according to the worldwide statistics, with combined trauma is 4 times less in highly specialized units of trauma. And we need to highlight the issues which we have in front of us in our healthcare issues, both military and civilian. And using this opportunity, I would like to say thanks to the Commander of Medical Forces of Armed Forces of Ukraine for this tight cooperation in which we are living and which we are finding the solutions. And most of those solutions, according to my opinion, are the correct ones. Because despite the fact that the war is happening next week, we also investigate 15 more guidelines and protocols. So we are going to have 27 new protocol standards, which are essential for each healthcare institution to be fulfilled, and of course also to fulfill those standards and norms which are mentioned in these standards and guidelines. They are based on the evidence. I'm not going to tell you about the authority of joint trauma assistant, which are the basis of our clinical protocols and guidelines. The questions of journeys of our clinical protocols and guidelines. The questions of journeys which are needed to take certain correct decisions which are going to improve medical care among our citizens, among our military representatives. I wish everybody to have a fruitful work and also glory to Armed Forces of Ukraine. Thanks so much, Serhiy. Thank you. It's the third year when we have this war which is happening in our country, and such a tight I would like to correct a little bit our colleague Roman who said that we have war for 3 years. Actually, we have a war for 10 years, starting from 2014. And all of us remember how hard and how difficult it was for us to align provision of highly specialized medical care. In this situation, we are talking about providing the traumatological care, trauma care. And I do remember exactly when in National Medical Military Hospital, the first consultants from Spain and France arrived that were willing to provide support regarding the treatment of the gunshot wounds because they had proper experience in how to provide this kind of care due to the experience which they had in Iraq during peace missions, in Afghanistan. And in fact, that was a pilot project which started to be implemented based on the National Injury Clinic of the National Center. And of course, we had a lot of respect to our colleagues. We have provided them all the possible additional studies, but we did not expect the feedback. We were not waiting for that. And our specialists, they have performed all the needed volume of surgical interventions, which was needed at that moment of time. And the feedback appeared in 2 weeks after that. And when we have shown what we have done, our colleagues have mentioned the following: there is nothing to add, you have done everything correctly. And it's a pity to say, but we were learning daily, monthly and annually. And at this moment of time, thanks to this cooperation of military and civilian traumatologist surgeons, we have a rather good achievements in this sphere. And at this moment of time, I would like to say that our trauma patients, injured patients, they do not want to get treated abroad. Somebody is going to tell you that it's great abroad. According to the worldwide guidelines, everything is being performed. We have a lot of cases when complicated extremity injuries, which require long-term treatment, they were treated radically in the leading centers, and everything ends up with patient treatment and care. They have this opportunity, and in those who are in surgery operating rooms right now. So each one of us does everything feasible, and each one of us does everything feasible and not feasible of the lectures, but also thanks to the personal communication, to get pleasure due to the personal communication. I wish all of us to stay in a good mood, to have as fast victory as possible. Glory to Ukraine, glory to heroes. Thanks so much, dear Sergei. It's great that the hall is being filled in more and more. Sergei, Anatoly, we also see huge amount of honored guests in our hall. Guri Sergei, Professor Kostrup, Professor Kalashnikov Andrei, Professor Dovgopolov, Alexei, and others. We hope that with our efforts, with our united efforts among civilian and military medicine, we are going to develop a common system of united medical care for those who are injured and those who have injuries. I would like to invite President of the All-Ukrainian Association of Surgery, of Trauma Surgery and Rehabilitation, Doctor of Medical Science, Professor Ankin Mykola in our work, but we have forgotten that there is a huge amount of severe trauma, severe injuries. Why do we talk about glory to Ukraine, glory to heroes. And right now we are going to start our scientific part of our Congress. That's why I kindly invite Mykola to prepare his first lecture, and I also kindly invite moderators of our first part of our Congress. So I kindly invite Professor Valentin Piątkowski. Okay, so one professor is getting a little bit late. I would like to give a floor to Professor Valentin Piątkowski.
Dear colleagues, we would like to invite Mykola Ankin, profession, who is a trauma surgeon. Dear friends, I have already mentioned that we have established the association in order to get a lot of specialists together. Those who are treating trauma, paramedics, orthopedic surgeons, anesthesiologists, rehabilitation specialists, physiotherapists, everyone who is involved in treating such patients. Why? It looks like it's only 6% is the death rate in developed countries after trauma compared to heart diseases and other diseases. It's not a lot, but those are predominantly young people. And basically, this is 15,000 death traumas per day. So every second someone dies. So the lethality is 30% higher for trauma compared to HIV/AIDS, TB, and malaria. What can be mentioned about our country? The war that has been on for 10 years is very traumatizing. The treatment system to treat trauma in developed countries stands on 4 pillars. This is the specialist, trauma centers with multidisciplinary teams, trauma registry, and patient rehabilitation after trauma. When countries started to using those systems, maybe we are not starting in the right time, because the Germany with one of the best systems has started that in 1994, Austria 96, the Netherlands 2001, British 2007. So this is the results of specialists from Great Britain. They looked at trauma in their country. 14,000 people died due to trauma, 550,000 get trauma, 900,000 simple fractures, and 24,000 of them is polytrauma. But 600,000 lives could be saved. The majority of trauma care is of poor quality. Only 36% get to the clinics where the state-of-the-art care is provided. And because of that, that impacts bad results of care. So the decision was there was no systematic monitoring of services for the majority of trauma patients. Rehabilitation is inadequate, and funding plans do not correspond to the real expenditures. And in 2012, there was the following decision: trauma care is disorganized, pre-hospital care is weak, care is provided in hospitals unable to provide necessary care, no standard existing, and treatment results uncontrolled. But when new approaches were implemented, the whole network started to work, and over the 3 years, the death rate in polytrauma patients has decreased by 12%. So what do we have? Our problems to treat trauma. Lack of one concept of trauma treatment and routing of patient pathways, and there is orthopedic traumatology departments without any structure, and they have to do prosthesis, replacement, joint replacement, osteosynthesis, conservative treatment, and there is no system in that. We do not see that. No teams to provide care in trauma and polytrauma, no protocols of trauma care. Only now during the war the new protocol started to be implemented that would impact, that would influence, improve the treatment of our patients, also delayed start of rehabilitation of trauma patients, because the system has been created that is kind of far away from our orthopedic patients, and the funding from NHSU happens only when our patient gets into the rehabilitation ward. So polytrauma patients might not get into such a department for 1, 2, 3 months. So who's going to help them? And as of today, within the trauma treatment system, what we have, a lack of subspecialists, neurosurgeons, thoracic surgeons, plastic surgeons, and orthopedic traumatologists. They do mostly arthroscopy and replacement. That's logical. Surgeons also want to do some planned operations. Lack of good training in admission wards and the emergency wards, and the principles to assess the condition according ALTC. So if you know how to save the patients with trauma, so you have to provide care at the place of accident, organize transportation to trauma center, anti-shock therapy during transportation, current diagnosis and therapy in anti-shock ward, admission ward care, and also a team of specialists should be involved. Intensive care and care provision according to damage control or ALTK. So we know that the death risk is the highest during trauma, and then it decreases onwards. This is the golden hour in shock, the ability to survive. If we started early, so we get a high percentage of survivors. If it's after 1 hour, we will probably not be able to help. So the scope of care on a pre-hospital step, so we have to do the respiratory care, oxygen intubation, ventilation, if unstable blood circulation, so stopping the bleeding, also replacement, blood replacement, and also we have to use splints or things like that. Pre-hospital care, so we do the initial examination, intubation, IV transfusion, fluid transfusion and infusion, stabilizes fractures, and transportation to an appropriate clinic. Treatment of polytrauma and severe trauma patients needs to happen in specialized trauma centers. For example, in the US, there are 4 levels of such centers. Number 1, specialized centers, university hospitals, where all specialties are present. City, interregional level, smaller hospitals where the care is provided by 4 or 5 specialists, small hospitals also, but remotely and far from big cities. So very similar system is in European countries. So this is how to open the trauma centers. So there should be trauma surgeons, orthopedics, trained emergency rooms for adults and children, X-ray, CT, MRI, sonography, echocardiography, angiography needs to be there, intensive care for adults and children, and a helicopter pad on the territory of the hospital needs to be there. Hospitalization of severe patients need to be done into the anti-shock ward. So when patient gets there, the main goal for this patient is to survive. So first initial examination is according to ATLS. I'm not going to dwell in detail on that. Probably you all know that. So theoretically, but we need to do it in practice. So multidisciplinary team needs to examine the patient. So what's the composition of multidisciplinary group? Surgeon, anesthesiologist, general surgeon, orthopedic surgeon, emergency doctor, nurses, special nurses, surgical nurses who help doctors and other specialists if needed. So who is treating our polytrauma patient? So who's the treating doctor? Surgeon, neurosurgeon, anesthesiologist, the traumatologist, polytraumatologist? We don't know, in fact. So who gets them? Those people are taking care of the patient. For example, the lead in polytrauma team in Austria usually 85% is usually a trauma surgicalist. So that's the Germans decided for themselves. So I can tell you that the treatment of such patients needs to be done by a specialist, subspecialist. This is traumatologist or trauma manager. So the person like that coordinates all the diagnostic therapeutic steps, makes decisions with regards to surgery, resuscitation units, defines priorities, provides initial care, and also controls injuries. And the specialist of internal injuries, and that's a very disputable question whether that person needs to be the best operator, maybe not, but that's the person who has the biggest experience in organizing care of such patients. Competencies of such a person can be the manager of traumatology team, knowing system ATLS, ETC, examination, condition assessment. Also, they need to know how to fix fractures, plasty, uh, vertebral or spinal surgery, trepanation, cranial trepanation. We don't know. Maybe neurosurgeons are better to do that. Stop bleeding, to do urgent surgeries in abdominal area and thoracic area. So where do we take the resources to develop the community of injury or trauma surgeons? First of all, those are orthopedic traumatologists and military surgeons. There will be a time when military surgeons who are providing care at stabilization stations and on other levels of care are going to retire. We will not be having a huge army with a huge number of healthcare specialists coming back, looking for another job and coming to, for example, joint replacement or something, or learn arthroscopy. Probably it's difficult, would be difficult to do, but to create a new profession, to work, to be able to work in new departments, I think that's important. It's a lot of specialists that we have like that. So training of specialists in Austria, for example, 3 years rotation traumatology, 3 years in general surgery, neurosurgery, anesthesia as well. So that's what they do. And these are operations or surgeries that a surgeon needs to take part in. Falk surgeons should do to get his specialty license or certification. So only after they do these types of operations you can see on the left, so only after that they are certified to be such a specialist. And if we started to train such specialists right away, before the war, it would have helped us, because every trauma during the war is basically polytrauma. Coming back to the patient in anti-shock ward, so if we've done everything to save the life, and we've made the diagnosis, so the next step is, and the task is what to do. There are different strategies, 3 of them: surgical, damage control, and SDS. It's a new approach to damage control. Early total care. It's one-time surgical treatment of all injuries, used since 80s of the 20th century. but it can be done only in prognostically favorable conditions, because there's vicious circle: bleeding, coagulopathy, hypothermia. So there was three of those, but number four now is the soft tissue injury. When we operate, we also do the injury of soft tissues. It's an additional hit to the patient, and that aggravates his overall condition. So bleeding, coagulopathy, hypothermia, and soft tissue damage. So one is aggravating the next one or the other, and or all the rest. This is damage control surgery to save patients' life at any cost, using non-standard approaches and decreasing time of operation. So first publication 76 and 93, we can see major provisions and the concept. So we are focused on stabilizing patients, not on treating all traumas. So ETC, so everything but damage control, the major ones, and quick surgical procedures to control bleeding and to prevent further blood loss. So this way we decrease complications and improve survival of patients with severe injuries. And another approach, surgical damage control, so short and efficient interventions to control injuries, very often combined with DSC. And the benefits, it is short surgeries are done in order to decrease the likelihood of disability, and also decreasing complications, and also it allows to decrease the time of operation and stress to the patient. So these are phases of treatment for polytrauma patients: uh, resuscitation, then one surgery by indications, usually 2-3 hours, damage control method used, intensive care and reassessment 3 to 6 hours, second operation phase up to 1 day, and long-term operations and rehabilitation. And it's done all the time. And in each country, there is trauma registry in each country for traumatology network, and you can see different names of these registries. So they exist in all developed countries, in the US, UK, Europe, the Oriental countries, Japan, and the aim is to assess the results and control of treatment, auditing, quality control. So when we know where this patient is, we know his condition and the test results, whatever, we can think about referring him to other centers and involving other subspecialists. Unfortunately, rehabilitation system is kind of far from a trauma treatment system. Why? Because they've gone different ways. Trauma treatment in one direction, there is a rehabilitation system that has been developed, but in a different direction. It's kind of on its own. I don't think it's correct. We need to work together. We operate the same day or the next day, and the same day the physiotherapist is getting involved, who is helping um, to work on patient function, because 1 month later this function will not be restored. So we need to not to go back to rehabilitation wards, but to early rehabilitation of our patients. And if we are not able to do that, then the results of our treatment are not going to be satisfactory. It's important to start. You've seen the slide when the work has started. Over the 20 years, these countries that I've shown, they've gone a difficult way, but they've developed their own system of such patients' treatment. So I think that the steps in order to create an efficient treatment system are there. So new statistical system and trauma registry should be developed. Current emergency care service and system needs to be um, established and training, so it's existing, but they need to know how to transport, where to transport, and so on and so forth. Renovation of current admission wards. A lot of wards have been created, or departments, but they work according to the same principle as before. They do not form the teams who will altogether provide care to polytrauma patients. Trauma centers needs to be established. Maybe it's going to be not with orthopedic departments. I am an orthopedic specialist and I love my specialty, but we are not going to get anywhere if we don't make a special center. So new specialty needs to be established, trauma surgery or injury surgery. And also we have to develop and retrain the admission wards. It's not like a general admission ward. It's part of the work that this admission ward needs to do, be involved in providing care to polytrauma patients. And also we have to develop and implement treatment protocols for trauma patients. Thank you for your attention. Thank you very much, dear Mykola, dear colleagues. Maybe you have questions. I don't see any questions. My remark, just a little, it's not a question, it's a remark. In our Rivne Oblast Clinical Hospital, orthopedic traumatologist is the leader of the team, so I can share my experience if everyone's interested. In the Oblast Hospital, yes, in the majority of cases, the polytrauma team was created and it was providing care. And in the majority of cases, orthopedic traumatologist is working there. I don't know about now. Thank you.
The next presentation is the Principles of Polytrauma Management in Trauma Center, Frank Hindenburg. Буде online? Online. Okay.
Can you hear me?
Yes, we do. All good.
Okay, very good. Then I try to share my presentation. Can you see it? Everything is fine? Okay.
Yes, all good.
Very good. So thank you very much for the invitation. I'm going to talk about the principles of polytrauma management in the trauma center, and of course, we'll focus a little bit on the German system. And we already heard in the last talk about the relevance of trauma, and trauma is worldwide the leading cause for deaths in the working population. So we have around 6 million deaths per year due to trauma. Furthermore, trauma is the leading cause for the use of medical services. So we have around 140 million injured persons per year worldwide. Therefore, trauma is a severe public health problem, significantly associated with morbidity, invalidity, mortality, but also socioeconomic consequences. Compared to high-income countries, low-income countries have a significantly higher number of trauma cases and a 3 times higher mortality. And I think this underlines the importance of trauma systems and a well-organized treatment of traumatized patients. However, especially in high-income countries, we have a marked increase of geriatric patients due to the demographic development and an increased activity level of these older patients. The cause of trauma are dependent on the geographical region and the level of income of a specific country. So worldwide, around 1/4 of all polytraumatized patients are caused by traffic accidents, and thereby traffic accidents represent the leading cause for polytrauma worldwide. Further relevant reasons for injuries are attempted suicides, violent and crimes, falls, water accidents, poisoning and burns, and unfortunately, military conflicts. How is polytrauma defined? So we have no uniform definition of polytrauma. The very first definition of polytrauma was done by my former chef, Professor Czerne. It's multiple injuries to different body regions sustained simultaneously with at least one injury or the combination of these injuries being life-threatening. Internationally, the definition based on the abbreviated injury scale, or the ISS, is an ISS higher than 15 or an AIS higher than 2 in at least 2 body regions. Quite new definition is the Berlin definition. It's defining polytrauma as relevant injuries of at least 2 body regions with an AIS higher equal to 3. And in addition, at least one pathological value of these 5 parameters: age, hypotension, unconsciousness, acidosis, and coagulopathy. The basic, and we heard this also in the first talk, the basic principles of polytrauma treatment is an interlock of therapies in different treatment phases in the sense of a treatment chain. So we start with a pre-hospital treatment. This has to go to the emergency room treatment and then the inpatient treatment with operations, ICU treatment, and so on. And very, very important, the rehabilitation phase. What are the challenges of polytrauma treatment? So first of all, we have a high heterogeneity of the clinical picture, and we have a time-sensitive treatment in the acute phase. The treatment quality after trauma is dependent on the structural quality, for example, the establishment of trauma system, and the process quality with implementation of systemic treatment approaches and standards, and the quality of results. You have to measure how high your mortality is and the quality of life after trauma. So in many countries of the world, but I will focus on this white book from the German Trauma Society, which I'm president of. In these white books, we see recommendations for the structure, organization, and equipment of trauma systems as a basis for a high treatment quality of polytraumatized patients. We also can find something about the prevention, quality assurance, and the research as other key elements of good polytrauma care. How can trauma systems be established? So characteristics of trauma systems are the certification of clinics as trauma centers of different levels of medical care. And we also have regional corporations of certified trauma centers, rescue services, and rehabilitation facilities in trauma networks. The competence criteria for the certified trauma centers refer to the specifications for personnel and structural equipment of the clinics, establishment of internal treatment standards, the definition of capacity and transferable criteria, and external quality assurance. Based on the competence criteria, we in Germany define 3 levels of care. So it's the local trauma center, something like the level 3 trauma center, the regional trauma center. Internationally, it's the level 2 trauma center, and the super regional trauma center, which is something like the level 1 trauma center internationally. In the smaller hospitals, we take care of the isolated injuries. We do the primary care of severely injured patients, especially if no major hospital is near around the site of accidents. The patients are transferred to the local trauma center so that they can take care about the life-threatening injuries. And after that, they are normally transferred to level 1 or 2 centers. The regional trauma centers perform a comprehensive emergency care of life-threatening injuries. They have the prerequisite for definitive care of most of the injuries, and they transfer to supra-regional trauma centers in very complex cases. And in the supra-regional trauma centers, we do everything. We have to do definitive care of all kinds of injuries. We do emergency care of all kinds of injuries, and we also have the possibility to take care of specific injuries like burns, spinal injuries, replantation, and so on and so on. And these supra-regional trauma centers must take over all the patients that these centers want to transfer. So we can say, okay, we don't have the capacity to do it, so we have to do it. Looking at the tasks and the structural requirements of the trauma centers, again, the local trauma center, we have the guaranteed care with conduct of emergency procedures. We have a department of trauma and orthopedics or of general surgery, and we have the 24-hour availability of trauma, anesthesia, general surgery. We have an emergency department, a department of radiology, and of course an operation room. For the regional trauma center, we have the 24/7 readiness for admission and therapy of patients of any age, including very severe injuries. Again, we must have a department of trauma and orthopedics. We have the 24 availability of trauma and orthopedics, anesthesia, general surgery, emergency department, radiology, operation room, and of course, neuro and vascular surgery. And in the super-regional trauma center, we again have this 24/7 readiness. We have to provide all specialties and specific treatment units like burns, paraplegia, urology, ophthalmology, maxillofacial surgery. We have to be able to treat at least 2 polytraumatized patients at the same time. And we have to be ready, if we have any case of mass casualties, to take over all severely injured patients. So we have also structural requirements in the emergency room, which we have to fulfill to be a local, regional, or super-regional trauma center. I will not gonna read all these things we need, but if we don't have this, we will not be certified as a trauma center. And you see, it's quite a long list only for the emergency room. We also have lists for the operation room, for the ICU, and so on and so on. So, and all these trauma centers are organized in so-called trauma networks. And all the trauma centers and also the trauma network are regularly reviewed, and we do quality assurance with the trauma registry, where we have to document all severely injured patients. And here you can see these are all trauma centers in Germany. The red dots are super regional, blue dots regional, green dots local. And these trauma centers are organized in trauma networks. You can find ours here in the very west of Germany. This consists of, my network consists of 1 super regional hospital, that's our hospital, 3 regional and 17 local hospitals. And I think it's very, very good to have such a system, because also for the smaller hospitals, they can be sure that we take over all patients that they cannot treat. And if you have a look at the literature, you have an improved treatment results with establishment of trauma systems. And this is especially true for the severely injured persons, where you can reduce mortality by 75% if you have a functioning trauma system from pre-hospital to rehabilitation. You also need systemic treatment approaches and standards. These standards reduce the probability of errors, make faster diagnostics, a faster start of therapeutic procedures, and reduce the overall time requirements for the emergency treatment. And you will hear about the ATLS or ATC concept in another talk. What I also want to mention is this recommendations of the polytrauma treatment. So these recommendations are subdivided in 3 phases: pre-hospital, emergency room, and first surgical phase. We have an evidence-based establishment under consideration of international literature, and also have a consensus-based guidelines considering all societies, German societies involved in trauma care. And these recommendations really help, because also people in smaller hospitals or unexperienced persons can have a look at these guidelines and see, okay, what is recommended in which specific situation. And this also helps to make treatment uniform. In the pre-hospital and emergency room phase, we have to stick to the ATLS principles with A, B, C, D, E. We need clear activation criteria of the emergency rooms. We need defined teams with a pre-structured working plan and specific training. We need a generous ER activation in case of geriatric patients. And in these guidelines, it's defined that the emergency room activation should be performed in case of these pathological findings, again, according to the ABCDE. And we also activate our emergency room if we have the following injuries, measures, or criteria. You can see it also here. It's if the emergency doctor is reporting about an unstable chest or an unstable pelvic, penetrating injuries, amputations, and so on and so on. We will always activate the emergency room with the entire team to be ready if the patient arrives in our hospital. What I want to show here is that your emergency room, according at least to our rules, has to be equipped with a CT scan as one of the most important diagnostic tools in polytrauma treatment. You have to do an EFAST, you need conventional X-rays, an ECG, and also an MRI. And what we all do with all polytraumatized patients, we do a timely whole body CT scan. If the patient does not to be reanimated or needs an immediate intervention or a surgical procedure, then we delay it after the surgical procedure. But whenever it is possible, we do a timely whole body CT scan, because we saw in a big evaluation of our trauma registry that we can reduce mortality if we do a timely whole body CT scan. And indications for these are mentioned here: fractures of two long bones, high energy accident mechanism, disturbed vital parameters, or abnormal findings at the physical examination. And with the CT scan, we also can reduce the number of missed injuries. But what I want to emphasize is that we need a secondary and a tertiary survey to reduce the number of missed injuries, because especially in the region of the extremities, we miss a lot of injuries if we don't do the secondary and tertiary survey. So, and after emergency room treatment, the patient should be characterized as stable, as in a borderline situation where you don't know exactly where the direction, in which direction it goes, and you have clearly the unstable or an extremis. And according to this estimation, you have to perform the further surgeries in these persons, patient group DCO, in this patient group ETC, and here you have to do a close re-evaluation if you can perform definitive surgery. And I mentioned it in the beginning of my talk, rehabilitation is extremely important because life quality after polytrauma is much worse compared to the normal population. And as if you have a big gap between ending your hospital treatment and starting your rehabilitation, you will have a much worse result than when you have the rehabilitation process directly after the acute care phase. And the rehabilitation has to focus on physical, cognitive, and psychological consequences. And if you perform efficient rehabilitation measures, you will have reduced pain, you will have a better reintegration and a higher return to work rate. But you also need a multidisciplinary team approach to do a proper trauma rehabilitation, and you do have to coordinate the rehabilitation phases. Last but not least, mortality. So historically, we also talked about the trimodal distribution of death after polytrauma within minutes, within hours, and within days or weeks. And newer studies show that we have a significant reduction of late mortality, probably to all the measures that I mentioned before. But of course, we have these deaths within minutes and hours due to TBI and severe hemorrhage. But this MOF and sepsis mortality has been significantly reduced. Therefore, the rehabilitation is getting more and more important. So in conclusion, trauma is worldwide the leading cause of death among employed persons. The establishment of trauma systems, implementation of standardized diagnostic and therapeutical algorithms result in improved treatment results. Defined emergency room teams with clear activation criteria are needed. We clearly recommend the early whole body CT. We have to be careful about missed injuries. Therefore, always do a second, third, and fourth examination at day 1, 2, 3, 4. Whenever it will possible, and again, if the patient is awake, so that he can tell you where he has pain. Start rehabilitation as early as possible and do a continuous treatment between acute care and rehabilitation, because then you will have the best functional results. And we were able to achieve a significant reduction of mortality over the last decades. And therefore, life quality is of increasing importance. So the mortality decreased from well above 20-25% in 1980, 1990 to now around, let's say, 10 to 11%. And we hope to be even better in some years. And therefore, we have to take care of the rehabilitation process even more than in the last decades. So thank you very much for your attention.
Thanks so much for this amazing lecture. Dear colleagues, does anyone have questions? Thanks so much for this lecture. It was extremely valuable and interesting. It is important also to know what kind of guidelines, what kind of trials or studies, or what kind of resources do you use when you prescribe early rehabilitation, during which you have mentioned. For us also to use the same resources, how to do it and how to do it in a better fashion and manner.
Yeah. So in Germany, for example, we have different kind of insurances. This is a public insurance, and one, it's called workers' compensation insurance. And if you have an accident as an employed person, you are insured by the workers' compensation. And these hospitals have really extremely good rehabilitation facilities within the hospitals. And what we can see is that the return rate to work is very, very high in these workers' compensation hospitals, because they have such fantastic rehabilitation systems. And therefore, we try to implement this also for the public insurances, because in these patients, we often have a rehabilitation gap. So we stop the treatment in our acute care hospital. Then these patients have to go home, or even in a care facility for geriatric patients until they are fit enough to go to a normal rehabilitation center. And this is really, really bad for those patients.
I think maybe the translation was a little different, because the question was about research, medical resources, not about money. So medical resources, scientific and research.
Right, yeah, okay. It's focusing on scientific, okay.
So again, about medical resources, medical, not financial resources, medical resources, healthcare resources.
Yeah, what exactly do you want to know? What medical resources we have in where? In the acute care hospital or in rehabilitation, or?
Our colleague was interested in which public healthcare resources the information can be provided with regards to providing care to polytrauma patients, your internal standards.
Okay. Now I understand. It's not a public one. This trauma registry we have in Germany was funded by the German Trauma Society. And all trauma centers they must enter the treatment data into the trauma registry. And then we have like 3 to 4 to 5 persons who only take care of this trauma registry. And if we have any kind of question regarding which treatment is the best, we can have a look in this registry. And we have data of around 400,000 patients in there. And then we can see everything we want to see. But this is not paid by the government. It's paid by the clinics who enter the data into the registry. It's not funded by the government.
Thank you. More questions? Thank you very much for your presentation. Can you tell us, please, you have mentioned like mass casualties. So number one question, how many patients has to come in order for you to classify it as mass casualty? Second, methods of evacuations that you use in such situations.
Yeah. So in Germany, even a number of an accident with 5 to 10 people is already a mass casualty, so a small one. But this we can handle without activating any let's say mass casualty plan. So if we have like 30 patients, we will activate. So the fire brigade will activate the mass casualty, and then we have plans and so on. What we will do. So we, of course, will stop immediately all elective surgeries. And then our operation room and the emergency department will be closed, and then all the patients will come. And we have this code red and code blue, green, black to estimate how severely injured the patient is. And then we will decide how to go on further with them. So we will be ready to take over 50 patients with the different codes. So like 5 code red, 10 with blue, and 20 with green, and so on and so on. So this is exactly planned. So it's probably not, unfortunately, like in your country where you have much higher numbers than we have. But if we have something like a bus accident, for example, and have like 20 accidents, we will activate this mass casualty plan.
Thank you. And Professor Guriev has a question from the audience. Thank you very much for very informative presentation. What's the maximum volume or scope or casualties that you have ever had in your trauma center, like per 1 hour, 10, 20, 100, like first hour right after the accident?
Yeah. So the biggest one was a bus accident where 4 severely injured patients and around 10 to 15 mildly injured patients arrived. But this is really completely different. We have lots of hospitals in Germany, and all in Aachen, where my hospital is, we have like 4 hospitals within the city, and around 16 in a range of, let's say, 20 to 25 kilometers. And so we will never have like 100 patients or something. So we are the only one who is taking care of really badly injured patients. But this mildly or moderately injured patients can be distributed to like 15 different hospitals. And even Cologne, which also has two major hospitals, is only 70 kilometers away. So we are really in a comfortable situation, to be honest.
Thank you. Thank you. Thank you. So that supports the importance of patient clinical pathways. And another question, Professor Hildebrand, thank you so much for this wonderful presentation. Considering decrease in mortality and length of ICU stay thanks to trauma centers that you have now, you as a president of STS, maybe you can tell us briefly what are the major infrastructural or logistical challenges that you have in healthcare systems, usually in developing countries like ours, when we want to establish centers like that, because one thing is to organize them in Germany, or the other thing is to organize them in Ukraine. Like you having your huge experience, what would be your hint or recommendation how to overcome such challenges to establish such centers in Ukraine? We've already understood that registry is up to us, like how we organize trauma surgeon, orthopedics, how we organize, but trauma centers is actually to overcome different political challenges and others. Would be nice to hear your opinion. Thank you.
Yeah, so to be honest, also the organization of trauma networks was not organized by the government. It was also organized by the society, by the German Trauma Society. And also these certification criteria for trauma centers were also defined by the society and not by the government. So we did it on our own, and now the government says, okay, this is perfect. We use it also for let's say, payment and so on and so on. So all the initiatives came from the society. So probably, I know it's hard, but probably you have to do the first steps and hope that the government supports you, because even in Germany they had no initiative to do something like this, and it was all coming from the societies. And then the government said, okay, good idea, we will support you. It was unfortunately, it was also not as I would like to have it, that some ministers are saying, okay, trauma is extremely important, we have to finance you and we have to organize the treatment. It was the other way around. So we from the society started the process, and now we have even additional funding from the government for trauma. But it was only the second step after the society did all the network and certification stuff.
Thank you so much. Dear colleagues, we are tight with time, so well, that's the last question. I would like to ask you, still, historically, what was the role of Trauma Association, you being the president of German Trauma Association? So what was the role of orthopedic traumatology community? What was the role of surgical community? And what other additional surgical specialties were involved, like neurosurgeons, whatever, and who prevails with regards to composition now? That's very relevant for us because we have the same tasks for Ukraine. Thank you.
Yeah. So it was only the German Society of Trauma and Orthopedics who was initiating. It was not their idea, and all the other subspecialties trauma and orthopedics and trauma. At the initiative. And we don't have an emergency surgeon in Germany. So therefore, the orthopedic and trauma surgeons, we are the same group. We are all in Germany, we are all trauma surgeons and orthopedic surgeons combined. And we did all this, and the other societies were just involved, but we started the initiative. And again, we don't have emergency surgeons in Germany, so we are kind of emergency surgeons also in Germany, with general surgeons who support us, of course, if we have abdominal injuries and so on. But we are responsible for the polytraumatized patient as trauma and orthopedic surgeons. And we started the process.
Thanks a lot. Thank you very much for this valuable presentation, your valuable experience. It was a great pleasure, and see you next time.
Bye.
Dear colleagues, and the next presentation is Konstantin Humenyuk, main surgeon, leading surgeon of Armed Forces Ukraine, current aspects to provide surgical care to injured patients and soldiers in Ukraine in current war. Thank you. Glory to Ukraine, glory to Armed Forces of Ukraine, and glory to Ukrainian surgeons, both civil and military, those who are saving lives of our soldiers. Dear panel, dear organizers, thank you very much for this opportunity to speak. It's a big honor for me, and hopefully that the second Trauma Congress in 2025 is going to happen in a peaceful, independent Ukraine. Let us start. I would like to mention I have no conflict of interest, no secret messages. You know that in order to organize surgical care during war, that's what Pirogov used to say. That's very relevant. He mentioned that it's not healthcare, but administration has the leading role in saving wounded during the war. And the way we provide and organize care, the result is going like that. During the full-scale invasion of Russian Federation into Ukraine, a lot of towns and cities of our Ukraine were hit by missiles. These were close to front lines, Zaporizhzhia, Kharkov, also Kiev and other cities and towns. And due to those artillery and missile hits, the surgical service of Armed Forces of Ukraine saw lots of mass casualties, wounded and deaths. The number of those who died were not only in frontline areas, that's where we used to be located, dislocated, but a lot of our military units that were within our country in other places, remote from frontline, also were hit. And then we saw lots of problems, mass casualties, and these mass casualties were coming to our front surgical groups, the military hospitals, mobile hospitals, with regards to all our medical centers. And then that we didn't have enough beds in military healthcare facilities. It was very limited. And then we were forced to redistribute lots of casualties to civil healthcare facilities. So a lot of the wounded soldiers are treated in civil healthcare centers. Second is supplies, healthcare supplies. I would like to say this is blood and blood products, especially in frontline areas, antiseptics, antibiotics. And you remember the problem with which we faced. This is the external fixation system, back therapy, and disposables, thanks to volunteers and partners and everyone who was involved in providing care. So with the whole world, we were getting those, for example, X-Fix systems for our wounded soldiers. And evacuation is the next challenge. Because of mass casualties, beds were occupied, and these casualties had to be evacuated to the next level of healthcare facilities within the country. And because of mass casualties, the commandment of armed forces and the Ministry of Healthcare, actually, they developed the one healthcare space or one medical space. There were a lot of conferences and discussions about one space, medical space, but the war actually combined and connected military and civic healthcare facilities, I would like to say. So what is one medical space? This is the system of one network of healthcare facilities in the country with all types of healthcare services provided, and it combines all healthcare resources with one management and mechanisms of funding. So that's very important. And of course, for servicemen and for all defenders, we provide guaranteed all kinds and types of health care, medical care. And of course, with regards to supplies and logistics, at that time, the volunteer movement has helped surgical service of armed forces a lot to provide supplies to the wounded soldiers. I would like to say that implementing the clinical protocols that have been developed and are being implemented is done. So blood and blood products were used in those stabilization stations, so they do hemotransfusion, saving our patients. You know, in the beginning of the war, a lot of medical companies have started to help the surgical service, like B. Brown, one of the first, 4 big general surgical sets like suture material and other surgical instruments, and they were brought to our mobile hospitals. Of course, that improved the quality of care to our wounded soldiers. And I would like to give you a little video, laparoscopy in gunshot penetrating wound, open wound, the ascending part of colon. So many invasive techniques and the instruments, state-of-the-art instruments were used. And as of today, the surgical service of armed forces of Ukraine has a huge experience doing end-video surgery.
This patient for the first time had endoscopic stapler marginal suturing of the gunshot wound. You see that the whole surgery was conducted in a laparoscopic manner. Thanks to the step where we were able to excise the incoming gunshot wound of the colon with great clinical outcome, and also the discharge of this patient. And this patient also fulfills his duty. He is back to the service in the battlefield. Thanks to the presence of the modern materials, military surgeons of Ukraine in 2022 near Bakhmut, they had 2 modern laparoscopic surgeries, laparoscopic nephrectomy among our injured patients, thanks to which we were able to preserve the life. And you see the first day after the surgery and after the wound, this patient, before being transported to the next stage, he's sitting in the bed and he was able to communicate and he was able to be more or less active. At this moment of time, I would like to say that this kind of surgeries, we have more than 1,000 of those in case of the modern gunshot wounds of both abdominal and chest cavity, thoracic cavity. Also, thoracoabdominal injuries, which we observe a lot, and thanks to the equipment, we have the possibility to conduct modern surgery interventions. Evacuation is extremely important because you know that starting from 2014-2015, we widely use aeromedical evacuation when the injured from the front lines were able to be evacuated to our city medical centers, to our leading medical and scientific institutions, where we were able to evacuate injured with the gunshot wound, with the heart gunshot wound to a Moscow institution. And in a couple of hours, this patient was already receiving a highly specialized a highly specialized institution. At this moment of time, we are unable to use aeromobile evacuation, but we use aeromobile evacuation at this moment of time thanks to the police helicopters, Ministry of the Emergency, and also we do it from our battlefield cities. From Dnipro, we evacuate our patients to Kiev, where the most where when the most sophisticated patients are being transported with aero evacuation, and also we evacuate patients with trains at this moment of time. At this moment of time, we have also reanimation units inside the trains, where we have artificial one, where we have ventilators, vasopressors, and patients are being evacuated to different parts of our country. Also, emergency care, emergency service helps to evacuate and to transport our patients within the borders of our country. Of course, one of the most important questions which we have right now in front of the surgical service of Ukraine. At this moment of time, we are unable to evacuate patients quickly from the battlefield. You may see that despite the marking of the Red Cross, patient, our enemy destroys our transport, our doctors, our combat medics. They die, all of those who provide care in the prefrontal lines, and this kind of evacuation is being delayed. Patient might stay 3, 4, 6, more than 12 hours in the battlefield, and you do understand what is the state of those patients when we get them. That is an extremely complicated issue which we need to work on and which we need to improve. We need to improve the evacuation from the battlefield. At this moment of time, you know that there are approaches which are being implemented when evacuation is being happening with the modern drones. We have this kind of elements, we evacuate those patients, but at this moment of time, we still have mortality among combat medics. I would like to show the evacuation measures which we have right now in the armed forces of Ukraine. There are certain levels. The first level, that's the battlefield. The second level, these are our mobile hospitals which are being opened in the prefrontal lines. The third level, these are all of our military clinical centers, all of our institutions of healthcare where patients are being transported. Fourth level, that's a highly specialized care, and rehabilitation centers. As a result of having stabilization institutions of combat brigades, this time which we have lost, this golden hour of transporting the patient, this issue happens on the first level. So now regarding the patients when they are being transported to the surgery, to our mobile hospitals, this time is really quick. 30, 40, 1 hour patient from stabilizing point is being delivered to the highly qualified healthcare professional care. On the second level, we have damage control surgery. That's an essential component because this approach saves lives. And from the statistical point of view, we have already decreased the amount of complications and also decreased mortality. In the third level, second look surgery in case it is needed, and other types of surgeries. One of the biggest issues which we have right now, that's post-tourniquet syndrome. You do understand that this delay of evacuation from the battlefield, it leads to the situation that tourniquets on the limbs, they are for 12, 16, or even 30 hours. That's the whole time when the patient was being unable to be evacuated. Of course, we have done a couple of steps forward. We have a common order of the medical forces of armed forces of Ukraine about the conversion of the tourniquet, about tamponades of the wound. But when you communicate with our military personnel, enemy is not given an opportunity to evacuate the patient. So when those patients are being transported to the second level of care, to military surgeons, they are forced to perform amputations. But the biggest issue which exists when we have analyzed the statistics of that damage, you know that the damage of big vessels in those cases, that we did not have a lot of them. We have a lot of cases when the trauma is not that big, without any kind of gunshot damage to huge vessels, just soft tissues without any kind of bleeding, serious bleeding, but everything ends up with amputation. It's a social issue, it's prosthesis issue, that's rehabilitation issue, and it's a pity to say, but we have a lot of those injuries and we have increased amount of those injuries. Shortly, I would like to show you this kind of map. It's not a secret. You may see with yellow triangles, our stabilizing points, our mobile grip aids. With red dots, we have our mobile hospitals, military mobile hospitals, and you see also prefrontal lines in Luhansk region, in Kherson region, and even in Sumy region. You may see where are the levels of providing care and evacuation. Battlefield, stabilizing point, primary surgery interventions, mobile military hospitals, then prefrontal cities. That's Kharkiv, Zaporizhia, Dnipro, Kherson, and further on those patients are being evacuated within the border of our country. Of course, we have our western part of the country where those patients, when they are being stabilized, they are evacuated to the different kind of cities in the western part of our country. Lviv, Ivano-Frankivsk, Uzhhorod, and other cities. So this is the approach of organizing the care. Talking about the organization of the surgical service of the Armed Forces of Ukraine, I would like to say thanks to our surgeon of the Ministry of Healthcare of Ukraine. I have constantly friendly cooperation with them about all the severely injured patients which are in the armed forces of Ukraine and also in civilian institutions of healthcare. We are cooperating tightly, and you may see that there is this kind of circle where I am a chief surgeon of health of armed forces of Ukraine, and I have information about all the patients which are being hospitalized. I have this information from all of our prefrontal lines, from mobile military hospitals, and from our surgical teams. So then all of our clinical centers and institutions of health care, of Ministry of Health Care. At this moment of time, this is the system and how it is functioning regarding the service provision. And I would like also to say thanks to all of our leading scientific research institutions, Ramadanov Institution, where we have the most severe patients with spinal and brain injury, and they're being treated in this institution. Heart injuries, heart wounds, Amosov Institute and Heart Institute. In case of abdominal wounds like pancreas, liver, and colon, this is being treated in Amosov Institute. Also, the Institute of Traumatology, which is treating the extremities damage and wounds, and also burns, all of our burn centers within our country. So at this moment of time, I would like to say that the cooperation among the surgical service of Armed Forces of Ukraine and medical institutions of Ministry of Healthcare. At this moment of time, I would like to outline those issues which are in front of us. That's antibiotic resistance. Dear colleagues, you do understand that those stages which our patients go through, we have issues of antibiotic resistance. We have also some issues regarding the antimicrobial therapy prescription. But at this moment of time, the results regarding the improvement of this situation are being observed. Despite that, of course, this is sepsis, one of the most severe issues, because the modern gunshot wounds, they lead to complications, and a lot of our wounded, they die because of sepsis. Amputations, which we have mentioned, then the development of osteomyelitis, long-term treatment, which is a huge issue. As a result of the post-tourniquet syndrome, we have an increased load on the dialysis departments, the acute dialysis conduction, and also patients, also specialists and equipment which is additionally needed. And maybe you have seen some of those defects of the tissues which we observe as a result of the modern weapons. And at this moment of time, we have this tight cooperation between the surgical institutions of MOH, where specialists, they know and they know how to cover the huge tissue defects. They help us to treat this kind of patients. Another issue, that's erosive bleedings among our patients, which happen in the post-surgical period of time. Peritonitis, one of the most severe issues when we have gunshot wounds of the abdominal cavity. Meningoencephalitis, gunshot meningoencephalitis, number one issue because we have a lot of complications, high mortality and morbidity because of the gunshot wounds of spine and brain, and of course Pelvic syndrome, where a lot of our patients are in this kind of state. Dear colleagues, at this moment of time, there is a highly functioning and well-described concept of providing surgical care among those who are wounded in war. We have a medical military doctrine of Ukraine. We have the Unite medical space where we have a strategic and tactical approaches. And at this moment of time, we do understand that there should be a united administration, the common understanding regarding the modern combat wounds, the united approaches regarding diagnostics and treatment with the modern approaches with appropriate levels of medical care and evacuation in case it is needed. In time, consequent, exact performing of medical procedures within the medical facilities. And of course, we have talked about trauma registry. We need to have an appropriate data regarding all the wounded patients. Regarding the tactical level, we need to have the evidence-based approach to the treatment of the modern combat wounds. Science should be in the basis of treatment and management of the modern wounds, combat wounds. We need to evaluate the ballistics of the modern weapons. Our enemy uses modern weapons, and we need to know about them, and we need to know about the consequences of these weapons being used. Also, we need to prevent and to treat curative and septical complications. Also, we need to use modern prostheses, which at this moment of time are available. We have a lot of prosthesis factories, and they use modern prostheses at this moment of time. Despite that, there is an issue regarding the transplantation of tissues and organs. Dear colleagues, we have two cases through this whole period of time of the full-scale invasion of Russia. Two military representatives, they had both kidneys being injured, and there was an issue regarding the kidneys transplantation. One patient is being under the surgery. Father has donated his kidney, and at this moment of time the recipient is alive and has a great clinical result after the transplantation, after the gunshot wound. And of course, we need to prepare surgical stuff, and this is a huge issue. We need to implement modern minimal invasive technologies. We need to evacuate injured quickly. We need to adhere to the standards of care on all levels of medical care, and also modern equipment on all levels of medical care. Dear colleagues, injured should receive a high-quality surgical care at that moment of time where he has a need in it, before highly specialized care is going to be provided. Thanks so much, all of you. Let's move together towards the victory. Thanks so much for this great talk, an informative talk. We have a proposal to have questions during the discussion period of time because we're a little bit off the timing. And the next talk is going to be the organization of service regarding the treatment of acute and intermittent pain among injured in the inpatient facility. Andriy Strokan.
Шановні колеги, доброго дня.
Dear colleagues, good afternoon.
Хочу подякувати оргкомітету за
Right now, I would like
можливість
to say
виступити
thanks
на
to the organizing committee for this opportunity
достатньо
to
серйозному
deliver
заходу
talk on this
присвяченому
first
травмам.
serious event, which is
На жаль, не
dedicated to
зможу
trauma
бути
treatment.
особисто
I'm not going to be able to be
певних
present in
обставин,
person because of
якраз
some
сьогодні
kind
маю
of
доповідь на Африканській асоціації
events.
регіональних
I am also delivering a
з приводу
talk
того, як ми
on
лікуємо
the African
пацієнтів з
Association of the Pain
політравмами.
Management
В
and among
президії на
patients
нашій
with
секції
trauma.
буде Ігор Михайлович
In
Зазірний.
our
Я
section,
думаю, що
we
він
are going to
допоможе
have
відповісти на ті
Professor
питання,
Zazirny,
як у
who is
нас
going to be
організована
able
служба,
to
якщо
answer all
вони
the questions
послуги
regarding how our service is being
в
organized,
шановної аудиторії.
in case any of you are going
Організація
to have
служби
those
з лікування
questions.
гострого і проміжного
Organization of the
болю
service
у
regarding the
пацієнтів з
treatment of acute and
політравмою
intermittent pain
багатопрофільному
among
стаціонарі.
patients
Це
with
нова
polytrauma in the
дефініція служби
multi-profile
болю
inpatient
і
facility.
нове визначення болю, саме проміжний біль, тобто біль,
We are
який
talking
триває
about
у пацієнтів
intermittent pain and
більше
acute pain.
3
Intermittent
місяців, і
pain,
вони
which
далі
happens
знаходяться в
for more than
лікувальній
3
базі.
months,
У
and
мене
then the patient
відсутній
is still
конфлікт
being in the
інтересів в
medical
даній
institution.
доповіді.
I do not have a conflict of interest
Клінічне
regarding
лікарня
this topic.
Феофанія. Спочатку повномасштабного
So,
вторгнення та й до
Clinical
нього
center in
ми приймали
Fairfalia.
пацієнтів, які
Starting from
виходили з
the full-scale
26-го пекла,
invasion, we were having
Це
patients
було
which were
учасник
getting
підприємства 20
evacuated.
пацієнтів. А
These were the
розпочали ми
patients,
свою
around 20 of
діяльність
those
пов'язану з
patients.
лікуванням
And
політравми,
then we started our
коли
treatment
зробили
regarding the
найбільшу
polytrauma
медичну евакуацію
when we had the biggest medical evacuation, when in one day 26 patients were being evacuated from Dnipro from the intensive care unit, and our units were fully filled. I'm not going to discuss statistical data, but overall I would like to say that at this moment of time we have more than 50% of the patients in our hospital. These are the patients with the combat wounds, and we are dealing with the most severe patients. So we have made this journey from those institutions which were providing care, and we were then converted to the medical clinic, which is highly specialized in polytrauma, and we have 80% of patients with polytrauma, combat polytrauma, and we are the hospital which is responsible for one of the most severe patients. How did we start our journey? We started to read a lot of information regarding this topic, because this kind of amount of wounded people were not present there before. And regarding patients with trauma, I would like to say the following. In fact, it does not differ a lot regarding the literature data regarding how to treat patients with pain, with classic pain, but reality is completely different. That's Buchenmeier. He has written one of the best books regarding the treatment of patients with trauma, regarding the pain management of those patients, and this is something like a guideline for us in our practice. How did we start? Taking into the account that this is the educational center for the regional anesthesia, that was a good start for those patients. Regarding performing the regional anesthesia approaches, taking into the account that hospital system does not allow us to follow up on everybody, we have collected all their medical histories, and then it was used in the anesthesiology department. Then we have all the changes which are being accounted in order to identify what is the pain management approach which is the most suitable and what kind of approaches should be used. So what is extremely important? We need to evaluate the pain syndrome in case we perform any kind of surgical intervention. Communicate with patients, and we need to understand, and we need to explain to them what kind of information, what kind of trauma has happened, and we need to daily examine the patients, which are severe patients with polytrauma, which have been hospitalized with regional catheters. And right now we have a huge workforce which is called interns, which are highly interested in receiving the knowledge, and we use them as an educational staff to provide the needed pain management. And also we need to have cooperation. What I would like to say, without the team, all of those actions are impossible to be taken. Our anesthesiology service has started, but then it was transformed in all departments in the in-hospital in facility, and we need to be patient-oriented, client-oriented, so we need to be patient-oriented. Take a look at the amount of specialists which are participating in order to treat one patient. Thanks God, we have a multi-profile clinic, and we have all of those specialists, neurologists, neurosurgeons, anesthesiologists, psychologists, psychiatrists, social workers, specialists on the physical therapy, physiotherapists, ergologists. These are the neurologists who have a subspecialization. We involve patients with prosthesis, specialists in prosthesis, and also vessel surgeons. And what is also extremely important over here, the social worker, which works since the beginning and helps us. We have a lot of psychologists and psychiatrists which play a huge role.
Now the system has been transformed, so it's difficult to refer patients. What have we done? Google Forms, so with help of young doctors, and now each doctor is his cell phone has a list of patients where it says what has been done and when with regards to pain syndrome, and what is the assessment results, and what kind of information you give to the next shift. And any specialist who is involved in care of this patient can assess the data, what has been done, what changes in therapy there were,
повністю все освітлити.
and that's important.
Біль є однією з основних проблем,
Pain
але крім
is
болю
one
є
of
ще
the
три дуже
major
важливі речі.
problems.
Це пацієнт
Besides, there are three
безсоння,
other things.
це, на жаль,
It's
психологічні,
insomnia,
психіатричні розлади і
unfortunately,
невизначеність. Якщо
mental
перших півроку
psychiatric
війни всі
disorder,
ваші пацієнти
and
посміхались, наші
in
принаймні посміхались, то
instability,
останні 2
like
роки
for the
людей
first half a
сьогоднішньої
year,
людини достатньо
all
часто
our
не
patients
побачите
were smiling.
серед
For
цієї
the
категорії людей, які
last
потрапляють в
2
клініку.
years,
Люди
you would
досить часто
see people
знаходяться
are
у нас
frowning,
військових
not
з
smiling.
пораненням, з травмами,
People
знаходяться по тиждень,
who's
по 2,
been with
по
trauma,
місяцю, по півроку. Є
injuries
пацієнти, які
stay
лікуються в
for
короткому стаціонарі.
weeks and
І
months
оце
and
все
half
коло
a
має
year. We
надзвичайно
have patients
важливе
like that.
значення для
So for
лікування
them and for
пацієнтів.
everyone, all this circle
Яка
is
мета, які
important.
цілі? Досягти
What's
стану
the goal
пацієнта,
of treatment?
коли у
To
нього рівень
achieve
болю
the
є
patient
відсутній
condition
або
when
легкий,
his
не
pain
заважає йому
level is
функціонувати.
absent
Це
or
перший пункт,
mild,
дуже важливий. Далі,
like let him
максимально
functioning.
можливо
That's
вплинути на
important.
безсоння та депресію,
Also,
не
we have
допустити
to
розвитку хронічного болю.
influence
Чим
insomnia,
краще замовити
depression,
безліч
to prevent chronic pain
і
syndrome.
повернути пацієнта
There
до
are ways to do that, and
соціалізованого
to
життя
return the
або
patient
військо, якщо це
into
неможливо.
his
В цьому
social
плані
or her social
відрізняються
life
цивільні лікарні
as
від
soon as
військових,
possible.
тобто
And
пріоритизація,
that's the
яка є у
difference
цивільних
between
лікарень,
civil and
це
military
пацієнт і
hospitals.
якомога швидше повернути його саме до соціалізованого
So we
життя.
need to
Що дуже
return
важливо з
the
боку
patient to his or her
анестезіології,
social life. So
і
regional
нереакціальні методики
anesthesia,
мають володіти всі. Не
neuroaxial
один, не одна
methods
дві людини
has to
підрозділу,
be
а всі
done
співробітники служби
and
анестезіології
no, not just by one person,
Що ми
but
робимо з
all
пацієнтами, які до нас
those who
потрапляють?
work in the
Найчастіше ми
Department of
беремо пацієнтів
Anesthesiology.
по медичній
So the
евакуації.
most
Це,
often
правило, 9-10
we take
година
patients
вечора
on
евакуаційний
evacuation,
потяг.
usually
Пацієнт
9-10
поступає через
p.m.
невідкладні
So the
стани
patient is
пацієнтів його дій.
admitted,
Після цього
so
він
he is
потрапляє в
assessed,
відділення, будь-які
evaluated,
відділення
and
займаються
then
пацієнтами з
he
військовою травмою.
gets
Іде
to a
ситуативний запит на
department. Any
зумовлення
department deals
фармакологічних
with
терапій. Це
military
все
trauma,
відбувається вночі.
so
Якщо
pharmacological
фармакологічна
therapy and
терапія з
everything.
іншого
So
боку
if
не допомагає,
pharmacological
запит на
therapy
знеболення,
does not
далі відбувається
help,
інвазивне
then
лікування болю
there is
анестезіологічною службою.
invasive
І
pain
повторення
treatment
по
with
колу. Ніхто не
anesthesia
чекає, поки
service,
зранку прийде чергова
anesthesiology
зміна
service. So we
для
are
того, щоб
not
адекватно
waiting
знеболити
until the
пацієнта.
next shift
Найлегші
comes in the
пацієнти,
morning to
якими справляються
adequately
лікуючі лікарі, це
give
пацієнти, у
analgesia.
яких біль від 2 до 4 балів.
So if the
Ці
pain is
пацієнти,
2
як
to
правило,
4,
не
the
потребують
score is 2 to 4,
лікування болю.
so
Вони
this
всі
is mild. They usually do
зупиняються
not
на
require
фармакологічній терапії. Але,
invasive
як
pain
показує досвід,
management.
таких пацієнтів вкрай
Pharmacological
мало. Це
therapy is
загальна
okay,
схема,
but
яку
we don't have a
використовують.
lot of such patients.
Поступлення
This is the
пацієнту,
overall
визначення
scheme. So
рівня больового
admission,
синдрому, якщо рівень
level of
50 балів,
pain
на жаль, це так пацієнти з
syndrome.
важкими ампутаціями, де запит на
Usually
знеболення,
it's
план лікування.
severe
Це
amputation,
визначає лікуючий
analgesia,
лікар,
treatment
щеплює
plans. The
аптекар. Це
treatment
дуже
doctor
важливий
is
пункт, тому що
defining that,
наша
and
була
that's
мета
really
зробити
important because
стандартизований
our goal
протокол,
was
щоб
to
усі
develop
підрозділи
the
лікарні
standardized
були одні ті
protocol.
самі.
So in all
Це
divisions
дуже
of the
складно,
hospital, the
надзвичайно
same
складно, тому що
protocol was used. That's
завжди
extremely
вноситься
difficult
якийсь дисбаланс. Не
because
завжди
usually
кошти,
there is
щоб
some
закупити одне і те саме.
imbalance. There is
Якісь
not enough funds
певні
to procure the same
дефініції
things.
видаються по визначенню болю різними спеціалістами.
Some
Хтось хоче одне, хтось хоче інше.
differences with
Але
regards to
загалом для лікарні
pain
дуже важливо,
score
щоб у всіх
definitions
підрозділах були одні
from
і ті самі
different
препарати для
doctors.
лікування
But
больового
it's
синдрому. І це
important
було
that all the
стандартизовано.
departments have
Це
the
було
same
нашою метою створити нашому стаціонарі.
instruments to
Якщо
treat
фармакологічна
pain.
терапія не
So that was
допомагає,
our
знову
goal.
ж
If
таки,
it's
йде
pharmacological therapy
5-10
and
балів,
it does
виклик
not help,
анестезіолога,
and so it's 5
інвазивне
to 10
лікування болю, які
points
методики
of
ви
pain
бачите.
score, then the
Після цього
invasive
оцінка
pain
його йде.
management
І
is
якщо
instituted by the
неефективно, це
anesthesiology
повер
ward. If it's
знову
not
таки
efficient,
запускається.
so again we
Щоденно
go
пацієнти
around the same
обов'язково
circle, so to
обходяться
say.
черговим
On a
лікарем
daily
інтерном,
basis, there
який
is
підбирає собі
rounds
пацієнтів
done
з
by
найбільш
the
проблемним
treating
болем,
physician and
і ці
interns
пацієнти далі
with the most severe pain, and these
і весь
patients,
персонал
regardless of the
повідомляє,
time of the
що
day,
проблемний пацієнт, ви маєте про це
the
сказати
relevant
черговий
interventions
для
are
того, щоб пацієнта
undertaken
знеболити будь-які
in order to provide
оцінюється найбільш
pain
проблемними пацієнти
and the most
виносяться, і
problematic
по п'ятницях
patients
у нас відбувається
are discussed every
протибольовий
Friday.
для того, щоб
We
можливо
have
змінити
kind of
терапії у
pain
даного
rounds.
пацієнта.
Maybe
Що
not
ще
to
є
change
надзвичайно
therapy
важливо?
in
На
this or the
першому
other
фото ви
patient. What
бачите
else is
навчальний
really
персонал
important? Picture
інтегративного центру
1, you can
ортопедичної
see
травматології
the
по
training
основам
center.
мотобольової терапії пацієнтам з
So these are the
військовою
basics
політравмою.
of
А на
pain
другому
relief in
фото
patients
йде
in
навчання,
polytrauma.
де
And
лікар-анестезіолог
picture 2 is the
розповідає про
training by
механізм виникнення
anesthesiologist telling
фантомного болю
about
і
mechanism
чому
how
саме у
phantom
пацієнтів з
pain
ампутаціями і при
develops
яких
in
саме
patients
ампутаціях виникають там
after
від
amputations, and
хірургів залежить
after what
дуже
kind of
багато хірургів,
amputations
від
phantom
ортопедів,
pains usually
судинних як
develop.
виконуються
So
ампутації.
lots of
Це надзвичайно
surgeons
важливий пункт, незважаючи
are
на те, що
listening to
у нас
how the
виконуються
amputation
ампутації
is done
за
and what is done.
PI9,
So
за
that's
іншими
really
методологіями.
important. So
Ці
we do
пацієнти є
amputations
проблемними.
according to
На
BNI and
два
other
дні назад був
methodologies.
точно
These
такий самий
patients usually
пенсіонер,
are kind of
де
challenging.
ортопеди-травматологи
So
розповідали про
orthopedics,
пересадку ножової плати, де були
traumatologists,
зібрані всі
they
спеціалісти, які
also
потрібні для
might
створення
train
даної,
and teach
для
about flap
асоціаційної даної
repositioning, and
проблеми,
all
і
other
про яку всі
specialists are
мають знати.
getting together
Тобто
to
постійно
know
треба
about how that
обговорювати
is done.
з
So we
колегами
really
стосовно
have to
цієї проблеми
discuss
і
with
їх
all
наразі
the
вирішити.
team, with colleagues,
Далі,
all the
протибольові обходи по
challenging
п'ятницям. Це на
issues.
другому
So
фото, це
pain
не
rounds on
перебирається.
Fridays are
Змінюється
depicted here.
безпосередньо корекція відбувається терапії у
So
пацієнтів,
that's when
які
the therapy
знаходяться в
might be
стаціонарі,
changed,
і в
corrected in
зносяться зміни у
patients
формі,
of the
яку я
hospital,
презентував.
and all the changes are
Надзвичайно важливе
introduced into the
нововведення.
form that
Консиліум
I have
проблемних
shown.
осіб. Ми його створили
So
більше року
this is
назад.
problematic
Суть його полягала в тому,
extremity
щоб прийняти
meeting or
спільне
consilium we
рішення
call
у
it.
важких
So in order
пацієнтів
to make
із ампутаціями.
common combined
Чому? Тому
decision
що
in
досить
difficult
часто ми
patients
змушені
with
виконувати
amputations,
ампутації
because very
пацієнтів, які
often
переважно
we
в
need to
стаціонарі
do
знаходились на
amputations
госпіталізованому по півроку і немає ефекту терапії.
in
Це складне рішення.
specialized
До цього консиліуму
conditions,
залучаються обов'язково
and
фізичні
it's a
терапевти,
difficult decision.
залучаються реабілітологи,
Physiotherapists
залучаються неврологи,
and
залучаються
PM&R
нейрохірурги
doctors,
і обов'язково
rehabilitation specialists are involved for
це
sure.
надзвичайно важливо. Чому? Тому що це
That's
є спільне
really
рішення. Пояснити
important to
пацієнту,
discuss
чому
together,
після
because it
півроку
has to be a
терапії треба
joint
прийняти.
decision to
Це дуже
explain
складно.
to the
Що
patient
зараз
and explain to the
відбувається, що
patient that it
надзвичайно
needs to be
важливо, що ми
accepted, so
залучаємо
to
цей
say.
консиліум і
And
інші
we
складні
also
рішення, там де
involve
виконувати потрібні певні реконструктивні
such
оперативні
meetings,
втручання
do such
звичайно
meetings
всіх
for other
спеціалістів.
difficult
На жаль,
decisions,
як
for
адміністратор,
reconstructive
чому таке робить
decisions.
адміністрацію,
Being
що
administrator,
тепер
I can
один
tell
раз
you
на
that
тиждень
now,
ми
once
робимо
every
обов'язково
3
великий
weeks,
адміністративний обхід.
we
Для
do
чого це
our
потрібно
major
пацієнтам військової травми?
administrative round.
Тому
So
що
why
досить
do we
часто
need
ви
that
не можете
for
вирішити
patients with
певне
military
питання. І в
trauma?
цьому обході якраз
Because
знаходяться не тільки
this is the
спеціалісти всіх
round
профілів, які приймають участь у
that
лікуванні
involves not
військової
only
політравми,
healthcare
а ми
subspecialties
знаходимо
involved in
певні
polytrauma treatment,
адміністративні рішення,
but
пов'язані
certain
з
administrative
адміністративними
responsible
проблемами,
persons.
які не
So
можуть
where
на
we
якомусь
try to
етапі бути
resolve
вирішені.
administrative
Це
issues,
надзвичайно
lots
допомагає.
of them.
Перевід,
So it helps a lot.
інші лікувальні заклади, перевід за
For
кордоном,
example,
певні
if a
коли
patient needs to
пацієнт
go to be
може
referred to a
висказати
different healthcare
всім
facility or go
стосовно тої
abroad,
проблеми, яка в нього є,
and
яку він
everyone
може
during such a
вирішити,
round,
наприклад,
everyone
лікуючий лікар чи
can have a
завідуючий
voice
лікар.
and
Да, це
discuss this
робимо
or
не
that
часто,
issue.
один раз на тиждень.
It's not often, it's
Що
only
дуже
once every
важливо
3
в
weeks,
плані
but
трансформації
important.
служби.
What
Відділення
is
анестезіології
important in terms of
терапії
transformation
створена
of this service?
міні-інвазивна
Anesthesiology
операційна
ward
закладу, яка
has a
винесена за межі
mini,
блоків, де пацієнтам
mini-invasive
постійно виконуються
OR.
блоки, які потребують час
So the
техніки. На даний момент на правому фото ви
this or
бачите
that nerve
22:00,
block
а також ми
might be
почали
done
виконувати
if
такі
patient needs
процедури,
that,
як радіочастотна
and
абляція, радіочастотні модуляції,
RF ablation
готуємося
or
до стимуляції
RF
спинного
modulations
мозку,
procedure is
spinal
also
cord
done.
stimulation,
Stimulation, spinal cord stimulation,
тобто ті процедури, які є
ablations are
типовими для
also
класичної
done there. So
анестезіологічної терапії,
actually that are not quite typical for classical anesthesiology, and pain relief but we doing them more. So, and we are going to have the biggest experience. So, from 50 to 100,000 patients with amputations have gone through our department. So, since November, we will be implementing the first course on pain medicine for healthcare facilities training, for example, where the representatives of the healthcare facilities come to us to learn the concept that we have implemented. And the first is going to be Vinnytsia Oblast Clinical Hospital, named after Pirogov. And so we start. There are no people who can ideally tell us how to do that. So there's no other war since the Second World War that is similar to ours. So we have a unique experience with a lot of casualties, wounded people staying in the same place. So military polytrauma is very different from civic polytrauma. That's also a factor. But we are learning. We teach others, and other people train us. So all that something that we are already doing, dear colleagues, to treat pain syndromes in patients or plan to do. What's new over the last half a year is hydrodissection of nerves, many invasively. Nerves are dissected from the adjacent tissues. It's Botox injections, it's denervations with phenol or alcohol, neuromodulation, sympathetic block a lot, and the surgical treatment. About 70 procedures of surgical pain relief procedures have been done. I don't remember, maybe up to 100. So all that needs to be implemented, and it's only a teamwork that can provide that. That's a new scheme of pain treatment. Standard protocol is here, and this is what is being used now for invasive pain treatment. So neuroma, RF ablation, surgical treatment, toxin, botulinum toxin injection. Surgical treatment is the last resort, because you never know what would be the result, final result of surgical treatment. Spinal cord remyelination, nerval hydrodissection under sonography guidance also allows us to avoid problems, and the pulsed RF modulation if there is no other mechanical cause. So all that led to creating the second version of our pain treatment protocol. And dear colleagues, if you are interested in this information, please get to know it better. So the most important thing, the whole team needs to work together. That has to be interested in the final result, meaning adequate pain relief, so the patient would be leaving the department with no pain syndrome or minimal pain, because this is the key factor that might lead to disability and decrease in quality of life. That's all from me. Thank you for your attention, and I wish you fruitful and effective work. Thank you. Thank you, Mr. Andrei. Dear colleagues, maybe you have a question to Konstantin Humenyuk. There is one question. You're most welcome. Kherson Dundic. I don't remember whether it was 2015 that we discussed the Tourniquet syndrome during the surgical congress. And again, we see this Tourniquet syndrome. So 2/3 of amputees are done because of this Tourniquet syndrome. I think no less. So what are the actions that you do as a surgeon, general doctor of this military service? Thank you. you understood probably from my presentation that the problem the surgeons face, that casualties comes with a tourniquet leading to amputation. A question to me: how to improve evacuation of a wounded soldier from the battlefield to the surgeon? So we've talked about this golden hour for a long time. And it was observed, by the way, 14, 15 till the 23, because our teams were not gunshot on their way, because the enemy is killing the medics, paramedics who come to the wounded soldier. So usually they use the tourniquet that the soldier has put on himself or his brothers has put on him. So how the Surgeon General can impact that situation? There is no way. I will continue so far. Let me continue. As soon as we improve evacuation, how we do that? We already use state-of-the-art drones that are almost invisible, and also we use the ground transport to take the wounded out of there. And there is a order that each wounded soldier, they know about tourniquet conversion and they know about tamponade or packing. But as of today, we have war with small groups, 5, 10, 15 people in one group. There is a point of combat activities. Out of those 10, 15, only 5 and 6 are alive, and they need to put the tourniquet on their own. And when the other person, like who was a builder, for example, yesterday, and he sees a blood, they will not be able to do it correctly because it's stress, it's a combat time with lots of shooting, constant shooting. So all that leads to the fact what we have today. Have I answered? You have answered. So there was a training. So when we, well, maybe later on over coffee. Over coffee. Thank you. More questions? I'm a representative of armed forces, and I'm a subordinate to Konstantin. I wanted to add that under the management of Konstantin, the control of each surgical frontline group stabilization station is controlled and checked whether they have the tourniquet, whether this group has the tourniquet. And also practical recommendations are provided about the tactics under the guidance. So everything is implemented and it's working now. So considering the fact that each military person is talking to his leader of his structural division, I can tell you clearly the order that comes from Kiev is received by the frontline surgical group representatives. So thanks to our Surgeon General, that is done thanks to him, because his initiative and his support is an example for all of us in current conditions. He knows us all where there is a surgeon who is able to do this or that. And Konstantin has mentioned a lot of the nice things. So that's thanks to his work, hard work. So the answer to your question is the work that's done on a daily basis, but not seen by people. Thank you, dear colleagues. Thank you very much. Our time is over. We will meet 11:40. Thank you. A big request. The next 3 presentations are from our colleagues who are online. Please do not be late. Those are colleagues who are traumatology, orthopedics, and military people. So 11:40 sharp.
1 to 1.5% of people in industrial nations suffer from chronic wounds, such as pressure ulcers, vascular leg ulcers, and diabetic foot ulcers. Besides being a high burden on the patient, these wounds can also generate high costs for the healthcare system. But why are chronic wounds such a challenge? Wound infections are a major factor. It is estimated that more than 50% of all chronic wounds are infected. Wound infections are caused by microbials such as bacteria, which do not only like to multiply, they also produce biofilm. Biofilm forms when free-floating bacteria adhere to surfaces and grow a colony. This colony excretes a thick and slimy substance, an extracellular polymeric substance which consists of polysaccharides, protein, and other elements. Biofilm can also release bacteria which form new colonies in nearby areas. The biofilm acts like a shield for the bacteria and protects it from many antimicrobials, including antibiotics, and from the host's immune system as well. So there can be a constant threat of a chronic wound infection. To prevent the development of wound infections and to promote wound healing, it is important to remove the biofilm and achieve an effective wound bed preparation. The Prontosan range provides a smart solution to effectively cleanse the wound of biofilm, slough, and debris. Moreover, the special combination of ingredients reduces the biofilm and also impedes its reformation. The two main ingredients in Prontosan solution are polyhexanide and undecyleinamidopropylbetaine. To keep it simple, we call it betaine. Betaine is a surfactant. Let's have a look at how a surfactant works. A surfactant molecule basically consists of a hydrophilic, water-attracting head and a water-repelling, hydrophobic tail. Since the tail doesn't like water, it searches for another place to go, which here is our biofilm. The polar heads of these surfactant molecules have the same electric load, and therefore they repel each other. This is how the biofilm breaks up. Several of these surfactant molecules bind to the biofilm and build micelles, which can then be removed from the wound bed much more easily. In this way, betaine has in essence opened the door for the supportive effect of polyhexanide in Prontosan, which can now act against the bacteria. Polyhexanide, or PHMB, is used as an antimicrobial substance. It is able to attack and destroy various types of microorganisms. Gram-positive and gram-negative bacteria are protected by a cell wall, whereas human cells are surrounded by a cell membrane. These bacteria can cause serious diseases and are resistant to antibiotics and antiseptics. A bacterial cell wall has a negative charge, while the PHMB molecule has several positive charges, which makes PHMB act like a magnet, attaching itself to different areas of the cell, starting with the negatively charged outer cell wall. PHMB binds itself to the cell wall through electrostatic interaction. The cell wall breaks open and begins to leak where the PHMB molecules attack. This results in the cytoplasm exiting the cell, which quickly causes the bacteria to die. PHMB attacks, breaks down, and destroys bacteria. Due to its positive charge, it also supports the barrier effect on the wound, as it helps prevent bacterial cells from adhering to the wound surface. No bacteria, no pathogenic biofilm. In summary, betaine breaks up biofilm and opens the door for polyhexanide to act against bacteria and to interfere with the reformation of biofilm. That's why Prontosan is a smart solution, not only for an effective wound bed preparation, but also to help prevent wound infections.
Dear colleagues, let us take places, because we are going to start the second part of our meeting, of our congress, of our trauma congress.
Good afternoon, ladies and gentlemen. We continue our event, and the next speaker will be just a moment. Importance of ATLS and ETC in the workflow of the emergency department. It will be Professor Florian Pavlu
Невідкладної допомоги. Це буде професор.
from Germany.
Good morning, colleagues. Do you hear me well? Can you
All
hear
good.
me?
We do hear you. All good there. We do hear you.
Dear colleagues, could you give me any sign that you can hear me well or not?
We do hear you. We do hear you.
Okay, somebody told me that you can hear me well. So, colleagues, good morning from Germany. It's a real honor for me to talk at your Congress today. And I really think you can hear me well because I don't have any signals that you can do, but I hope everything is well. So time is short, so I will start directly. What I'm going to do now is for the next about 20 minutes talking about ATLS and ETC in the trauma department or in the emergency department, and what we do with ATLS and ETC in Germany. So basically, ATLS started back in the 70s and came to Germany in the year 2003. And today we have about 30,000 ATLS providers trained by 300 ATLS instructors in Germany, and ATLS is more or less spread it all over Germany. And for sure, ATLS is always more or less a matter of trauma care. When we are going into the kind of training which is done by the ATLS, it's always the baseline scenario which is trained that you have the situation of limited resources with only one doctor or one nurse. And they are organized in a vertical management. That means a doctor more or less is the one who is in charge. And normally it's a small rural hospital with only X-rays and no CT scans. And what is focus of the training? It is providing optimal care in this kind of situation with limited resources. And there are some basic ATLS principles that are trained. And first of all, and that is what the whole training is all about, is the rapid and accurate assessment of a severe injured patient based on the X, A, B, C, D, E scheme, and the assessment due to this system, which means exsanguination, airway breathing, circulation, disability, and environment. The second point is, and this is what ATLS is basically all about, is treat first what kills first. That means focus is to resuscitate and to stabilize the patient as soon as you can, and to control problems which are recognized by you directly without going further in the assessment. That means if you identify an A or B problem, you have to solve it directly, not just to overgo it and to go to C or D. This is what ATLS is basically about. The third point is during the patient care, it has to be sure that there's no decrease in the level of medical care that the patient is getting. So that means reassessment of the patient's condition is mandatory at all time. The one more point is that you have within the care of the patients, you have to think about a patient's transfer to another hospital, especially in the situation that you don't have all the facilities that are necessary to handle the patient, for example, severe injuries to the vessels or to the brain if you don't have neurosurgery at all. It's always focused on clinical decision making. This is what makes it that suitable, especially for situations with limited resources. And it's a straight focus on clinical problems and the solution of this. The trainings are basically structured in skill trainings where all the trainees get the practical skills to handle the scenarios which are trained later in the course. It's like they learn basic and advanced airway skills, spine protection, thoracostomy skills, and all the things you need practical to handle a severe injured patient. Then the course is, there is a part of so-called interactive discussion. That means that the trainees are getting some kind of clinical scenario which has to be discussed by them. And then there is the scenario training where in the end the trainees get moulaged people and patients which they have to take care about. When we are going to ETC, there is a big difference between the ATLS and the ETC principle. So ETC is all about team approach. I told you that ATLS is more or less about situation with limited resources in a small hospital, but ETC is definitely focused on how a team works and in situation where the team has to take care about a critical patient. So the focus in the ETC course is more or less not the basic training of several skills. It's more like the team access and leadership and decision making in these situations. So there are basically skill trainings as well, so airway management and all these things. But the bigger focus in the ETC training is on a leadership, on task allocation and allocation of responsibilities, closed loop team communication, clinical problem prioritization, and in the end, decision making to make sure that the patient receives the best care you can provide. And that is what in the end, where ATLS and ETC comes together, it's always, on the one hand, it's the transfer of practical skills, which the trainees have to provide to the severe or to the critical patient. But on the other hand, there are a lot of skills like soft skills, communication skills, decision-making skills, allocation skills, and communication skills that make this kind of approach to take care of a critical patient makes these systems a lot of stress resistant, and this decreases human failure and in the end increases the level of care which is delivered to the critical patient. So when we are going really back, so in the end, there's the question, why are we doing that? So there's a lot of, this study is pretty old, but it's one of the baseline studies about the ATLS implementation, and they saw, okay, ATLS and the structured approach to a critical patient definitely reduces overall mortality. In this special case, it was 24 hours mortality, but there are a lot of other studies that have shown that this structured approach to critical patients definitely reduces overall mortality. So in Germany, we have a level 3 guideline for treatment of severe or multiple injured patients. And there is a recommendation, the grade of recommendation is A+, so this is the highest evidence recommendation. And the recommendation is for the management of polytrauma, dedicated teams, so-called trauma teams, should work according to pre-structured protocols, and they should have completed a specialized training. That means, so it's not, we don't say you have to do ATLS or you have to do ETC. It doesn't matter in the end, but you have to had specialized training, and the trauma team should follow pre-structured protocols to assess the critical patient. When we are going to combat trauma care, so ATLS is basically the biggest point in the German combat trauma care system at all. When we look to pre-hospital care, it's a mixed up of PHTLS, which is more or less pretty common to ATLS, and the tactical combat casualty care, which came from US. And when we going from the pre-hospital setting to the inner hospital setting, or to a damage control surgery unit somewhere directly behind fire line, then we go for the critical or the injured patients from the battlefield. We go for them via the ATLS approach, combined with ATCN, which is basically ATLS for nurses. And then we follow basics of damage control resuscitation, damage control surgery, triage, and in the end, tactical abbreviated surgical care. So this is what we do with the combat care in Germany. So in the end, this is what I want to say in the end of my talk. It's not the matter of if you have to do a course or not. It's more or less basically about going to a critical patient in a structured way. And there are right courses, but you have to choose the right course for the right trainee. It depends on what you want to achieve by going for these courses. And it's not like that they are competitive, the ETC system and the ATLS system is more. And so, in my opinion, it's more like ATLS and ATCN is more some kind of basic training. And if you want to go ahead, like training of team structures, leadership training, and all this, it could be that ETC is the better course to go for. So my bullet points in the end: ATLS and ETC definitely reduce mortality and improve patient outcomes. Not only for trauma, but for all critical patients in the trauma room and in the emergency department. ATLS has the big advantage that is suitable for environments with limited resources and lack of personnel and material. And ETC is more focused on the team approach. And in the end, it's a matter of putting the right trainee to the right training to achieve what you want. So, and this is in the lack of time, the end of my talk, and I'm open for questions. Thank you very much.
Do we have any questions? Could you clarify whether I may ask a question in English in order for me to be heard there? Okay, in Ukrainian. So, greetings. My name is Katerina. And right now in Ukraine, we have actively implemented courses which are certified, also ATLS, ETC, and PHTLS as well. And I do understand this course content, and I'm interested more in terms of the implementation of ATLS courses within the educational system. Maybe what was your process of implementation of TLS training, or maybe you know about milestones or underwater traps, how to implement the training, or maybe what are the demands regarding the training, or maybe there are any kind of recommended courses which are standardized in terms of preparation of a specialist regarding the trauma management. Thanks so much.
I definitely can hear you, but somebody has to be so kind to translate it for me. Yeah.
Can I check if you hear me? Yeah, okay. We're actively working about implementation of international courses into Ukraine. And what is my question? It's a bit wide and have a big scope, but the question is, do you have any insights or pitfalls about the implementation of such courses into the requirements for education for a specialist in the area of trauma management? Meaning in the system of education, in the system of requirements for the specialist working in the area of trauma management, to make sure that the education system is unified and approaches are unified in the country. Thank you.
I think basically the trainings should be done by specialized and certified ATLS instructors, and it could be that you have to send some guys from you to international courses just to get the certifications. And basically, so the ATLS approach is this kind that you don't have to be really deeply specialized into trauma surgery just to go for these courses, because especially, so for example, in the German military, we also send, like, it's not only trauma surgeons that are going for the ATLS and for the combat care preparation. There are general surgeons, nose and ear surgeons, and all these guys, they are going for that as well, and they are not exposed to trauma surgery every single day. So the course is focused on getting the baseline practical skills to handle critical patients, and it doesn't depend on what your original specialization is at all. Does that answer your question?
Thank you very much, Florian. I just wanted to comment that in Ukraine, for now, we have more than 11 full instructors of ETC, and we have 40 instructor candidates for ETC.
Yeah, perfect.
And we also have more than 30 full instructors of ATLS. So this is present in Ukraine, but the question was more about the implementation that into education system. But this question can be readdressed in some discussions between the team, between the auditory. Thank you anyway for your time, and the lecture was really interesting. Thank you.
Thank you.
Чи є ще запитання?
Okay, so in this case scenario, the next talk is going to be Professor Roman Fiver from Zurich, Switzerland.
The opportunity to be in this conference. I would like to discuss with you an early major fracture case polytrauma, priorities and timing. Try to give you a little bit, like, let's say, it's not everything evidence-based, but at least some recommendation or some hints how you can probably approach your patients for fracture fixation. I have no conflict of interest. If you look to the history, in the last 2 to 3 decades, you will find that we had different treatment strategies in polytrauma. So initially in 1890s, the early total care was mainly used here. You see, for example, in the femoral fractures, majority of cases, up to 60% nailing was used, and then also plating 23%. But over the time, the damage control strategy took over, which was the reason was here mainly the complications due to severe inflammation and multiple organ failure in the clinical course. If you look now to the data, these are the data from German trauma registry. You see that up to 50% of our patients get an external fixation of the femur. But probably you agree, not all of them, not all of these patients need an external fixation. If you look to the data closely, you will find that probably up to 15-20% have hemodynamic problems or physiological problems. So it seems to be that we overdo the damage control strategy, or we use another reasons to do an external fixation. And there are other publications actually indicate and stimulate to do early fixation in large fractures of major fractures of pelvis, spine, and long bones. In this ongoing discussion about early total care damage control is still has no end, and we feel especially in the polytrauma, which are very dynamic clinical course. So this, depending on patient's physiology, injury patterns, and so on, this patient can go in many directions, and also our treatment should be very dynamic. We should rather change our strategy to a new concept or to a different concept than early total care damage control. So we call it safe definitive surgery, but you can call it differently. The question is how you can approach the patient, and the first step, what we feel of importance in the patient's physiology. So on the right side, you see, for example, a different grading system. So we have found in literature. So how you probably know early appropriate care strategy and another strategies. And you see the list of different parameters: lactate, ATLS score, urinary output, and you have platelets, and so on, fibrinogen, DDMRs. All these factors probably not so easy to have directly in the trauma bay, and this is very often so confusing to have all these parameters. That's why we try to sum up a little bit these groups. Actually, mainly everything focuses on bleeding. Everything focuses here on the coagulation system. The temperature plays an important role, and of course, so we call it tissue injury. It means, let's say injury pattern or associated injury plays also a very important role in the decision making. And very important, especially if you feel it in our group, that not only focus on one system, not only one base system, but only look at all parameters like coagulation, bleeding, and also unassociated injuries. Then you have a good prediction for early complication if you check all these parameters. As an example, I would tell you just a few numbers from our department. And you see, so in this study, we included only polytraumatized patients with normal acid-base system, with normal values here of 2 millimeters, 2 millimole per liter, excuse me. And all patients were here hemodynamically stable. And we looked, for example, on the presence of other existing system problems. For example, even if you have normal hemodynamics, you can have in 25%, at least in our patients, we have a patient with the coagulation problems. And we have patients with, especially in the winter, patient with hypothermia, 7%. And we have, especially in our department, many patients with traumatic brain injury, so it's called here soft tissue damage. Even if you have a good lactate levels and normal, these patients, you would probably rather not do an early total care procedure. That's why you need to look at all different parameters, not only an acid-based system. So in order to identify which parameter might be relevant in your decision making, we try to go initially at the parameters we have in our department in the emergency room. For example, look here, do we have ROTEM, or what we can measure temperature, we can have blood gases, and so on. We asked trauma surgeon from Europe, from the Estes Society, and about their strategies, and published it here in our journal. And we looked into the European guidelines, especially they were mainly written by anesthesiologists, and very important for us to discuss here also the strategies with anesthesiological colleagues, because they look at the different parameters, and we need to communicate with them and to understand their decision making as well. And to bring the concept together of this, let's say, triad of death and soft tissue damage. If you look into the literature, systematic review was done, focus all different parameters here. We try to identify, let's say, the threshold for a stable situation, which is not so easy and threshold for unstable, and in between was mainly defined as a borderline condition. And probably if you follow the literature, you will see that the thresholds are not really clear, and sometimes they move one direction to another. And this is what we actually try to describe it here. For example, which kind of parameters may help you in your decision making. It's only like a help, a hint, and an aid for you in your daily practice. So, for example, for a hemorrhage assessment of the hemorrhage, of course, the blood pressure. So you usually do it on a daily basis. Lactate is widely accepted, and hemoglobin, especially for anesthesiologists, they guide the transfusion protocols here, at least in our department, and they really focus on these values, and they also give you some idea about here the bleeding of the patient. Coagulation, so mainly you can focus on INR. 50% of European hospitals do not use ROTEM on other similar devices. So 50% use just rapid INR on INR for a coagulation assessment. But another 50% use like techniques like ROTEM and TEC is mainly used in the United States. But I don't go to each of these details, but if you use a system, probably these thresholds may help you. And the temperature is of importance as well. 35 degrees was many publications described here as a threshold. And we have values below 33 degrees. In these situations, patient can develop severe complications. And so having these physiological parameters, you can see if everything is normal, this patient is stable. You may probably proceed to a stabilization, of definitive stabilization of the patient. If the patient is an extremis, it means the patient is in a way to die. So you need to do, to find the bleeding source mainly and do, of course, resuscitation. Here, surgical and anesthesiological resuscitation. And if you have situation in borderline condition, you need to reassess the patient repeatedly. Similarly, in unstable situation, and then according to patient's physiology, you can then find your strategy day by day, whether you stabilize the patient or you do damage control orthopedics, or and find like let's say, secondary time point of reconstruction. So we look to our patients which came here to us through Trauma Bay, 1,471 trauma patients, and just actually look what kind of strategy did we use. So early total care, safe definitive surgery, or damage control. And what we found mainly is here. So if in our group, so if you have patient with severe brain injury, in this situation, we mainly did damage control in the patients. We have found a patient with unstable spine, and he also included abdomen. In this situation, very often we had in its combination with the abdominal trauma also pelvic injuries. We try to fix also in this situation pelvic surgeries very fast in order to avoid late complication and associated with laparotomies. That's why this group is here included in early total care. And if you have mainly a patient with a musculoskeletal injuries, then we very often proceed to safe definitive surgery. It means that we try to fix it and the fracture day by day, or focusing the physiology of the patient. So what to do if a patient has a physiological stable situation and values are normal, but we have concomitant injuries. So then to clear this, we developed here such an international expert panel, including of 17 experienced trauma surgeons from all over the world, Europe, United States, India, China, Australia, and we developed something like a Delphi consensus process, try to discuss this, because of evidence, to get an evidence in polytrauma, it's very, very difficult. And I think we need to, using this Delphi consensus process, let's say, process, we could even increase a little bit the evidence in this field. And also, in addition, perform a systematic literature review in order to also to increase the evidence level in this field. And we recently, I think, so around about 6 weeks ago or 2 months ago, we have published it. And so, if you would like to read it, you can download it. And I will just go very slowly, step by step, and give you some recommendations that we found here together in our group. So what we would like to focus here, so if you have a patient with, let's say, a fracture, whatever it is, it can be a pelvic fracture, femoral fracture, and you have a patient with additional brain injury, thorax trauma, spinal injury, you have vascular injury or abdominal trauma, or associated musculoskeletal injuries, how you can proceed and how you can find your decision here. And so we also went to the literature. You see here all included studies. And in the end, you will see this Delphi process. We had two online meetings in the end. We met in Zurich in September last year to find they developed 20 consensus statements. And this is a list of all participants from all over the world. They were not only orthopedic trauma surgeons, but also general traumatologists, neurosurgeons, and so on from all over the world, representatives discussing with us this relevant point. This you will see all members here in the final picture. In the end, we had such tables where we included all relevant literature, the recommendation of the literature. For example, early fixation is green, late fixation is red, neutral is yellow. And here on the right side, you will find here, for example, a recommendation for traumatic brain injury, the agreement of the group, and evidence level, what we have found. And I will just give you like an example. It would be boring if just read for you the recommendation, but just give you very easy short abbreviation of these recommendations. For example, if you have a fracture and you have a patient with traumatic brain injury, and this is a mild traumatic brain injury, and they have no evidence of bleeding in the brain, and your physiology is okay, then I think you can fix the fracture. If you have a traumatic brain injury and this patient has a deterioration of neurology, it means the Glasgow Coma scale is below 13, or you have some progression of the bleeding, then think about damage control. I think it's logical. So what to do if you have a patient with traumatic brain injury, with bleeding and probably also swelling in the brain, and when you can start with your reconstruction? And that was also a big discussion in our group. And actually, we defined that if you have a patient with traumatic brain injury but stable neurological conditions, there are no changes in the Glasgow Coma scale, and there are no deterioration of neurology over a few days, and there's no progression of CCT. And of course, we have normal perfusion and no increased brain edema or no increased intracranial pressure. Then you already can start here with a secondary reconstruction. So you don't need to wait 2 weeks until the patient has recovered completely from these neurological problems, or 3 weeks, whatever. But you observe if your neurology has no changes, no increase of bleeding, no change of Glasgow Coma scale, and you have no circulation problems and swelling problem. In this situation, you can start your secondary reconstructions. What to do with thoracic trauma? So there's always a big discussion what to do, nailing or not nailing, and so on. So if you have a chest injury and your oxygenation and ventilation is fine, then you could fix your fracture. If you have a bilateral severe chest injury, see, in this situation, you may think about damage control, especially, so we have discussed it also in the paper, especially if you have it in geriatric patient, elderly patient, and the compensation mechanisms are really, really low. In this situation, you may think about damage control principles. If you have changes in oxygenation or you have unstable lung function or so on, then you might, in this situation, you should do damage control stabilization. What about abdominal trauma? If you have abdominal trauma and there's no surgery needed and the physiology is fine, you can start with the fracture stabilization. What about abdominal trauma with surgery but no damage control procedure? Sometimes you have minor lacerations where you can just suture or just observe the screw bleeding, and the physiology is still fine. Fracture fixation is possible. Of course, you need to observe the dynamics of this patient, and this patient is still stable. If you have an abdominal trauma with severe injuries in abdomen vessels, or this is a damage control procedure in abdomen, of course, then you have a damage control indication in abdomen, then you need to extend this damage control indication also into the extremities. Spinal fractures and spinal cord injuries. So if you have spinal cord injuries and partial neurological deficits or the deterioration of the neurology of severe spinal instability, then it's also a recommendation for early fixation. But of course, you need to exclude here, of course, also life-threatening conditions in the abdomen, in thorax, in the brain, and also check the physiology of the patient. Another very interesting topic is our vascular injuries. If you have a patient with extremity arterial injury and brief ischemia, the brief ischemia, it's not really defined in time. It can be like 1 or 2 hours. And you can make rapid fracture fixation, then you should proceed, but please think about fasciotomy after that. But if you have a long period of ischemia, let's say 4, 5, 6 hours, or probably even longer, probably in such situations you need to restore the arterial floor. It can be done with shunting or even other techniques, vascular surgeons. But this situation, probably the arterial reconstruction probably has a priority to the fracture fixation. If you can do a fast fixation in parallel, it could be probably a good choice. But if not, arterial reconstruction of arterial flow has a higher priority here. What to do with the multiple fractures? Again, it's a big, complex topic. Actually, what we need to do is go step by step. We need to reduce the loss of lives, especially the pelvic injuries. So here is very important that we exclude the bleeding and stop the bleeding in the pelvic injuries, if you speak about musculoskeletal injuries only. And the next step is that we need to avoid catastrophic disabilities. Mainly, is a focus on neurotrauma and unstable spine. We need to exclude in the third step the limb loss, compartments, thrombovascular injuries, open fractures, and of course we need to prevent the loss of function, especially peripheral neurological injuries. So this is a little bit how you can stratify it, but it is like I said before. Probably there will be further studies improve the strategies and probably give you more clear recommendations. So what we can do as a trauma surgeons. So not only the physiology and the injury pattern play a role, but also our decision making, what kind of surgery we do. So nowadays we have good techniques, percutaneous techniques, minimal invasive techniques to fix and temporarily stabilize the pelvis or the spine. And so we ask orthopedic trauma surgeons from the CCOT Society and ask him more and reach him more than 196 participants also from all over the world. And you see here that the majority were from Asia, 55%, Europe, 20%, African countries in North America, and ask them how you apply surgical load. So if we operate very aggressively, so the patient will also have changes in the physiology, and it will also limit your reconstruction, let's say, possibilities and strategies. Mainly what orthopedic trauma surgeons look at is the blood loss and the tissue damage. So this was like of main importance. Of course, there's a bone damage, surgery duration, infection rates play an important role as well. But this is something that was one of the first priorities, blood loss and tissue damage. So if you sequence your surgeries, mainly of our the trauma surgeons mainly focus on anatomical regions, spine and pelvis were first, and then long bone fracture second. And of course, I looked at the bleeding risk, and so that avoid severe bleeding. And if you look to the surgical load and procedures, so of course, if you have open reduction of the humerus and elbow, it's more invasive. If you do it in femur and tibia open, it's more invasive than nailing. It's logical. Similarly, if you do open intervention in pelvis and spine, it's more invasive and more aggressive if you do percutaneous techniques. So in polytrauma, we can also, let's say, play with our techniques to reduce the surgical load, the bleeding load, the soft tissue damage, here with different techniques. And so also here preserve the patient's physiology from complications. So in conclusion, physiology is very important. And then the recommendation from the impact group may help you in your decision-making if you have associated injuries. Fracture fixation in general is recommended and within the initial 24, let's say 48 hours here. But of course, you need to exclude bleeding sources and unstable situation. And of course, our surgical interventions are really relevant, what we do to patient. And this we should also use carefully and decide carefully what we do with this polytraumatized patient. Thank you very much for your attention.
Dear colleagues, do you have any questions? You're most welcome. Professor Kalashnikov. On the average, for how long does the patient with polytrauma stay in the acute trauma department without switching him or referring him to rehabilitation? On average,
if I understood right, so the question is how long as a patient in general in our department after severe trauma. So so in our strategy, so it is probably depending on the system where you live and work. So we have actually good system in our trauma base. So every polytraumatized patient that come to us, we have directly an anesthesiologist, and usually we can very early plan and do early fixation different fractures. Mainly we fix pelvic injuries very early, directly after the trauma patient, of course, is hemodynamically stable. The patient go to ICU and we decide day by day if we fix other fractures. I mean, I don't know exactly statistics in our department, but our intensive care colleagues are very active, and they even force us to do surgeries day by day. And even if we have no slots, they organize slots for us to do, let's fix spine and pelvis, so to mobilize the patient and bring them back to the wards, because we have a problem with ICU beds, and they're so rare, and they want to have early fixation, and we need always to accommodate, even do some spinal surgery in the weekend to have these patients back in the ward. So I know I don't want to have exact statistics for you, unfortunately. Probably next time I should prepare something, but actually we try to do it. We are really fast, and intensivists and anesthesiologists even help us to do early reconstructions if possible, of course, according to the criteria we showed before.
Are there any more questions? My question is, in your university Zurich clinic, if there is a polytrauma patient in significant soft tissue damage injury, so who is dealing with covering the soft tissue defects? Is it orthopedic surgeons or the people who work in your department, or is it done by a plastic reconstructive microsurgery specialist? Thank you. How is it organized in Switzerland? So is it that every big hospital in each canton has specialists who know how to cover the defects with flaps?
So so in Switzerland, probably there's still special, let's say, at least in our canton and in some neighboring cantons, a special situation that we have general traumatologists on call together with which actually do also laparotomies and do also fixation of his extremities, which is a little bit unique in Europe at the moment. So nowadays you're more trained orthopedic or orthopedic traumatologists. So I'm actually trained in Germany and more orthopedic trauma surgeon, But to start my work here, I had to do also like a rotation into abdominal surgery. But actually the initial stabilization is mainly done by our department. But if it's required during the clinical course, we ask a plastic surgeon extremities to help us with the reconstruction. It's to be honest, not so perfectly organized like some hospitals have to get like this is in the strategy of orthoplastic, orthoplastics, where you work very close together with plastic surgeons and with open fractures, you do early reconstructions. This is still not possible in our department. Usually we start with initial debridements and stabilization, and later plastic surgeons together with us do a reconstruction of the extremities and soft tissues coverage. But it is how it's organized at the moment in our clinic.
The audience, are there any kind of other questions? I do have a question. Good afternoon, Roman. We met physically during the last Congress, in case you remember. Thanks so much for joining. When it is the stage to surgically closure the wound among patients with severe polytrauma? When do you close the wound, the injury? Because we have talked about the fracture fixation, but we are asking about the plastic closure.
So probably in comparison, so I had experience so previously in Germany and also here in a few hospitals, I had to go for rotations. Probably we are a little bit slower than it must be. So usually if a patient come to us, usually use a vacuum therapy to close the wounds. And we try in such wounds, usually we do it wound clinic a couple times. It needs at least 1 week. And then in the second week, we try to close the wounds with the plastic surgeons. But the reason for it, this period of time, mainly is organizational. So if we would have the possibility to work with, let's say, specialists could do it earlier, we would probably also cover it earlier. But it is like an organizational problem together to find a specialist plastic surgeons to do it with us. Like it takes always almost 1 week or even a little bit longer. Thank you for having me.
Thank you.
See you next time.
Are there any kind of other questions? Just quickly let us check. Thanks so much. Thanks so much for represented talks. I have a question. I have a question regarding more of a combat wounds of extremities. What is your surgical approach in case of the treatment of the fractures of the femur bone when there is an possibility of infectious consequences, when there is an infectious wound? How you are going to treat this kind of fracture according to your approach?
Sorry, I didn't understand.
It is a femur
Ukrainian,
fracture,
but not all,
infectious.
Everything. If you probably can translate it to me, excuse me for that.
Do you hear me
It
right
was a little
now?
bit difficult for me to understand even
Could
the
you hear me?
medical language. What should I press? Sorry. Yes, I have it now.
So the question is about the femur fracture. Could you hear me right now? Yes, you do? Okay, perfect. So you have a femur fracture and there is a real threat of infectious complications. What kind of osteosynthesis you are going to use, internal or external? In case you use internal, what kind of internal fixation you use?
Okay, thank you. Now I understood. Okay. So I need to go a little bit one step back, only for a few seconds. I don't want to discuss a lot. The very important is very often we have patients that come to us and have, let's say, open injuries, open fractures. And in this situation, we need to do an external fixation. And we, I mean, of course, to prevent infection. In this situation, we don't not want to call it damage control surgery. So to differentiate the indication of, like, let's say, vital problems and to differentiate the local problem. And That's why, especially this local situation, we defined in Estes, in our Estes group, to call it musculoskeletal temporary fixation. So to differentiate those two different indications, polytrauma, unstable situation, and local factors like infection or articular fractures, which are really complex to reconstruct. So usually, if we have an open fracture, and as if it's grade 1 or grade 2 or even sometimes grade 3A according to Gustillo. We clean the wounds, we close it, and even if the patient is stable, we can even do a fixation with a nail, for example, with the antibiotic treatment in this situation. But in most, if you have a complex soft tissue situation or even severely contaminated wound, it's not possible. Then do just external fixation, do cleaning. And then if you have a clean situation, you can probably start according to the fracture. So we decide mainly according to the fracture if we do a nail or plating. Hope this is okay for you.
Patient who comes in extremis, can you tell us what your strategy is for dealing with your soft tissue loss and your initial coverage of those losses? What techniques do you use? How much do you use? Wash out the wound, and what other adjuvants do you use?
So the patient comes to you and they have severe, let's say, soft tissue damage on extremity, or even it might be sometimes an indication for amputation if you have an unstable patient. Yeah. So if you have a patient which have real bad hemodynamics or even problems with the coagulation, and you start to do a reconstruction and cleaning of the wound, you may develop a big problem here. And then in this situation, you may think about amputation, yeah, of the extremity. If you have a stable patient and you have severe conditions, so usually we tend, at least, there's also a lot of discussion, but at least in order we try to restore, as if it's possible, using external fixation. And if we have even bony defects, we try to restore the length and also do a debridement of the soft tissues and cover it with a back therapies, vacuum therapy, mainly. And so we clean a lot with the fluids, normal saline fluids. We do not use local antibiotics or special solutions, only normal saline fluids. We feel that the debridement plays an important role. If you have a dead tissue, you need to remove the dead tissue. If you have bone fragments which disrupted and somewhere connected to the surface around, you need to remove it and clean the wounds and use the external fixation and restore the, let's say, anatomy as if it's possible. If it's so damaged, then probably amputation might be also a better choice. But we are not military surgeons. That's why actually in majority of cases we try to do a reconstruction, and then we speak with the patient and with the family and try to advise them. If it's too, sometimes it's a very, very long way. All the salvage procedures, all the strategies, it might be too much for the patient. That's why usually we try to restore it and restore the anatomy if possible, and then day by day we discuss with the family of the patient and try to advise them. Sometimes even doing like next step directly an amputation if patient agrees. But initially, it depends on the physiology. If polytrauma amputation, if a physiologically problematic, then amputation. If not, usually we try to restore it.
There is another question. Thanks so much for this amazing talk. The question is more from the practical point of view. So what type of fixation, temporary fixation, do you use for a short period of time, for like 24 hours, for example, when a primary patient was hospitalized and you do not have an opportunity right now during the admission to fix a huge tubular bone? I'm going to clarify. Do you use skeletal muscle fixation in case it is polytrauma? We are not talking about severe polytrauma. It is rather stable patient.
So if you have, I mean, all points, everything what I have showed you, of course, it's like it demonstrates you something like a perfect situation. If you have an experienced surgeon and you have all implants. So we're doing all these polytrauma courses all over the world in our group, and we see some, you know, the logistics and the trauma system is organized completely different, region by region, country by country. And that's why, of course, I understand that sometimes the implants are not always present in a trauma bay or even an emergency situation. And so you need then in this situation, usually you do an external fixation. Some situation, even a traction is described, but nowadays it's not according to what we discuss here in our department, and I also learned from all these polytrauma courses, traction or extension therapy is nowadays not a standard anymore. But external fixation should be done before you have your implants and do a reconstruction. Yeah, this is what you actually need to do. But and then depending on your organization and your system, you do your definitive stabilization when depending on the implant you usually use. But we use standard external fixation, so there's nothing special in it. If it's, I hope I understood your question right.
Thanks so much. So the next talk is going to be delivered by Professor Ingo Marzi, professor from Frankfurt, Germany, from the Department of University Clinic of Reconstructive Surgery, and this topic is going to be regarding the relevance of pelvic injuries in polytraumatized patients.
Yeah. Dear Chairman, ladies and gentlemen, dear colleagues, so I will present you the combination of pelvic trauma and polytraumatized patients. Actually, there are about 20 to 30 injuries, about 100,000 inhabitants, and there are two age peaks, younger patients and the very old patients that are to be considered very differently, and half of them are stable pelvic ring fractures where you do not make a special treatment actually, but they are about 1/4 of severely injured with a high lethality as well. And the pelvic ring, we have the AO classification, the stable fractures, the vertical and horizontal unstable fractures, and the complete unstable fractures. And the major problem of the severe pelvic injuries are the bleeding problems, and the second one is the reconstruction. But from the emergency point and the primary treatment, the circulation and blood loss is the main problem, and about 1/5 is due to arterial bleeding, and about 80% mostly from venous plexus, from the presacral region, or from the bone or some other vessels. And also the instability is a reason for bleeding, because vessels are ruptures and you have a lot of bleeding, and the major cause for initial death is actually hemorrhage. So what are the standards of treatment? And the primary preclinical situation is if you have an unstable pelvic ring injury, you need to stabilize the pelvis. And the reason is if the pelvis goes wider and wider, the more blood can be within the pelvic cavity, and the bleeding will not be compressed or stopped. And so the pelvic binder from many different companies, or just a towel or something, can be used to avoid the distension of the pelvis to the side. And Also, the binder has to be applied very properly. So if it's too high, it has no effect, as you see here, and it should be around the trochanteric region to compress the pelvis. On the other hand, you should not over-compress actually the pelvis. Of course, first you have the clinical examination. You see some bleeding, for example, from the urethra, some other injuries outside, and you can try to test the stability of the pelvis by compression and tension of the pelvic ring with your hands, and only in really unstable situations you feel that this is not stable, and usually you cannot compress the pelvis. So you have some idea that you have a pelvic injury besides the injury itself, and of course you can use a FAST or pre-hospital FAST to see if you have blood within the pelvis actually, and in the hospital the primary tool after the ATLS criteria to stabilize the patient, of course, is a CT scan. And the CT scan should be done with contrast media. So if I have a polytrauma patient, we do first the CT scan of the head without contrast media to evaluate the brain injuries, and then the CT scan with the contrast media. And as you see here, then you see in a certain percentage, maybe 1/5, you see arterial bleeding around the fracture. So the contrast media shows you have an initial ongoing bleeding. And there are some publications here from radiology paper where you can see if you have bleeding on the back, you have rather from the venous plexus. If you're bleeding in the front, you have from the corona mortis, for example, and you have some idea where the bleeding might come from the region, or you can even have it in the rectus here, the bleeding. And this is something you can judge actually, and it has an excellent correlation with the angiography, contrast-enhanced CT, and it had a high specificity and a high diagnostic accuracy. So with the contrast-enhanced CT scan of the thorax, the abdomen, and the pelvis, you have some good idea if you have a bleeding pelvic injury and if it's an arterial bleeding. And there are some publications the last 10 years about the situation, and they show if you have an arterial plush in your CT scan from an arterial feeder, then you have an arterial bleeding. If you have just hematoma, it's rather a venous bleeding or diffuse bleeding. And so only if you have signs of ongoing bleeding, loss of blood, and enhanced contrast media extravasation, you know you have arterial bleeding where you have something to do, which is different to the situation if you have just a hematoma. So the question is, do we need angiography after the CT scan? And with the angiography, in these cases, you can embolize the arterial hemorrhage. And this is the difference. So if you have a venous bleeding, you have, of course, to perform the pelvic fixation, the pelvic binder. You can make a pelvic packing, where we discuss later on. And this is mainly hematoma venous bleeding. But if you have an arterial bleeding, you might consider arterial embolization. And for this, we have a protocol which we published already many years ago, but we still use it actually. So we have in these patients, in this protocol, we see the bleeding in the situation in these patients, and then we know that we have to do something. We also do it in other fractures, spine fractures, for example, and abdominal and thoracic fractures to judge whether we have arterial bleeding. So this protocol is actually published. So what do we need to do? First, if we have unstable pelvic fractures, which is mostly the case in young patients, in very old patients, it might not be the case that it's unstable and they are still bleeding, but in young patients, it is the case. You need to stabilize it. And of course, the pelvic binder, I mentioned already as the pre-hospital situation. Then theoretically, you have the pelvic clamp, the fixator. You can have a definitive osteosynthesis, and all you can combine with the pelvic packing, and you have the possibility of angioembolization in these patients, what you see here, the fixator, and here the packing. The pelvic C-clamp was very has had a hype, but is almost no more in use. And all the hospitals I know, they're basically only rarely using it. There might be an indication of posterior instability where you can really use it in a good bone, but it's rarely used anymore. And it's just too complicated. And in the pre-hospital situation, in the emergency room, it's also difficult to do it without a X-ray and some other controls. So the major thing is actually the supraacetabular external fixator. And this is a patient a little bit a few years ago with a complete instable pelvis where we used the C-clamp and the anterior fixation. And though we fix the pelvis in the back and in the front, there are currently some discussions to use a screw of the iliosacral joint as an emergency treatment instead of the C-clamp. But personally, we have with the acute screw no experience. And in some situations, it might be necessary to just perform a plate osteosynthesis if you have an open fracture, open free bleeding fracture, and you go to the site. And like in this situation, you cannot use a C-clamp, you cannot use really an external fixator to fix all parts. And also in the open book fracture, sometimes it's just easier to definitively perform the surgery with a osteosynthesis. And all these recommendations are to be read in the S3 guidelines published in English from the German Trauma Society in the European Journal of Trauma and Emergency Surgery. And everything of this is here mentioned. And the bleeding control must be by packing endovascular approaches like the embolization or even surgical. So the pelvic packing should not be from the open abdomen. So if you have a laparotomy and you have exposed everything, you don't get a really good packing. So usually if the pelvic bleeding is the major point, it's better to have an incision in the lower abdomen or secto-caesarean incision. Actually, you fall into the hematoma, you can pull out the coagulates with your hands and you push to the right side and the left side and in the middle 4 or 6 of these towels, and you get a good compression. But for this compression, actually the pelvic ring should be stable. And there are many discussions in meetings, but also in the literature, what is better, angioembolization or pelvic packing, and you can read the one or the other thing. And one thing is quite clear. The selection of the patients for embolization must be very careful. So if you don't have arterial bleeding, embolization will have no effect or no big effect at least, and you have to do other things. And if you perform pelvic packing, but you have still an arterial bleeder, which you might not get compressed really, then, and this is one study, 1 quarter is not stable enough. So the question is not embolization or pelvic packing. The question is to make the right indication, and they are complementary, not antagonistic actually. And a major thing for the initial view in the emergency room is to have the CT scan with the contrast extravasation of an arterial bleeding. And if you don't need to go to the OR, you can do embolization. But sometimes you need to go in the OR, or you have to stabilize by an external fixator or by plates or whatever. You make a packing, and still the patient gets not stable. And this is the case when the anesthesiologist says no, we give blood and still he loses something, not so much. And this is a situation we published a few years ago, that in these cases you might go after the surgery and the pelvic plaquing to the angiography, and in not so few cases you still see an arterial bleeder, or you then the arterial bleeder because the circulation is now better and you can embolize it. So in patients in our situation that get not really stable, they show signs of a continued blood loss due to the pelvis, most likely, of course. Then we go directly to the angiography and look whether we have such a bleeding, and the bleeding then we can embolize. So that means a secondary angioembolization after a primary treatment with pelvic packing, with osteosynthesis fixator or whatever, still is a useful tool to get the patient stable, and sometimes it's really astonishing. So if you do the embolization and 1 hour later the situation is solved, and so this is the message from this. If you do all the surgical procedures and still it's not stable and the coagulation is okay, then you should look again with angiography. And that means the decision making between packing and embolization depends on several things: the injury pattern, the possibility, what you can do, the situation where you are in a high-end hospital or somewhere in the field, of course, and the availability of personnel and people. And I will show you some things a little bit about the decision making. So in the talk before on Roman Pfeiffer, you heard about the stable and unstable patients and when you can go for surgery or you cannot go for surgery. We had been involved in this impact group to discuss all these things. And so in patients that are not responding to primary resuscitation in the emergency department or wherever, you need immediate stabilization, pelvic packing, and if it still does not work, you need, for example, a secondary embolization. But on the other hand, if you have so-called transient responder, that means they got 1 or 2 units of blood, infusions, other stabilizations, coagulation factors, then you get the patient stabilized for a while. And if you have it stabilized, you can perform the angio CT scan. That means the CT scan where you see if you have arterial bleeding or not. And if you have a bleeding, you can go for embolization, and then you can directly or later someday go for the orthopedic stabilization. So this is a differentiation, and if you have no plush, you need to perform the surgical steps. So this is a flow chart we published exactly 10 years ago. Actually, it has not changed so much. Where we say after initial primary survey, X-rays, intubation, fluid resuscitation, and external pelvic stabilization. So all the things should have been done. Then you see if a patient gets stable, and if you get stable, you can do the CT scan with the contrast media, and you have the information what you might need, and you might perform embolization. If you have a transient responder, you can do the same. If you have no plush, you go for a surgical procedure, and if it is not necessary, you go to the ICU, for example. And if you have non-responders, you have no time to perform a multi-size CT scan, and you have to go to the emergency room with mechanical stabilization. And Repoa is a discussion point, so we don't use Repoa actually, and it has too much complications, and it's, I think, only for very specific situations useful. So the algorithm for treatment of patients with pelvic fractures would be, in our situation, a non-responder, emergency operations, stabilization, pelvic packing, whatever. Then you have to fulfill your diagnostic, because it's usually a truck here in the city, which was quick in our hospital, had several fractures, of course, and immediately 6 units of blood loss, so no blood pressure on admission. In this case, we did emergency laparotomy, of course, because there was bleeding. The fractures were also there, and if you can see here, we have still the pelvic binder in the OR. Initially, even a laparotomy we did with the pelvic binder in this situation, and then we packed it and stabilized it, actually, and then later we performed the surgery. Initially, we had to fix the bladder, actually. And during the second look operation, actually, we finished the surgery from the abdomen to fix the pelvic ring with 2 blades, because it was, the situation was so that it was open and we had a urethral lesion which was solved, and the rest was treated later on. And most often situation is the responder situation, where we by standard use the multi-slice CT and see if there's a flush or not. So this is a case of motorbike against the car with a symphysis rupture sacrum fracture. So he was pretty stable, as you see from this. Still, he got external compression, and he has this fracture. So we did routinely our polytrauma scan actually, and in this situation we performed initially anterior stabilization of the symphysis rupture, the open book fractures, and due to a bleeding we did a post-operative angiography. And this post-operative angiography, we saw a continued bleeding in this situation. So obviously he was not so stable during the surgery, and was bleeding from the pudenda branch, and it was coiled, and then it was stable. And a few days later we finished the orthopedic surgery by the iliosacral screws. And one of the most cases are the transient responders with the multi-slice CT after primary stabilization. So there's a 50-year-old man from 5-meter fall from a construction site. So he had this C-type pelvic fracture, also spine fracture, and bleeding in the brain. So he has a low blood pressure, declining when he came. He got 2 red cell packs, and then it's a transient responder. We stabilized him so far that we could perform our CT, and we saw a huge hematoma actually, and we saw a contrast plus within the hematoma, and we thought it should be the internal iliac artery, what you can see here as a situation. And with this stabilized patients, we went in the angiography, and he was already monitored by the pressure of the brain and ICP monitoring, and we saw the bleeding, and we embolized the bleeding, and then the patient was stable. Then we did no surgery the first 10 days, and day 13 we completed actually the reconstruction of the pelvis, and you'll see some coils in this situation. So the decision making is between non-responders and responders or transient responders, what I just told to you. And you have we go according to this chart in this situation, and I might conclude my talk that pre-hospital, clearly the pelvic sling is essential. Yeah, it should be on the right place and not too strong actually. And we always still use initial X-ray of the pelvis and the chest. Some other people only do CT scan. We feel safer with this because we have it within minutes, and we have some idea is there's a pelvic injury or not. And then you have to stabilize the pelvis in stable pelvic fractures. You have to discuss the embolization. The packing is for emergency treatment necessary. The packing can remain 2 days actually. Then you have to change it or to take it out. Usually you can take it out. And also you should consider, if you have done all your treatment and the patient is still not really stable, it still losses over time blood, it's a good idea to perform a new angiography in this situation. Yeah, thank you very much for hearing this talk.
Thank you so much. Is there any questions from the audience? Thank you. Thank you so much for this wonderful presentation. I have one question. Do you use it when you provide emergency care along with packing? Do you use ligation of internal inguinal artery?
Okay, this might happen. Yeah, it depends what you have. So in our university situation, we have 24 hours interventional radiologists. So we don't use it regularly. I remember 2 cases where we did it, and if you don't have it, you ligate it. Yeah, I think. because first you have to get some stability. The other thing is, if you use a Reboa catheter in this situation to get to save some time to look where the bleeding is coming on and where you can reconstruct it. But in the first situation, you have to get a stopping of the bleeding, and then you have to see what's going on.
Have you done ligation, internal iliac artery? Have you done ligation of internal iliac artery in your in an open surgery, openly, without no angiography, no Reboa, for example, first level?
Yeah, we have done it. So I think 2 cases. If you do it on one side, in a certain situation, you can do it, I think. Yeah.
Thank you very much for your presentation. Very interesting. We know the standards of care provision. Yes, and a separate question, not about your presentation with regards to pelvis, acetabulum. When do you do surgery on acetabulum in polytrauma patients?
Okay, usually never initial. So to reconstruct the acetabulum, the reconstruction of the acetabulum needs, I would say, a little bit of time and quite a situation, because at the end you have it to reconstruct it as best as it is possible. But sometimes the acetabulum fracture is part of the unstable pelvic ring fracture. And these are situations where you should do it early, not late. Actually, destroyed acetabular fractures where you need ilioinguinal or dorsal approach, I think we never do initially. But I showed you the one case, the first case where we had the open abdomen. And if the fracture goes over the acetabulum and you put a plate from the os pubis from the other side over the same side to the os ilium to stabilize the pelvic ring, and this is like a stopper plate actually, you can do it very early. So in certain situations, maybe also the first day. But if we have the patient stabilized, he has an acetabular fracture, we would do it a few days later, after 4 or 5 days. Usually we wait 4 or 5 days until the patient is stable. But I agree, it might be a situation that you have done an open pelvic packing with a symphysis incision. You have the towels inside, the patient is stable. After 1 or 2 days, you take it off, and then you put a stopper plate in. So nothing against this, but it must be possible.
Can you tell us, Professor Martsev, what if, for example, just to continue with what Professor Ankin has mentioned, what if it's a patient with old trauma of pelvis or acetabulum? So a long time has come, like, for example, 1 month and a half has passed since that fracture. I understand that in Frankfurt you don't have such situations, but we face such situations. How, hypothetically, what would you do with patients like that? Would you try to do the osteosynthesis of acetabulum? And if yes, what kind of operating table would you use? HANA table or some other? Because you have to be physically really strong to use power for reduction, for reposition of such patients. So it's very difficult to distract them 1 or 2 months later. Would you do that, or you would leave it like that and then you do prosthesis if it's a complicated fracture of acetabulum?
Okay, this is a different question. So actually, sometimes we get transferred patients from over the world with old fractures like this. You're right. After 6 or 8 weeks, it's pretty late, and it's difficult to really do a good reconstruction. And then it depends on the age. So if you have an older patient and the pelvic ring is more or less normal, I would stabilize it and put the endoprothesis later on. If you have a young patient and a shortening of the leg due to a vertical shear fracture or something, in addition, or a strong protrusion into the pelvis, I think we will try to reconstruct it, even knowing that it's not easy. You have to open the colors again, and you ask for a tension table or not a tension table. We never use tension table in acetabular fractures, but I will not exclude it. But maybe also if you have a very late patient and a contraction, you might use first for a few weeks distraction external fixator to get extremity in the right length, and then to do the reconstruction. But reconstruction is only useful after 6 or 8 weeks if you really can restore the cartilage. If this is not possible, you should restore the length of the leg and then do endoprosthesis.
Dear colleagues, thanks so much. Thanks, Professor, for this amazing talk. There is another question coming from here. Just a short question in case you allow. So I am interested, when we have a pelvic fracture with ureter disrupture and epicystostome is being implemented, do you use osteosynthesis or not in case of epicystostome?
Okay, yeah, this is no problem. We don't care, actually. Yeah. So this happens in many cases, and they have a cystostoma, and we rinse it, we clean it, and then we do the osteosynthesis. Yeah. Yeah, I would use for maybe a week antibiotics in these cases. But this is no reason not to do the osteosynthesis, I think.
Thank you. Dear colleague, thanks so much. Thanks so much to the whole audience for this activity, for interesting questions, practical questions to our speakers. We are going to continue this session.
Yeah, have a nice meeting.
And I would kindly invite the Chief Doctor of Traumatology Institute, Vice President of the Association, Roman Derkach, with his talk regarding providing care in case of trauma and polytrauma in conditions of the current medical institutions, the need of the change. Dear committee, dear specialists, dear friends, dear colleagues, first of all, I would like to say thanks to everybody who's participating in our Congress. I do understand that we have more than 500 of registered people, and we are around 600 of registered people. So it's time to change. What it means that there is a need of change, and not only the change in terms of the medical approaches, but it's also the time to change the organization. I do see that a lot of youth is in the audience, and I don't want them not to have any kind of cognitive confusion regarding what they hear from our foreign colleagues, but they need to understand what is happening in our country, how trauma and polytrauma is being approached in regional clinics, district clinics, and also in other institutions, especially in rural area. So when we talk about the need of the changes and attitude of the government towards the medical institutions, this is the talk. So at this moment of time, we all understand how in our country, how care is happening in our country regarding the patients with trauma. That's emergency which transports patient to identify to the closest medical institution, which might be always not ready or might be ready partially to admission the patient with polytrauma. And there is a complicated question whether they have local guidelines, standards, what to do in case of patients with polytrauma, and whether those standards are good enough, and who has created those standards. Of course, when we transport the patients with polytrauma and trauma, they receive anti-shock therapy. We hope that they are being admitted where there is an anti-shock room. But immediately after that, especially when we talk about rural area and some kind of local hospitals, the presence of the equipment, the needed equipment, the patient is going to be hospitalized to one of the profiled institutions. And in case specialties do not allow to perform some kind of interventions, then there are the nearest relatives which are agreeing on how to transport this patient to a more ready to be used facility. And it loses some time. And we lose the most important thing which we have. We lose lives and health of our patients. As I have mentioned previously, the journey of a patient at this moment of time inside the institution, I'm not going to stop on that. That's the admission department, anti-shock room, and then reanimation and intensive care unit. In case we have all the needed specialists and care is being provided, then this patient is going to stay in the profile department and is going to get treated. But in case there are no needed specialists and there is no equipment, immediately after the intensive care unit, patient moves the other way around. It also is regarding the polytrauma. For almost 30 years, we talk that in our country we do not have definition of polytrauma, and there is no statistics according to what polytrauma we have and how many polytrauma patients we have. We have polytrauma departments where great surgeons, neurosurgeons, orthopedics, traumatologists work, and they provide care in case of polytrauma. But there is no normative document on the governmental level that would identify what kind of department should be named as polytrauma. We do not have that. Also, we do not have exact algorithms regarding the treatment and who should treat those patients and who should be the head and who should develop those algorithms and who should develop overall local guidelines and standards. Also, we do not have any legislation framework regarding that. To my opinion, this is the new specialty which we need to create in our country. That's the damage surgeon. But when we create a specialty of a damage surgeon, in case we are going to leave the old system of providing medical care to patients with trauma and polytrauma, we are not going to go any further. That's why we need to change the concept of trauma. It should be comprehensive and inclusive, and it should be pre-planned, organized, and coordinated work regarding the control of trauma in identified geographical area, whether it's a province, whether it's a region. We need to have an agency which is going to identify those patients. It should be guided by the government, it should be financed, and it should be accountable, and also it should be responsible for prevention. It should provide all the services from the moment of trauma until the full rehabilitation of the patient. System should include immediate access to the emergency care, fast transport to the appropriate level of care, also the emergency care like intensive care unit, surgery, and also special services, rehabilitation and reintegration in the society. We should fully use this system to have studies, trials, and to improve the current system. And this system identifies the connections with the emergency program. This kind of system exists all over the world. Was it in Ukraine? Yes, it was. I would like to give you two documents, examples of two documents. The first document is from the Soviet Union. The other one is coming from the 90s in our country, where we had a trauma committee, which was organized by the vice prime minister at that moment of time, and it was influencing all the ministries. And there was a task for the ministries to improve the work towards providing care to patients with trauma. Because of some events, after 20 years, for 20 years, Ukraine did not have issues with trauma, such huge issues which are in front of us right now. And with time, those committees, they were shortened and they were disorganized, so no more committees were working regarding the trauma. But as you have heard from our foreign colleagues, all over the world, there is a system of care for trauma, which includes the network trauma. What are trauma centers, which organize network? These are the centers which try to shorten the time towards the treatment and to provide the needed amount and volume of care to minimize the transportation time among patients with multiple and combined trauma, and for those patients to be treated in specialized centers of trauma. When I was evaluating the centers all over the world, in the United States of America, in Canada, in Europe, I have never seen an ideal network or ideal system. Each system has their own advantages and disadvantages, benefits and negative aspects. But in front of Ukraine, we have a challenge. We need to create this system. We need to take the best experience, and we need to create trauma centers system within the medical institutions of our country. All over the world, trauma centers are playing an important role in providing care to patients with trauma. Traumatological center, trauma center, this is the medical center where resources and priorities are identified in order for patients with acute trauma to receive full and in-time resuscitation, evaluation, and care. I would like to underline that one of the highlighting moments, that's the equipment of the centers. At this moment of time, there is no hospital in Ukraine which corresponds to those international demands in terms of equipment. We have a worldwide experience. In the United States of America, we have 4 levels of centers. First level, specialized centers based on university hospitals. Second level, these are city and regional hospitals. Third level, small hospitals. And fourth level, the smallest possible hospitals in some kind of rural areas. These are the first level trauma centers. In Canada, there are 5 levels of traumatological or trauma centers, and also 2 levels of specialized pediatric trauma centers. So government is thinking about pediatric population, so they have a separate pediatric trauma centers. And there is a Trauma Association of Canada, which is responsible for that. And in case you have heard during these trauma centers, and this is the function not which is being carried by the Ministry of Health, but it is carried by the profile specialties organizations. What is the trauma center of the first level? This is the head role in the system of traumatology, the central role in regional system of traumatology. 1/3 of all care is provided in this center. They provide comprehensive and unique traumatological services, also academic experience which is needed to be present. There are a couple of ways on how to develop the systems, trauma systems. How are trauma centers organized? Some of them are organized based on the population. So, for example, the amount of centers are being calculated on 1 to million of population, or it is being calculated based on the amount of trauma. And for example, in case these are the trauma from 500 to 1000 of serious traumas, they create the second to the first level trauma. The third and the fourth trauma centers, that's rural area. These are city hospitals. But I would like to emphasize that this is the work which is conducted according to the same standards. And also, that's the transport of the patients from third or fourth level to second or first level of trauma centers, and it should be done without any kind of prior alignment. That's the Europe. We have this slide of trauma centers from Germany, where on 80,000 millions of inhabitants, we have this amount of trauma centers. So what is Center of Trauma? That's a separate specialized unit of the hospital which has a specialized care which is being provided. It should include an emergency department, anti-shock room, resuscitation room, intensive care units, surgery, in hospital, stationary departments, and also the outpatient facility for those patients which were treated previously. We expect that for Ukraine, it is possible to create of the first third levels. So for us to have a 3-level system of trauma centers in Ukraine. I'm not going to emphasize on the main principles because the time is flowing, but we need to provide the highest possible specialized care, and we need to transfer these patients from trauma center of the 3rd level to 2nd or the 1st level of trauma center. At this moment of time, we have absence of specialists which would be prepared to treat the most severe patients with polytrauma. As I have mentioned previously, we have great surgeons, neurosurgeons, traumatologists. They work according to their own algorithms or developed algorithms for those institutions where polytrauma units are present, but we do not have a separately approved specialists. So it is still unclear where to treat patients with polytrauma. They are being treated in different surgical or traumatological inpatient facilities, and specialists there might be not ready enough and might not be aware on all the peculiarities of providing care to these patients. During the last period of time, a lot of things were created. Ministry of Health, after constant changes, whether they create a hospital, amalgamated communities, or whether they create intensive care units, and right now they create cluster hospitals and over the cluster hospitals. Work has shown that orthopedics and traumatologists, surgeons, they play a rather important role in treatment of the patients with trauma. That's why they have created expert groups. They have created expert communities, as you have heard from Professor Dubrov lecture. In 2025, it is planned to have an optimization of patient journeys and also the creation of multidisciplinary groups to work with patients with polytrauma. That's why we have this kind of proposal to the Ministry of Health, in case you support us. It should be a multidisciplinary working group which is going to be created based on a couple of associations. We are not going to come from top to bottom, we are going to go from bottom to top. And this working group is going to develop guidelines, protocols, standards, doesn't matter how we name it, for patients with polytrauma, after car accidents, after combat wounds, and so on. They are going to have a united, structured system. We are going to identify and we are going to approve the main timelines needed in order, and I'm going to emphasize it once again, everything that we need to have a united registry of trauma. A separate talk is going to be dedicated to the registry of trauma. Also, as we have mentioned previously, we are going to develop within this working group patient journeys with trauma patient journeys. Also, we need to adapt them according to our country. We need to have adapted worldwide guidelines for our country. And also we need to have an agenda and the environment, the equipment provided for the first, third level of centers. We need to identify medical institutions where the trauma centers might be organized. We need to approve officially the protocols according to which local algorithms should be developed for trauma centers of the first level. And I hope that in 1 year, on the next Trauma Congress of Ukraine, we are going to present our work of this working group, and we are going to identify further steps. On this photo, I would like to remind everybody that in most of the regional hospitals, there are orthopedic departments which are not dealing with trauma. On this photo, these are the first days of the full-scale invasion of Russian Federation. And when in our emergency department, admission department of our institute, and our institute in 90% of the cases was doing orthopedics, we received the first injured, the first wounded patients. It was Bucha, it was Irpin, it was all the patients coming from Zhytomyr. Immediately, all specialists requalified, and they recalled their traumatology skills, and we started to work in 100% traumatology department institution. So sometimes our life brings sudden things to us. So dear medical community, I kindly invite you to know that trauma issues are extremely actual at this moment of time, and I kindly ask you to support me in all of those issues which are highlighted on our Congress. Everything is going to be Ukraine. Thanks so much. Roman, thanks so much. In case there are any questions coming from the audience, please feel free. Okay, it works. Thanks so much for this presentation. Really, in fact, what you have presented are actual questions, and your presentation sounds like a plan, according to my opinion. It's not like a presentation, it's a plan on what is needed to be done regarding the issues which exist. My personal question, which is more conceptual, according to your opinion, what are the limitations for us to move further regarding those? What are the barriers which we may face in order to fulfill this plan? What are the main limitations which we may have as a team which is going to work on those steps which you have mentioned previously, whether it's human resources or bureaucracy? Thanks so much.
Thank you for this wonderful question. It's true, my presentation is not something new that I was talking about. We've been discussing that for about 30 years. It's true. So we heard a lot from the Ministry of Health, the committees of the Verkhovna Rada, and we discussed why we need that, how it's going to work, what do we get in the end. So why are we talking about today? Because of the 3 years of large-scale invasion and 10 years of war, basically, now the system of care to injured people needs improvement, and everyone understands that really well. If those issues, when they were discussed in 2021, so we discussed that in it was in 2017-18 there were committee hearings on polytrauma. So if that system, the overall national system, was adopted earlier, maybe right now, I cannot tell you for sure, it's my personal opinion, we would probably would have had better results. As of today, as we see, if we follow the route of initiatives from specialty associations, professional associations, we don't have to get any hindrance things from the government, and the Ministry of Health can hear us, everyone can see what's the situation in the country. I don't see those hindrances right now to implement a program like that today. But funds, we've always had lack of funds and costs in the country. Hello, thank you very much for your presentation. Roman, I'm interested in the following question. What do you think? Number one, how time will it take to implement a system like that? And number two, with regards to damage surgeons, do you think it's worthwhile to train new ones, like to introduce changes into the education curricula, or maybe additional training to already existing specialists? So thank you. The answer is in your question. As of today, of course, we cannot start from scratch to develop damage surgeons. One of the options that to take traumatologists, orthopedic surgeons, neurosurgeons to undergo additional training, like refresher course plus additional training to learn basic principles of providing care. According to that new system, maybe they have to be trained abroad, then when they come back, they train young specialists, new specialists. So we count on Ukrainian youth who would like to see changes and to make changes. So it's about 2 to 3 years, but trauma centers is a different thing, so it can be done even tomorrow. For that, you don't have to start from scratch or construct something. There is a system acting in each region. We just have to get together and say, like, for example, this is orthopedic traumatology regional department, so this is going to be trauma center level 1, and then follow the algorithm. Regional, local protocols also developed and start working. You don't need to construct to build anything. Just like we did in Kiev Oblast, so you audit the existing hospitals and the equipment and maybe add something, whatever they need. So it will take some time and depends basically on local government and the community, specialty community that's going to push them forward. Thank you, colleagues. Do you have any other questions? If no questions, so then we will hear the plan, the future plan. Thank you very much, dear colleagues. After lunch, we are invited to the Zurich auditorium to master classes. And what time, dear colleagues? We have lunch according to our agenda, 1604 p.m. We continue with lectures here. Thank you. Also, please visit the satellite lectures. You will be able to see what kind of new equipment, new methods are used now. And 4 o'clock, come back to this room.
1 to 1.5% of people in industrial nations suffer from chronic wounds, such as pressure ulcers, vascular leg ulcers, and diabetic foot ulcers. Besides being a high burden on the patient, these wounds can also generate high costs for the healthcare system. But why are chronic wounds such a challenge? Wound infections are a major factor. It is estimated that more than 50% of all chronic wounds are infected. Wound infections are caused by microbials such as bacteria, which do not only like to multiply, they also produce biofilm. Biofilm forms when free-floating bacteria adhere to surfaces and grow a colony. This colony excretes a thick and slimy substance, an extracellular polymeric substance which consists of polysaccharides, protein, and other elements. Biofilm can also release bacteria which form new colonies in nearby areas. The biofilm acts like a shield for the bacteria and protects it from many antimicrobials, including antibiotics, and from the host's immune system as well. So there can be a constant threat of a chronic wound infection. To prevent the development of wound infections and to promote wound healing, it is important to remove the biofilm and achieve an effective wound bed preparation. The Prontosan range provides a smart solution to effectively cleanse the wound of biofilm, slough, and debris. Moreover, the special combination of ingredients reduces the biofilm and also impedes its reformation. The two main ingredients in Prontosan solution are polyhexanide and undecyleinamidopropylbetaine. To keep it simple, we call it betaine. Betaine is a surfactant. Let's have a look at how a surfactant works. A surfactant molecule basically consists of a hydrophilic, water-attracting head and a water-repelling, hydrophobic tail. Since the tail doesn't like water, it searches for another place to go, which here is our biofilm. The polar heads of these surfactant molecules have the same electric load, and therefore they repel each other. This is how the biofilm breaks up. Several of these surfactant molecules bind to the biofilm and build micelles, which can then be removed from the wound bed much more easily. In this way, betaine has in essence opened the door for the supportive effect of polyhexanide in Prontosan, which can now act against the bacteria. Polyhexanide, or PHMB, is used as an antimicrobial substance. It is able to attack and destroy various types of microorganisms. Gram-positive and gram-negative bacteria are protected by a cell wall, whereas human cells are surrounded by a cell membrane. These bacteria can cause serious diseases and are resistant to antibiotics and antiseptics. A bacterial cell wall has a negative charge, while the PHMB molecule has several positive charges, which makes PHMB act like a magnet, attaching itself to different areas of the cell, starting with the negatively charged outer cell wall. PHMB binds itself to the cell wall through electrostatic interaction. The cell wall breaks open and begins to leak where the PHMB molecules attack. This results in the cytoplasm exiting the cell, which quickly causes the bacteria to die. PHMB attacks, breaks down, and destroys bacteria. Due to its positive charge, it also supports the barrier effect on the wound, as it helps prevent bacterial cells from adhering to the wound surface. No bacteria, no pathogenic biofilm. In summary, betaine breaks up biofilm and opens the door for polyhexanide to act against bacteria and to interfere with the reformation of biofilm. That's why Prontosan is a smart solution, not only for an effective wound bed preparation, but also to help prevent wound infections. 1 to 1.5% of people in industrial nations suffer from chronic wounds, such as pressure ulcers, vascular leg ulcers, and diabetic foot ulcers. Besides being a high burden on the patient, these wounds can also generate high costs for the healthcare system. But why are chronic wounds such a challenge? Wound infections are a major factor. It is estimated that more than 50% of all chronic wounds are infected. Wound infections are caused by microbials such as bacteria, which do not only like to multiply, they also produce biofilm. Biofilm forms when free-floating bacteria adhere to surfaces and grow a colony. This colony excretes a thick and slimy substance, an extracellular polymeric substance which consists of polysaccharides, protein, and other elements. Biofilm can also release bacteria which form new colonies in nearby areas. The biofilm acts like a shield for the bacteria and protects it from many antimicrobials, including antibiotics, and from the host's immune system as well. So there can be a constant threat of a chronic wound infection. To prevent the development of wound infections and to promote wound healing, it is important to remove the biofilm and achieve an effective wound bed preparation. The Prontosan range provides a smart solution to effectively cleanse the wound of biofilm, slough, and debris. Moreover, the special combination of ingredients reduces the biofilm and also impedes its reformation. The two main ingredients in Prontosan solution are polyhexanide and undecyleniamidopropylbetaine. To keep it simple, we call it betaine. Betaine is a surfactant. Let's have a look at how a surfactant works. A surfactant molecule basically consists of a hydrophilic, water-attracting head and a water-repelling, hydrophobic tail. Since the tail doesn't like water, it searches for another place to go, which here is our biofilm. The polar heads of these surfactant molecules have the same electric load, and therefore they repel each other. This is how the biofilm breaks up. Several of these surfactant molecules bind to the biofilm and build micelles, which can then be removed from the wound bed much more easily. In this way, betaine has in essence opened the door for the supportive effect of polyhexanide in Prontosan, which can now act against the bacteria. Polyhexanide, or PHMB, is used as an antimicrobial substance. It is able to attack and destroy various types of microorganisms. Gram-positive and gram-negative bacteria are protected by a cell wall, whereas human cells are surrounded by a cell membrane. These bacteria can cause serious diseases and are resistant to antibiotics and antiseptics. A bacterial cell wall has a negative charge, while the PHMB molecule has several positive charges, which makes PHMB act like a magnet, attaching itself to different areas of the cell, starting with the negatively charged outer cell wall. PHMB binds itself to the cell wall through electrostatic interaction. The cell wall breaks open and begins to leak where the PHMB molecules attack. This results in the cytoplasm exiting the cell, which quickly causes the bacteria to die. PHMB attacks, breaks down, and destroys bacteria. Due to its positive charge, it also supports the barrier effect on the wound, as it helps prevent bacterial cells from adhering to the wound surface. No bacteria, no pathogenic biofilm. In summary, betaine breaks up biofilm and opens the door for polyhexanide to act against bacteria and to interfere with the reformation of biofilm. That's why Prontosan is a smart solution, not only for an effective wound bed preparation, but also to help prevent wound infections. 1 to 1.5% of people in industrial nations suffer from chronic wounds, such as pressure ulcers, vascular leg ulcers, and diabetic foot ulcers. Besides being a high burden on the patient, these wounds can also generate high costs for the healthcare system. But why are chronic wounds such a challenge? Wound infections are a major factor. It is estimated that more than 50% of all chronic wounds are infected. Wound infections are caused by microbials such as bacteria, which do not only like to multiply, they also produce biofilm. Biofilm forms when free-floating bacteria adhere to surfaces and grow a colony. This colony excretes a thick and slimy substance, an extracellular polymeric substance which consists of polysaccharides, protein, and other elements. Biofilm can also release bacteria which form new colonies in nearby areas. The biofilm acts like a shield for the bacteria and protects it from many antimicrobials, including antibiotics, and from the host's immune system as well. So there can be a constant threat of a chronic wound infection. To prevent the development of wound infections and to promote wound healing, it is important to remove the biofilm and achieve an effective wound bed preparation. The Prontosan range provides a smart solution to effectively cleanse the wound of biofilm, slough, and debris. Moreover, the special combination of ingredients reduces the biofilm and also impedes its reformation. The two main ingredients in Prontosan solution are polyhexanide and undecyleinamidopropylbetaine. To keep it simple, we call it betaine. Betaine is a surfactant. Let's have a look at how a surfactant works. A surfactant molecule basically consists of a hydrophilic, water-attracting head and a water-repelling, hydrophobic tail. Since the tail doesn't like water, it searches for another place to go, which here is our biofilm. The polar heads of these surfactant molecules have the same electric load, and therefore they repel each other. This is how the biofilm breaks up. Several of these surfactant molecules bind to the biofilm and build micelles, which can then be removed from the wound bed much more easily. In this way, betaine has in essence opened the door for the supportive effect of polyhexanide in Prontosan, which can now act against the bacteria. Polyhexanide, or PHMB, is used as an antimicrobial substance. It is able to attack and destroy various types of microorganisms. Gram-positive and gram-negative bacteria are protected by a cell wall, whereas human cells are surrounded by a cell membrane. These bacteria can cause serious diseases and are resistant to antibiotics and antiseptics. A bacterial cell wall has a negative charge, while the PHMB molecule has several positive charges, which makes PHMB act like a magnet, attaching itself to different areas of the cell, starting with the negatively charged outer cell wall. PHMB binds itself to the cell wall through electrostatic interaction. The cell wall breaks open and begins to leak where the PHMB molecules attack. This results in the cytoplasm exiting the cell, which quickly causes the bacteria to die. PHMB attacks, breaks down, and destroys bacteria. Due to its positive charge, it also supports the barrier effect on the wound, as it helps prevent bacterial cells from adhering to the wound surface. No bacteria, no pathogenic biofilm. In summary, betaine breaks up biofilm and opens the door for polyhexanide to act against bacteria and to interfere with the reformation of biofilm. That's why Prontosan is a smart solution, not only for an effective wound bed preparation, but also to help prevent wound infections. 1 to 1.5% of people in industrial nations suffer from chronic wounds, such as pressure ulcers, vascular leg ulcers, and diabetic foot ulcers. Besides being a high burden on the patient, these wounds can also generate high costs for the healthcare system. But why are chronic wounds such a challenge? Wound infections are a major factor. It is estimated that more than 50% of all chronic wounds are infected. Wound infections are caused by microbials such as bacteria, which do not only like to multiply, they also produce biofilm. Biofilm forms when free-floating bacteria adhere to surfaces and grow a colony. This colony excretes a thick and slimy substance, an extracellular polymeric substance which consists of polysaccharides, protein, and other elements. Biofilm can also release bacteria which form new colonies in nearby areas. The biofilm acts like a shield for the bacteria and protects it from many antimicrobials, including antibiotics, and from the host's immune system as well. So there can be a constant threat of a chronic wound infection. To prevent the development of wound infections and to promote wound healing, it is important to remove the biofilm and achieve an effective wound bed preparation. The Prontosan range provides a smart solution to effectively cleanse the wound of biofilm, slough, and debris. Moreover, the special combination of ingredients reduces the biofilm and also impedes its reformation. The two main ingredients in Prontosan solution are polyhexanide and undecyleinamidopropylbetaine. To keep it simple, we call it betaine. Betaine is a surfactant. Let's have a look at how a surfactant works. A surfactant molecule basically consists of a hydrophilic, water-attracting head and a water-repelling, hydrophobic tail. Since the tail doesn't like water, it searches for another place to go, which here is our biofilm. The polar heads of these surfactant molecules have the same electric load, and therefore they repel each other. This is how the biofilm breaks up. Several of these surfactant molecules bind to the biofilm and build micelles, which can then be removed from the wound bed much more easily. In this way, betaine has in essence opened the door for the supportive effect of polyhexanide in Prontosan, which can now act against the bacteria. Polyhexanide, or PHMB, is used as an antimicrobial substance. It is able to attack and destroy various types of microorganisms. Gram-positive and gram-negative bacteria are protected by a cell wall, whereas human cells are surrounded by a cell membrane. These bacteria can cause serious diseases and are resistant to antibiotics and antiseptics. A bacterial cell wall has a negative charge, while the PHMB molecule has several positive charges, which makes PHMB act like a magnet, attaching itself to different areas of the cell, starting with the negatively charged outer cell wall. PHMB binds itself to the cell wall through electrostatic interaction. The cell wall breaks open and begins to leak where the PHMB molecules attack. This results in the cytoplasm exiting the cell, which quickly causes the bacteria to die. PHMB attacks, breaks down, and destroys bacteria. Due to its positive charge, it also supports the barrier effect on the wound, as it helps prevent bacterial cells from adhering to the wound surface. No bacteria, no pathogenic biofilm. In summary, betaine breaks up biofilm and opens the door for polyhexanide to act against bacteria and to interfere with the reformation of biofilm. That's why Prontosan is a smart solution, not only for an effective wound bed preparation, but also to help prevent wound infections.
Okay, perfect. I have done that. Actually, you have it pre-recorded because my connection, I think, is not that stable. I sent it pre-recorded. The PPTX pre-recorded was a video of myself. I sent it this morning to Volodymyr.
Afternoon, Christoph. Just to verify that you're able to hear me, that's the interpreter talking. In case you hear me, it means everything works as it should.
I'm hearing you.
Dear colleagues, according to the agenda, we continue our meeting, our congress, and we continue our lecture part. So according to the agenda of the congress, this meeting should start at 15:50 sharp, and it should continue up to, with the next talk, it should continue by the talk of Christoph Hirsch, but due to the technical issues, the organizers have asked me to have his lecture as the next one, because there are some issues with internet connection and with the video recording. So right now, based on this, I would like for us to align for not to lose any time and for us not to lose any agenda time, because we plan to have an dinner after the meeting. So the next talk is going to be presented for now by our dear Petro Nikitin, the modern trends in development of osteosynthesis approaches. So please, Petro, we kindly invite you to the talk. Good afternoon, dear colleagues. Extremely happy to greet all of you on this forum. My name is Petro Nikitin. I am head of the Department of Orthopedics and Traumatology in Central Border Control Service of Ukraine, and the main topic of my talk is going to be the modern worldwide trends in the development of osteosynthesis methods. As far as all of you know, there are main principles which were already formed by association of AO, principles of fracture treatment, to protect the blood flow, to have the functional reposition, to have a stable and also early active function. And our main approaches of osteosynthesis are this kind of 5 main approaches. This circulage or wire, that's screws, these are external fixation devices, that's bone plates, and also intramedular blocked spines. In our realities, we have a lot of issues. We have lost this school of external osteosynthesis, according to Elizarov, and also the experience in how to fulfill it. Most of the young specialists do not know and do not how to perform Elizarov osteosynthesis. Also, there is an absence of toolkits and implants for osteosynthesis in most of the clinics of Ukraine. The standard toolkits which are needed to be performed by traumatologists. There is absence of school of osteosynthesis and also the criteria of quality of performing the internal fixation. And also there is no control over the quality of our osteosynthesis based on some kind of external experts. In most of the cases, there should be an external expertise, which is an external insurance company. That is how it is done in the Western countries. So Ukraine is standing in between external and internal osteosynthesis. And you may see that there are some trends. Internal osteosynthesis, this is something which is happening in the global north, and the external osteosynthesis or conservative approach, that's the global south approach. And Ukrainian traumatologists, they don't know in most of the cases where do they go, because they do not have enough money and they do not have enough resources to have internal osteosynthesis, and we have forgotten the external osteosynthesis, and it's a pity. So the main goal of my talk is to show the main trends of the development of osteosynthesis in the modern world, and also to identify the direction of movement for our young traumatologists which are present in the audience. I think that this slide, this is the basic slide, and I may finalize my talk based on this slide. These are the modern approaches to osteosynthesis, and they require all of those demands to be fulfilled. In case you have osteosynthesis, with all of those demands, then your osteosynthesis is going to be successful. Early stable osteosynthesis with high quality fixators, the minimal invasive approach, to use small surgical access, also intrasurgical control regarding the reposition and the quality of fixation, post-surgery control, CT control after fulfilling the osteosynthesis of intra-articular fractures, the usage of artificial materials to have a plastic to cover the plastic defects of the bone defects, the in-time and quick closure of soft tissue defects, and also in-time and clever approach to the usage of antibiotics. And also we cannot go without rehabilitation. Early rehabilitation. The earlier the better. It gives an opportunity to have a good result based on everything which have achieved in the surgery. What are the main trends regarding our internal fixators? That's Titan fixators with type 2 anodine. What are the main advantages? That that bone does not grow into the fixator, that we increase how sturdy the implants are. Also the risks of the cold melding when we have the second type of anodine. Also, we might increase the prior load of those screw changes, of those screw connections, and also we have a decreased possibility to have biofilms in our implants. And let's take a look at all the possibilities. Wire. At this moment of time, using wires. So, circular wires is not used rather often right now, and also to mostly fixate one tubular bones. Mostly, wires are used as an 8-shape loop in case of some kind of fractures, like the knee fractures, intra-articular fractures, but it requires internal splinting with spines or with screws. When we use wire systems, this is something which is used by our friends endoprothesis specialists when we have the fractures and they're used in an isolated fashion. It is not used that frequently. Usually it's an additional fixation when we use special plates. Screws. Screws are being used, standard screws, and they're not used rather frequently. They're not used often in an isolated approach. Right now, only cannulated screws are being used, which we use according to the spines. And these are the ones which we use when we, for example, acetabulum fractures, in case we have pelvic fractures, in case we have caput of the femur being fractured, and so on and so on. That's an example of having wire the ischiadic part by using the posterior part of acetabulum, and it is done under the control of the CT. That's a fixation once again of this pelvic fracture, and the fixation is being done with the long cannulated screws. Fractures of the caput of the femur, please do not forget that the standard fixation, in case we have caput of the femur, it is being performed by 3 cannulated screws, and at this moment of time quite widely are used screws when there is a heel bone fracture, which is done minimally invasive thanks to the cannulated screws.
X-fix systems, as of today, as you know, those are the most prevalently used fixators that are used in our country in general. And you know that there are pin-based, screw-based, and combination based on circular frame or rod-based system, or as of today, in Western countries, hexapod-based systems started to be used widely. So when do we mostly use X-fix systems? So the trends using them in the global practice. In closed fractures, not used, so exclusively used in open fractures, stage 1, 2, maybe 3, or as a conversion method. So preliminary fixation before the internal fixation. So you can see gunshot wound in this patient with this situation. So we have done the conversion method very quickly, day 6, from the time of X-fix system placed. Widely used also in different orthopedic pathologies, deformities, shortening of extremities. Here, there is a gunshot wound, and one of the captured soldiers kept in prison was shot from Makarov. So there is malunion and shortening of the extremity, osteotomy, distraction, osteogenesis. An orthofix system, X-fix system was used for this case. So distraction, and then there was a LIS system used for the external part. And also this is for replacement of bone defect system. And in this case, we can see, like on this slide, using a Lizarov system combined with internal fixation with intramedular screw traction, and then distraction osteogenesis was done, and then the system was removed and the patient started to walk on intramedullary blocked screw. Very convenient systems. Those who are into military trauma, you have seen them already. Special systems for emergency quick fixation when we have mass casualties, in order to provide fixation, basically to immobilize and to provide some traction of fragments in order to remove some angular and other deformities. And those are the module fixators, hexapods. We have such in some clinics. We've already been trained in using them. I think it's for future. It's a good view for future, but what stops us is they are quite expensive and they require special software to use them correctly, but the system is very good. I've been to this training course in Davos in 2016, how to use those systems. So my belief is this is the future of our orthopedics. And this is bone plates. Globally, they're widely used. There are standard DCP plates. They used not less frequently than LCPs. The newest ones is polyaxial stability plates, also widely used, frequently used. What's their benefit is we can control that our screws do not penetrate the articular area, the joint area. And also this is for fixation and very definitive localization fractures. So I think there is going to be development here. There will be some fixators. For each specific localization, the fixators are going to be developed very specific. It's just different size types. And probably, I think even custom individual fixators are going to be manufactured. It's just the strengths need to be the required strengths. What are the main trends? Using our plates in diaphysis, but that's rarely. MIPO technique with a small incision, closed reduction with forceps, and this is how the postoperative wound looks like, and our osteosynthesis should look like that after using plates. So the same is shown here. So all approaches were mini-invasive, but first lateral plate was used for fixation, mini-invasive, then lateral, then the plate with plastic, bone plastic for fibula was used. So the main use for our plates is using plates closed for fractures that are articular, intra-articular, and close to the joint. Of course, plates can be used for open fractures as well. So that's why high quality debridement might signify, if we do that we can use the bone plate if you can cover soft tissues. The main trend in metaphyseal, epiphyseal, close to joint fractures is using two plates, and also in situations when our bone defects are located in a metaphyseal area. So two plates that you can see in a defect of a tibia, some two plates for the shoulder, for the arm, and two plates also for the defect of femur. Technical aspects of osteosynthesis. What we use is quite small provisional fixators. And for provisional fixators, little, small plates with small screws, 2.4, 2.7 are used. And it gives the opportunity after good reduction, we can do the fixation of the fracture with a small plate in order to be able to use the big plate later. And of such manipulation, the small plate is removed. Sometimes some surgeons might keep it for a year. It's up to you. And there are lots of special plates for specific orthopedic surgeries, like, for example, for arthrodesis of the ankle joint, anterior, medial, lateral. In this case, on an X-ray, you can see the posterior plate for the arthrodesis of this ankle joint. The same for the hand, and you can see this design of the plate. There are some round plates, so there are lots of opportunities depending on what you can do as a surgeon, and also depends on what your healthcare facility can provide for you. And you can see quite beautiful plates. The last one was pictured in the US. Very often the hip replacement specialists use Zimmer plates. in our market. They are provided by Zimmer, but there are other companies that provides them with polyaxial stability. And here we can see both for the proximal and the distal ends. So we can use those plates in case of fractures, periprothesis, and for hip replacement of the femur and the knee. And periprothesis fractures with special tops. Professor Belinsky would cry looking at those because they look like his plates, but they are quite widely used in periprothesis fractures. Motomat plates are also known. I don't know what's the correct pronunciation. Joel Metamoto, special plates for osteosynthesis of pelvic bones and acetabulum. Also, they are widely used globally. Also, there's quite interesting plates developed recently for fractures of acetabulum, but this is for specialists who are into those specific surgery. They're very delicate, nice plates. But unfortunately, in our country, we are not using them now because of the war. I think I personally did not use such plates, although I had them in my arms and I was planning to use them. And such interesting plates for osteosynthesis of the patella, and they can look not just like a star, different other forms of plates are used for multi-fragmented fractures of patella. I used to work in one clinic. For some reason, they didn't do the osteosynthesis of the ribs, but there are some special sets and plates to do this type of osteosynthesis in floating fractures of the ribs. You can use those as well. And the most important thing I wanted to say, after you have done the osteosynthesis of the near articular fracture, you need to confirm your quality result in terms of reduction and fixation with a CT. In 2012, I've been to the US for training, and we were doing the acetabulum and very complicated fracture. So we put the spring plates, and next day we did the CT, and we saw that the spring plates have gone 4 millimeters into the articular lip, and that made us take the patient back to the OR and redo osteosynthesis because the insurance company might not pay for this operation. So we had to put it NU. So soon insurance companies are going to do the same in Ukraine, so think about that. This is intramedulla fixators. So the main fixators used for femur used usually. So you put big screws, 14 and 12 for the tibia, and so special screws, ellipsoid, and also special other parts. Professor Rublyanik used to do that as well, but for some reason in our country, people got not interested, but abroad it is widely used. And of course, treatment of open fractures. So you can see 3 open fractures, so femur and 2 fractures of the tibia. Fixation was done with intramedulla screws. So the physial fractures and the open fracture lets you do this type of osteosynthesis. So using these screws is being widely used because of their structure. The new screws have more opening, and you can see the special like advanced top on the distal part that allows to adequately fix this pin. and special ones to do the proximal fixation of humerus, also proximal femoral plates, not plates, but pins, and the augmentation of the area is possible when the femoral neck is fractured, when osteoporosis does not allow us to adequately do the fixation. So the ability to do augmentation using special 3-calcium phosphate is used. We make our osteosynthesis is more stable in our geriatric patients and elderly patients. An interesting method is also when on top of our osteosynthesis in rotation instability, we add monocortical plate. Also is one of the options to stop this rotation movement that still is present in this patient. And also different types of screws and little plates for additional fixation of low or high physical fractures. Again, adding bicortical or monocortical plates in patients with intramedullary osteosynthesis on big defects. That's where pin is like a pencil in a glass. It's there. It looks like it fixes something. So it occupies the internal space of the defect, and it allows us later on to use less bone plastic. But this fixation is not stable. And if it's not stable, there's not going to be union. So you can see the posterior axis and long metaphyseal plate is used. So that's what was used for this patient. So there is union for 2 years, adequate healing in that patient. He is walking. And this is an example of using medial plate, the second plate, for fixation of the pin. When we can see on a big defect, as we can see, when it's not enough, so the ability to use medial plate to increase the stability of the osteosynthesis. So the same on humeral bone, big defect, bone plasty was done, but we know that on such a big defect, usually union is not going to happen on the pin, so we need to increase the stability. How? So increase the diameter of the pin, but not too much. Or we can add such a plate in this case. And one of the tendencies, I don't like it, to tell you the truth, it's my personal opinion. So it's introducing the pin under the knee in tibial fractures and allows us not to bend the knee. So to use that method for higher fractures, so it gives us a better point of insertion, and we don't need to bend the knee all the time in order to do the adequate X-ray control. So the majority patients with this type of fracture, they use subpatellar access. Once again, please read instructional labels for each pin. So this is from one of the companies. So everything looks the same, but 6 degrees for flexion and a different point of insertion. So if you use this one from the incorrect point of insertion, although the names is the same, then you might use malunion. So you have to read the label for the specific pin. You really need to know specifically the point of insertion. That's important. And the telescopic pins, and you can see elongations. You can do elongation with magnets. The pin itself is about $20,000, and this magnet system also is about $17,000 additionally on top of that. So X-ray shows the plate and there are other options to do this osteosynthesis without the guiding plate, but they are rarely used in leading clinics in femoral defects and tibial defects. Thus, you all know that there are lots of methods of osteosynthesis. With each year, the number of them is increasing, but you always have to remember about the main and basic treatment principles that you always have to remember with any method. So you have to be cautious with soft tissues, functional reduction of fragments, stable fixation, and early function of an extremity. Thank you for your attention. Thank you so much, dear Petro Vitalich, for this wonderful presentation. I think maybe there might be some questions. Most welcome, Professor Zazirny. Dear Petro Mikhailovich, thank you for this wonderful presentation. The last pin, the question, do you have a more detailed information how often they are used in malunion or lack of union? Because what I saw about those pins, why they are used when the patient is trophic, when the extremity is not well. So these pins are used to elongate the extremity. So I asked my colleagues how often do they use them in trauma, injury, gunshot wounds. I didn't get the detailed answer. Do you have information how often that is used in cases of our patients?
Unfortunately, in our conditions, it is not being used. Yes, abroad. In terms of gunshot wounds, they do not have a lot of gunshot wounds. And when our gunshot wounds patients into other countries do it because it costs a lot, it's an expensive technology. And also there are special indications regarding the usage of this approach. So defects less than 7 centimeters. And defects less than 7 centimeters might be also, we may apply different technologies and maybe the outcome is going to be even better. So mainly it is being used to prolongate the limbs, not only among pediatric population, also among adolescents, and also, as you have correctly mentioned, when there are hypertrophic malunions. The segmented resection is being performed and then elongation according to the Elizarov technique. It is being done. In terms of the gunshot wounds, I wanted us to have this technology. I have talked with people that actually produce these devices, and they have told us that, sorry, that's an expensive technology, and we are not going to be able to share the technology. That was the official answer which I got. Okay, thank you. I may just add a bit. Our colleague from our department, there is Professor Tower, and he was visiting our Association of Traumatology and Osteosynthesis in 2020. And Professor Tower visited physically from München, Kiev, and they have the biggest possible practice regarding the elongation of the limbs using telescopic pins. And this is just an orthopedic issue. At this moment of time, in case we are going to use these pins to treat the gunshot wounds, we might be the pioneers of the worldwide level. Thank you. Yes, the next question, please. Thanks so much for this lecture. You have presented the clinical case of floating fractures of ribs and osteosynthesis. No, there was not such a case. There was just a picture. Oh, sorry. I was unable to find a good X-ray in order to show this whole case. But yes, I have made this osteosynthesis. So based on your clinical experience, we do understand that floating fractures, they are going to be associated with mediastinum, organs damage, or with other complications like pulmonitis. When do you recommend to perform osteosynthesis? And the second question, do all ribs which were included in the complex needs to be osteosynthesized? No, not all ribs. One in one it might be done, one after another one. When? Which day? I cannot tell you. I do not have huge experience with that. I had just a couple of cases where I have done it myself. What I have in the US clinics, it is also being done really randomly, really rare. I have seen that being performed on 5th and not 7th day, but that's my personal experience. Taking into the account the dynamic function of the chest, we do understand that the movement is going to be there. Do you recommend to get rid of the plates here in 2 years or here? That's a complicated question. Why it is a complicated question? I do not recommend overall for my patients to excise correctly implanted fixators. I do not recommend that. But right now, war is happening, and everything that we do, it usually happens with infections or with some kind of hidden infections. In those case scenarios, according to my opinion, we need to excise those fixators. Talking about fixators in the chest, I do believe that this is not a serious question to address. First of all, we need to preserve and to save the life. And then whether he wants to, whether he does not want to excise them, it depends on the decision. Yeah, this question requires to be further investigated. Please, Professor, the owner of the conference. I'm not an owner of the conference. So, Petro, thanks so much for this great talk. Thanks for this lecture. There is such question. There are a lot of wounded with the wounds in the... So, approach to arthrodesis, or do you preserve the knee joint and to perform the osteosynthesis with a plastic approach, or you need to excise those fragments in case they're small? And what kind of approach, according to your opinion, we may perform the arthrodesis of knee joint? We work daily and we think about it. At this moment of time, I have 2 patients who have arthrodesis of the knee joints, and I constantly want to make it in a following way in order to preserve the most, and for our surgeons to preserve the zone of the knee or of the pelvic joint. But further on, there is a question. There is a question regarding what kind of opportunities do we have? And we have 2 opportunities, 2 possibilities. Whether we perform osteosynthesis, adequate osteosynthesis. But in order to do that, we need to preserve the surfaces of the joint. Or we perform arthrodesis or endoprothesis. Endoprothesis, in most of the cases, is being performed in those cases when we have some defects of the knee joint. And in case there is a defect of the knee joint, then it means that we need to use modular prosthesis. And in case we need to use modular prosthesis, connected prosthesis, binded prosthesis, and to have from the young age binded or connected prosthesis, that means that he to prosthesis, whatever you may name it. And it might be used only for those patients which are elderly, which are not going to have a long-term lifespan after the surgery. So on daily basis, I get back to the opinion that we need to perform arthrodesis. And at this moment of time, that's what we perform and that's what we do. Talking about the pelvic, the situation is a little bit different. I would like to pay attention to an issue which is called trauma energy being transmitted from the bullet to the fragments, and that's the main opportunity for us to perform of surgical interventions. In the prosthesis, for example, in case the energy of the trauma was have damaged ligaments, or we have severely injured soft tissues, we need to think carefully, how do we establish our prosthesis? When we have minimal energy, gunshot wound is not huge enough, the bullet is inside the wound, when our bone basically caught the bullet, then we might have an adequate endoprothesis. But what are the criteria regarding this energy in the trauma? They might be the same according to the size of the wound, according to the size of the fragments. It might be the same, but that's a rather individual and hard to evaluate and to assess approach. It's hard to do it adequately because somebody is thinking about endoprothesis, somebody else is thinking about arthrodesis. So it's hard to tell. Where is the truth? Maybe we will find out in 5-10 years when we are going to have negative outcomes from one or another. Thanks so much. Opinion that it depends on the time which went from the trauma. We should not establish endoprothesis in acute or subacute period of time. We need to have some kind of formation even of those parts of the joint which were left, and then we are going to have delayed osteosynthesis. We might understand better, and then we understand whether there is a need of substitution of those joint surfaces. So that might be the best approach. Dear Petro, I have a question, this kind of question. How are complications after performing the internal osteosynthesis? I mean, delayed complications, 8, 10, and more months. And what was your approach in those cases? So we had this kind of complications, and it's a pity to say, but they're going to happen. And in 7, 8 months, in case we are going to do everything correctly, we are going to have the formation of the bone, and we have the function of the limb, and that is extremely important. For example, I have a patient day before yesterday, which was operated a year ago. Everything was fine. He moves, he walks. Everything was formation has performed, but there is a complication. There is a fistula in the place of the surgery. So now we have taken the intramedulla pin away, we have excised it, and we have performed the surgery, the secondary surgery. These kind of complications, they are going to happen. And that's why I say that in those cases, we need to excise metal instructions in time. We need to excise them in time. In case it's military personnel, in case there was an infection, in case it is a gunshot wound, then according to my opinion, in a year and a half, it is allowed to get rid of those implants in case there is an adequate formation of the bone structures. Thank you. That's a rather important question, because in fact, really, those constructions, and especially those constructions which are used right now, not in a specialized institutions, but overall which are being used, they needed to be excised in most of the cases, taking into the account our current environment. In case of the civilian trauma, I do not agree with it. Yes, especially right now. Right now, taking into the account, and Petro works with patients which have suffered because of the war, conflict, and aggression. And I have a question regarding to excise it. For this complication, but do we excise them before the complication occurs? I do believe that the standard approach is the following. We excise it in 1.5 years after fixator being applied. So before 1.5 years, there is no need to think about the need to excise those metallic constructions. In a year and a half, yes, really, it might be highlighted. This question might be raised among those patients which had gunshot wounds which were compromised in terms of the infectious, some kind of infectious agents which they had previously. So, for example, this patient who had intramedulla pin, we have taken the culture from him and he had Klebsiella revealed in 1 year after the trauma. There was no issue at all regarding information for 1 year, no issue at all. But, he got cold, or yeah, he was fishing, something like that, and he got this. Thank you. Dear colleagues, I'm going to tell you that we may listen to Petrov for a long period of time, and I would listen to him, but we have agenda, and there is something to be mentioned, and also to listen to a clever person who is playing a leading role in osteosynthesis. We may do it for a long period of time. So great talk, Petrov. Thanks so much. Thanks so much for your attention. And right now, in case it is allowed, yes, we are going to move further.
And its role in trauma medicine. Presenter Christopher Hirsch, please.
Good afternoon, colleagues. Dear Chairman, dear ladies and gentlemen, first of all, I would like to thank you, the Ukrainian Trauma Association, and especially Volodymyr Kovalchuk, for the invitation and the opportunity to speak at this important conference. I'm happy to see that you assembled so many national experts of the Ukraine who are doing an amazing job with passion and endurance for medical care under these special conditions and with limited resources in the field. With my lecture, I would like to present the possibilities of plastic surgery and its role in and for trauma medicine, based on my experience as a discipline that can achieve a lot, although the required resources and the training level for plastic surgery 2.0 are not insignificant in all these cases and strategies that I'm showing to you. You might laugh, but there is one image in particular that is widely associated with plastic surgery. It's buffed up dingy lips, petrified, paralyzed facial expressions, pimped up C-list celebrities, and invisible significance for medicine, for trauma medicine. But this is only a very limited part of the core discipline of plastic surgery, as it's difficult to show bloody images in media. Although there's a connection between the classical image of plastic surgery in media and its role for trauma medicine, it's not obviously seen even in these two pictures. Where's the connection between plastic surgery in the field and plastic surgery as it's very popular? But plastic surgery can have a significant impact far from visible advertising. The aim of my presentation is to elucidate the role of plastic surgery in trauma medicine, its unique armamentarium and its impact on outcome, especially on form, function, quality of life, integrity and body image, as well as aesthetics. Plastic surgery is a pretty old discipline that can be traced back to its first descriptions in 800 to 600 before Christ in India to reconstruct the nose, which was cut off for punishment. Plastic surgery has its rise and falls in the Middle Ages, in the Church and the Inquisition, when plastic surgery was supposed opposing against what has been given by God. The Renaissance of plastic surgery was in Europe at the University of Bologna, and the name Tagliacozzi is one of the names that reinvented plastic surgery. Plastic surgery and its main medical field has repetitively experiences a sad but necessary renaissance in meaning again and again in connection with wars and the serious injuries like the First World War, where patients had serious surgery for gunshot and shrapnel wounds, especially to the face. And what you see on the right side is just a drawing and a model of what has been invented during the First World War for surgery to cover the defects in the face. What are plastic surgeons finally doing? Plastic surgeons aim to replace like with like, as the New Zealand-born British surgeon Sir Harrod Gillis once stated as a very helpful state. We follow and stick to symmetry and ideal proportions as represented by the Vitruvian human Da Vinci. We are not using need, but doing similar alterations to the healthy tissue using expansions devices, free flaps, or fat grafting with several components to improve vascularity and soft tissue quality. We love to treat wound defects, shape tissue, and improving form, body image, and integrity in form and function. So trauma, what's next? There is a certain plastic surgeon perspective that I like to summarize for you. Plastic surgeons are not commonly involved in the primary survey in the trauma bay unit. Major amputations to evaluate replantation service are rather an exception. Nevertheless, plastic surgeons who are involved in trauma service have certain issues they focus on during evaluation and scheduling the treatment and what is concerning us. It's the timing of being involved in the trauma bay and intraoperative consultations, hopefully not at the night, to have a service, be present. Extent of tissue damage, the type of involved tissue, infection, contamination is a very important part. Perfusion control, the timing, the demarcation of tissue or early coverage, secondary procedures, and the use of flaps and an innovative armamentarium that we can offer for our patients. In the next part of my presentation, I'd like to address several components of plastic surgery 2.0, which are meant to improve the outcome based on its special armamentarium, its form, surface, and contour to have appropriated integrity, its the choice of tissue to replace like with like, its decisive selection of the donor size, harm the patient. It's compound flaps to address all tissue types that are affected. Lymphatics in order to address post-traumatic lymphedema. It's a certain field of stem prophysis management with several techniques that we can offer. Peripheral nerve surgery as a secondary procedure, the vascularization status, infection control with innovative techniques, secondary refinements on techniques from aesthetic surgery as well as timing, which is decisive. Infection control is a significant success for plastic surgery. The displayed series here in the image summarized the last 5 Ukrainian citizens that we treated in Frankfurt at my hospital, and next to the need of plastic surgery coverage and tissue augmentation by means of soft tissue or bone flaps for long, they all are defined by one severe common problem: severe multi-resistant infection and colonization in all these 5 patients. The aims of infection control are to reduce the spectrum and bacteria count, to save soft tissue coverage and bone stabilization. What can we do? Anti-infective strategies and therapies are one of the very good techniques that we're using is intense local therapy with negative peri-wound therapy and installation in order to sometimes reduce systemic antibiotics or not to resign on several reserve antibiotics. It's timing duration of antibiotics more than 6 weeks and the optimization of vascularity, which can improve local immunocompetence by free flaps, loops, or vascularized transplants. This is a case of a severe lower extremity trauma which delayed soft tissue management. You see, after 30 days there was still no coverage of the bone, the plating, and the whole situation. And after delayed transfer, we performed an immediate free flap to cover the defect, the plate, but you see that there are some issues with the free flap. It received diminished perfusion, it required several steps of revision, and finally it failed, and even the local vascularity and immunocompetence of the flap was not enough to achieve appropriate results. So the flap failed, we had to remove it, it was necrotic. Also, free flaps have the strength to improve both vascularity and improve local immunocompetence in wounds with residual contamination. This case with a free flap loss shows the limitations, which require further anti-infective and early anti-infective strategies in the contaminated trauma wound. So we had to restart with a new flap. The next case is meant to demonstrate the efficiency of local negative pressure wound therapy in combination with installation therapy with anti-infective solutions. This patient suffered a severe polytrauma and was meant having developed a pressure sore during hospital stay with a non-healing scar and multi-resistant germs. Plastic surgery was asked if there is anything to do for the patient who was unable to be reintegrated into his workplace. After excision with biopsies of this wound, shown you here, we performed 2 cycles of negative pressure wound therapy in combination with installation with an anti-infective solution, resulting in a clean wound bed. This defect was covered very easy with a classical plastic surgery technique with a rotational flap, in this case with a back cut. Very uneventful healing. This was a combination of success of this anti-infective strategy with installation therapy using anti-infective solution and the ideal vascularity of a free flap. Plastic surgery provides concepts and techniques in line with vascular surgery to improve the vascularity in the traumatized, vessel-depleted extremity. These concepts involve various anastomosis techniques to bypass, as shown here on the right side, in the sketches, improving the vascularity of the extremity in 1, 2, and 3, or even the flap alone. When bypass surgery is not suitable or necessary, AV loops are an alternative to improve reconstructive vascularity. What are AV loops? So these are kind of neo-recipient vessels that are generated distant to the original site. It's used by local tissue engineering, 1 versus 2-step reconstruction in a course of 10 days to improve and stabilize the perfusion. Issues are size mismatch of the new recipient vessels to the areas that you need. Anticoagulation has to be increased and might trigger bleeding, and the placement and prevention of kinking of the whole AV loop is a necessary step. In this video, the AV loop is placed to the X side to increase the length of the thoracodorsal vessels for an area of the buttock region where recipient vessels may be limited and have been limited in this case. In the videos, you see the pulsation of the loop after anastomosis, and therefore a division which is going to be followed as the arterial inflow and venous backflow axis. Modern plastic surgery techniques imply to use pliable and adjustable formable flaps who allow secondary thinning for contouring to be really functional reconstructions, so boots can be worn without limitations, as you see on the left side. In addition, several small split flaps as shown on the right side allow improved positioning in the middle and on the right side to resurface as one of the big flap piece. Plastic surgeons like to use smart donor sites for free flap. Plastic surgeons try to examine the patient to find smart donor sites. This patient with a lower extremity defect had been treated with bariatric surgery and lost a lot of weight. He was already scheduled for post-bariatric contouring abdominoplasty, so we decided just to reduce the abdomen to use the flap, an abdominoplasty flap, a low abdominal fasciocutaneous flap for extremity reconstruction, to combine both the post-bariatric surgery, the tightening surgery, and the reconstruction. And we use smart dissection techniques to preserve the nerves in the abdominal wall in order not to weaken this wall. So this is the final result. Plastic surgeons follow form, function, aesthetics, trying to replace like with like of soft tissue components. The variations are unique and very broad, so using several components and compound flaps with vascular connection to bring best tissue selection and shape for defect reconstruction, as a lympho-myofasciocutaneous flap including lymphatic tissue to prevent or treat lymphedema, split fasciocutaneous flaps to have a better arrangement of the flap, a second two-pile flap to reconstruct the fingertip, a combination of bone and soft tissue with the latissimus dorsi flap with scapular bone, or the fibular graft with a skin island. Another compound includes function, muscle function, nerve surgery. This is Ukrainian patient suffered from a loss of the palmar muscles and a defect due to the traumatic wound. We provided him with a free function muscle transfer with synchronous defect coverage. He left us weeks after consultation back to the Ukraine as he was happy with the result, making it impossible for me to provide you follow-up. The concept is really nice to be seen here in this situation. Another component to be included is lymphatic tissue to either prevent or treat secondary post-traumatic lymphedema. This is a patient, a burn, 25% burn, and required surgical eschlerotomy. He was first excised, then received split thickness skin grafting, was partially got lost with exposed tendons and joint. This was the reason why we scheduled him for a free flap. The idea was, as this patient nearly had lost all superficial and deep lymphatic vessels, to schedule him for a prophylactic therapeutic lymphofasciomyocutaneous compound flap. In order to achieve this idea, we made a multi-component flap for the multilocal functional defect. We used the latissimus dorsi, which is A, to serrations of the muscular serration, which is like B, the lymph node flap, which is C, and the skin island-based perforator flap, which is D. We published this, and here on the left you see the defect, and in the middle the flap again, and the inset on the right side of the flap, with the results, acute and long-term results without any onset of lymphedema, which was very nice for the patient. This patient, after severe degloving injury, who has been treated with split-thickness skin grafts, reduced pliability and a secondary lymphedema to the distal lower extremity. In the first step, the aim was to replace the skin grafts with pliable skin and a pre-expanded free flap, as you can see here. The flap and the first result. As expected, the lymphedema was not resolved, so we did vascularized lymph node flap based on the lateral thoracic artery, with anastomosis to the lower extremity. You're gonna see here the harvesting site on the left, the recipient site on the right, the flap with the lymphatic package, the whole flap as a conjoined flap, a compound flap, the ICG uptake to identify two lymph nodes to the flap to provide the inclusion and the final results. As the patient resolved step by step, the flap turned more pliable and we rescheduled her for thinning and reduction of the flap. We took a near-infrared video you see on the right side during the excision, which sees depot-wise injections around and uptake to the flap as proving the new direction of drainage. Plastic surgery techniques that are meant to improve the stump quality and function as a concept of contouring and amputation stump management. This patient here suffered from an emergency amputation, and after internal fixation and consultation with orthopedic technicians, the formed stump was regarded to be about 10 cm too short for optimal myoelectric prophysis supply. This is why we scheduled the patient for stump prolongation surgery with a free fibula with skin island and a split ALT for contouring. On the right you see the design of the fibula with skin island, the harvested graft, the ALT site, and the final result of contouring of this prolonged stump, and the final results after osteosynthesis. In the next step, the patient was scheduled for initial shaft and prophysis, and ortho technicians presented again the patient with requesting thinning and reshaping for shaft improvement and approved electrode signals, which we performed with classical plastic surgery techniques like liposuction, you see in the upper images, and reduction therapy with excellent results. This is the patient in the secondary rehab phase after contouring surgery and shaft. What else can you do with a free flap after partial amputation? This is a patient using a neurotized flap with sensory reinnervation, suitable for bouldering and free climbing after contouring. A very promising picture I received from the patient. Secondary refinements should be considered during initial surgery as well and may also include special stump management. This patient suffered from neuroma, exophyte, adherent central scarring, and thin soft tissue layer. After resection, an overlapping skin flap was planned, followed by fat grafting, lipofilling to improve the subcutaneous layer and the loading zone, as you see on the left and right side after 80 milliliters. This is another patient to demonstrate the possibilities of plastic surgery and amputation stump management. After a thigh amputation, the patient lost 60 kg of weight and suffered from skin excess of subcutaneous tissue, and an adherent central scar. She was scheduled for scalp contouring to reduce reduction plasty. You see in the middle the drawing on the right side. The same patient visited me again for further body contouring to her abdomen, so I was able to take photos of both her stump, the shaft on the left image, and in the middle the stump after reduction of the stump and the abdomen as a result of plastic surgery. Fasciocutaneous flaps have the huge advantage that they can easily be addressed by liposuction and contouring surgery to improve form, pliability, and thus function. You see a flap being treated with liposuction on the left with high definition, as the plastic surgeons like to address this way of defining contour, and in conjunction with reduction surgery on the right side of the image. Timing plastic surgery is a special issue and has a debate for 40 years now, since the Slovenian Marko Godina published the results on free flap loss and with easy late and very late reconstructions. These results have been revised by several studies now, especially since the use of negative pressure wound therapy has revolutionized sterile wound dressings, now being available in accordance with installation. Nevertheless, plastic surgeons regard negative pressure wound therapy somehow controversial, as some disciplines tend to use it too long without a clear plan for coverage. This is another option to augment soft tissue. This is a Ukrainian patient who suffered from the lack of soft tissue being scheduled for adjustment osteotomy. In order not to risk the complex osteosynthesis with exposed plating, we decided in a board meeting to start with a free flap and provide the orthopedic surgeon with improved augmented soft tissue with a free flap, as you can see on the right side, to prepare her for further osteotomy surgery. How to put all these techniques into daily routine of conceptual approaches. I recommend you to establish a board meeting on a weekly basis, analog to oncological meetings, to discuss your reconstructive cases and include the disciplines of trauma surgery, septic surgery, plastic surgery, radiology, and vascular surgery, internal medicine if required, neurology if required, technical orthopedics, rehab medicine, and so on, in order to get everybody together and discuss the patients, to achieve early involvement of all disciplines and having a room for open discussion. Your patients will be grateful for this communication tool. We published this in order to get all our experience together. So there are typical thought patterns between trauma and plastic surgery. Why are all these requirements and necessary? We do not need plastic surgeons. VAC, split thickness skin graft, and local flaps always work. Unreachable, plastic surgeons lost in liposuction Friday. Takeovers are delayed until secondary healing. Plastic surgeons prefer other surgeries, and reconstructive surgery is part of trauma surgery anyway. So try to overcome all these issues. Define your plastic surgeon as a partner in trauma medicine. Do SOPs, standardization. Define ways of communication. Imagine the role of soft tissue and perfusion from the very beginning. Focus on concepts, not only on flaps. Enable septic surgery competencies in plastic surgery. Build up a reconstructive microsurgical skills and competencies. And defining your resources you can have for plastic surgery. Thank you very much. Very many greetings from Frankfurt.
Useful presentation. Any question from the floor? Any question from the floor? Прошу.
Dear Professor, thank you for your presentation. It's a great results. The first question. According to the previous information, we know all chapters damage control surgery. Do you know right now a modern approach, especially damage control for recovering tissue or soft tissue damage during the battle conflicts? It's the first question. And the second one, according to the tactics or levels of evacuation, do you have any recommendation directly what we have to do according to these law, role 2, role 3, or role 4? Thank you.
Thank you very much for this important, which I mean, kind of addresses the limitations that I mentioned at the very beginning. Is the question of resources that plastic surgery and the ideal coverage always put into practice. So for damage control surgery, I mean, plastic surgery has just a limited role, as the resources in the setting of damage control usually don't allow the sufficient coverage in plastic surgery, independent of what technique. And also conferring to your second question, I mean, I'm not so much familiar how much experience and how much in reality you're using negative pressure wound therapy at the very beginning of damage control and the different roles. But I think in preparation of keeping the wound as clean as possible, having in mind that there might be a role for plastic surgery and reconstructive surgery at a very certain step, this could be an option, also adding this to an installation device to keep the wound clean. I don't know if you have this experience for your damage control situations in the field.
Є ще питання?
Any other questions?
Hello?
Professor Duncan.
Прекрасна
доповідь.
Wonderful presentation, dear Professor Christoph. My question is follows. The question is about non-traditional perfusion methods of free flaps, in particular with arteries arterialized through the venous vessel, the axial one. The arterial blood is directed through the venous axial vessel, and there are some reports that this flap is surviving. So arterial blood through the venous bed. So do you use such flaps, and what are the results if you do?
Mm-hmm. So thank you for this question. I think you're referring to this type of venous flaps that have been described, like from the forearm to, for example, to the coverage of small hand defects. I have just a little experience with them. I have done them like once or two times, more or less that like a backup option. But my experience is not so high for this type of flap. But I have some colleagues who have a high experience, and they are really happy with that. I think one of the limitations of these flaps is that at the very beginning, the venous flaps always look pretty ugly and not well perfused, which is often a limitation for the team to monitor them. And this might be a reason why so many surgeons are a little bit afraid of this appearance of the flap. They are not using them. But in the hand of people who are experienced to the setting of the venous flaps at the very beginning, it's very helpful. But my experience is a little bit limited with these flaps.
Thank you for your presentation, but also I have a question, one question. You are a plastic surgeon, or are you an orthopedic surgeon?
I'm a plastic surgeon.
And of course, we all use a VAC system. So if a person is hospitalized with wounds or open fractures, we all use VAC systems. So the majority of our orthopedics use them. So when is your time, that your time comes, in your opinion?
Yeah, that's a very good question. I mean, there are so many stories about the ideal time point and the ideal setting of reconstructive surgery. There are emergency-free flaps, which have been described like doing it immediately in the situation where you have exposed vessels, but this is a high demand for resource. You can keep the wound relatively clean or take some time for decontamination. The ideal time for extremity, for nerve, for like having exposed important structures is not having it exposed longer than 7 to 10 days. This would be the ideal setting from my perspective to cover it, because from my experience, then you have like a shift towards that there is an increase of the colonization again, even if you have a perfect setting of negative wound therapy and doing everything what you want. So like 7 to 10 days should be the perfect time frame for coverage, which I know is a pretty demanding or challenging situation in some circumstances.
The last question, according to the rules. When you decided to put in the reconstruction of the damaged nerve?
Can you repeat this question, please?
When exactly you decided to reconstruct if you have the patient with the damage of the nerve structure?
Right. Okay, got it. Thank you. So this is an important question. We had this discussion in the German-speaking society as well for a long period, because there have been pretty many challenging approaches to have like big nerves reconstructed in the immediate setting. And what is my personal experience and also the recommendation from our German-speaking society, that you have, if you have like small peripheral nerves, not the main nerves, small nerves should be, if possible, reconstructed immediately. And major nerves, where you need major nerve grafting, for example, they should be delayed in order to have a sufficient soft tissue coverage and vascularity, not to sacrifice any donor sites or donor nerves for a failed reconstruction. So we recommend to have it like delayed after 2 to 3 weeks if you have stabilized tissue around.
Thank you for the comprehensive answers. Тепер я скажу, що як уже сказав Микола Львович у своєму доповіді, програмній доповіді.
Mikola in his talk, and how it was already approved by our dear Roman. There is no work in our sphere, in our treatment, without the data capturing of what we are doing. That's why creation of a registry is extremely important at this moment of time. That's why Professor Burguka is going to tell us about next speaker. Next lecture is going to be by Professor Igor Zazirny, Register of a Trauma and the need to create a registry in our country. Please, we kindly invite next speaker. Good afternoon, dear colleagues. So first of all, right now, I would like to greet everybody with the Worldwide Trauma Day. Exactly today is the day when this Trauma Day is being celebrated according to the United Union organization, and it is rather symbolic that our conference happens today as well. In case we are going to take a look from the management perspective, control and capturing the data, that's the basics of prevention. So when we talk about trauma success treatment, the register of the trauma, data capturing of the trauma, that's the basis in order to have an improved quality of care. What is a registry? Registry is an information system or specialized data. Registry is a potential source of the part of the data which is needed to have a comprehensive surveillance regarding the trauma in the public health setting. As other registries, trauma registries is being used to capture, to save, and to obtain the data with etiological factors, demographics, diagnosis, treatment, and clinical outcomes among separate patients which correspond to certain criteria. Trauma registry is being used as basics to monitor and to evaluate the effectiveness of the treatment on the national level and the governmental level. Do we have legislative trauma registries? Yes, we have an order of the Cabinet of Ministers of Ukraine from 2012, number 546, where it is an approved position regarding the electronic patient registry. And based on this, we may create different kind of patient registries. Last year, I had 3 publications in Terra Medica journal regarding the endoprothesis registry. And basically these topics, endoprothesis and trauma registries, they are rather similar. So the first registries, they were created in Sweden as endoprothesis of knee joint registries. But then when I was that in the United States in 1969, the first registry was created in Illinois. And in 1971, there was the National Trauma Registry in Illinois state. And of this registry was there was a National Registry of Pediatric Trauma, and in 1988 there was a National Registry, Trauma Registry. And in 1990 there was a law regarding planning and development of the system of providing care in case of trauma, which is based on these registries. And in 1993 there was the overall national ban regarding the trauma. So based on what is created in different countries, there are different ways to manage this registry and different ways to register it. In Wales, England, UK, and Finland, the registries are based on the initiative of the MOH, and in others based on the associations of orthopedics. The main source of financing are the budget costs, and also some registries obtain additional costs to evaluate separate results. In UK, well, New Zealand, the financial resources are also added according to the tax from each implant. Regarding the institutions, in Australia, Denmark, New Zealand, Norway, and other countries, it is coordinated by the Department of Orthopedics and Traumatology, and in Canada, Italy, and Scotland, the institutions are being associated with the National Committee of Healthcare, and only in the UK and Wales, as the United Association, there is a private company which has a contract with the Department of MOH, with the Department of Healthcare, and it creates the registration of different kind of diseases. Each registry has a couple of operative committees with different responsibilities. In most of the cases, we talk about specialists from the scientific field in orthopedics, epidemiology, public health, statistical data, and administration of the clinics. Also, there are some registries, committees, which include different specialties, patients, and also the employees of the companies which produce implants. The goal of each registry of the trauma is to monitor and to evaluate, to have a public health evaluation of the trauma and evaluation of the trauma influence on the well-being of the population. The main advantages of the trauma registries are the main goal and the main focus is being on those traumas which are life-threatening and which are influencing the limbs, the extremities. We need to collect a huge amount of data about separate patients, to have data capture and analysis and distribution of the data, also to evaluate the costs which are being paid by the institutions, and also potential regarding the evaluation of the potential regarding the outcome. So what are the drawbacks of the registry, trauma registry? Absence of standardized approach to huge trauma. Registries require a lot of resources. Not all data is being captured, and that's why registries do not have whole data. It was already mentioned by my colleague from the Institute of Traumatology about trauma centers. Trauma center, it should be a clinic which is able, it's not a department, it's a clinic which is able to provide specialized healthcare services to those patients which had trauma incidents. It is proven that specially prepared, specially trained personnel might decrease validity among the patients. Trauma registries are being used to monitor and evaluate the care of the trauma on institutional, regional, and national levels, to evaluate the frequency and reasons behind the trauma, to evaluate the objective and evaluated subjective data regarding the treatment, also to evaluate the annual multi-hospital registries. They appear in those registries where the emergency medical service is being guided by trauma systems. There are a couple of factors which are barriers to an information data capturing process. First of all, the participation is usually happening only in the huge traumatological centers, trauma centers, and there is not whole information which is being captured. Second of all, in those registries, the information is not being captured on the pre-hospital stage and on the pre-hospital mortality. That's why we constantly need to stimulate registries with different organs in order to have more full registries. Right now, a couple of words taken into the account exact registries. What registries provide us and what do they give us? For example, registries which are coming from Germany. Trauma registries are existing from 1993. And there is a separate institution which is working with the German Trauma Association. So these registries provide us this kind of information. For example, what is the level of the hospital in which more or less information is being provided? What kind of level of care was provided on the pre-hospital stage? For example, over here, we might see the data from the German registries, whether was used during the transportation of the patient to the inpatient facility. What is the volume of infusion which was being used during transportation? Whether the blood transfusion was being performed, what is the volume of the blood transfusion and how massive or major the blood transfusion was there? How often CT was used on early stages? Whether CT of the whole body was in Germany did not start a long period of time ago. It has started in 2002. So the regular collection of the structured data allows us to evaluate the trends and changes which are being evaluated often subjectively. German registries is working for more than 20 years, almost 30 years. And despite the fact that the results should be interpreted in the increased amount of hospitals which are being evaluated as trauma centers, there are some trends which allow us to evaluate the efficacy of treatment providing care to trauma patients. Let's move to the Swedish registry. Swedish registry started the data in 2007 and was being developed in 2007, and then it started to operate from 2010. And all of those registries, they provide us information about each localization. On this slide, you see the publications which are associated with the femur trauma, with distal apophysis of the radial bone, clavicular fractures, and so on. And there are a couple of types of the treatment, when and what is needed to be done. Osteosynthesis with 2 screws, osteosynthesis with hip compression screw, with using separate nails. Operations for hip fractures, for example, to use the total prosthesis or polar prosthesis. National registration of hip fractures in Sweden gives an answer. Before 60 years, osteosynthesis. After 60 years, total endoprothesis. And also, total endoprothesis of the joint is divided into 2 parts. Active patient endoprothesis and those patients which have some kind of mental illnesses or some kind of physical diseases. They also need unipolar prosthesis. So we divide patients in those who are moving and those who are not moving. There is some kind of differential approach because it also saves all costs which are being used in the government. What does Swedish registry give us? It gives us more than 80% of proximal part of femur fractures. These are about 80 patients. 80% of those patients, these are females. More than 50% they live alone, and trauma among this kind of, and hip fracture among this kind of patients, it creates a huge burden for economical and also for healthcare systems in the country. We also may evaluate the mean hospital time. 10 days is the mean hospital time among the patients which have hip fracture. And despite the appropriate, we do understand that rehabilitation to the first initial state happens only in 50% of the cases, and other patients are not rehabilitated enough. And this is an opportunity for the government to improve the quality of provided services and management. In case we talk about fractures, around 25%. These are trochanteric two fragments fractures, 35% displaced cervical fractures, and also 15% that's without the displacement fractures. What kind of 10% that's gamma nails, dynamic screws, 35%, and only 10% total prosthesis, and unipolar endoprothesis more than 25%. At this slide, you may see the results in case of the hip fracture, hip caput fracture. You may see total hip arthroplasty 15%, 65% hemi-or-bipolar arthroplasty, and 2 screws or pins 20%. And the question of efficacy, usage of the costs, as it was mentioned by Margaret Thatcher, the costs of those who pay taxes, taxpayers. A rather interesting slide. Before the fracture, 50% of the patients which had fractures, femur fractures, they were walking alone. But after the fracture and after successful treatment, they may walk alone without any aid only in 30% of the cases. Before the fracture, 5 of them were living inside the bed and were not walking. Then after the fracture, they walk alone and they leave and do not leave the bed. So we do observe what kind of situation happens inside the healthcare system, and that's why we need registries. The next results of the registry is how patients are staying inside the hospital. In Sweden, patients with fractures, they do stay in the hospital before the surgery for at least 1 day. Most of the patients have been having an intervention during the day. Then the registries provide us information according to the classification what type of fractures have happened. For example, on A2, A1, or A3, 31, A3, trochanteric fracture, and what kind of approaches were used to treat these patients. The next slide, that's the comparison among the mortality among male and female patients. This is also information which is coming from the registry in order for us to understand what we are going to do and what we are going to obtain as a result of our treatment. And you see that patients after 60, most of them are patients which died during the first year. And in case these are the patients above 80, then there is a gap which is becoming even bigger. Data from the United States of America regarding the prosthesis and total prosthesis, THA. And it is mentioned in case of the hip fracture, in most of the cases, we have hemiarthroplasty. Unipolar hemiarthroplastic, not a total hip fracture replacement. Norwegian registry. We have an increased amount of fractures after 70 years old patients. So this is the group which we need to prepare in order to treat them. And in case we are going to evaluate the type of the fracture, we do observe that displaced femoral neck fractures, it's not a huge percentage, but most of the fractures are trochanteric fractures. And approaches regarding the treatment in this situation. Not a lot of cases of a total prosthesis, but most endoprothesis. In most of the cases, these are osteosynthesis approaches. In case we compare Norwegian and Ukrainian population, according to their registry, then in case we talk about the hip neck fractures, that's 1 up to 9 in case we talk about correlation of the populations. 1 to 9. In case we evaluate, Ukraine should perform in 1 year more than 6,000 of primary interventions and more than 1,000 of secondary interventions. This is something which we are going to obtain from the national registries. Australian registry from the South Australia state. Type of fractures and type of osteosynthesis were used and which were performed, and you may see that most of this management in case of the proximal part of the hip fractures, that's DHS or intramedullary nail, and total endoprothesis 8.9%. Everything else, these are different approaches regarding the treatment, cheaper approaches because it's the costs of taxpayers. And interesting data, what happens and when happens with patients. Hospitalization in 2.3 days. Huge state. State has more square meters than Ukraine, and population is being distributed. While patient is going to call to the hospital, while helicopter is going to take him or her, while he's being hospitalized, it takes some time compared with other countries. Day of the surgery, it's more than 1 day, that's 1.5 days. And patient stays in the in-hospital facility for at least 12 days. This information is also interesting from the registry of Australia. Time of intervention, 50% of patients are getting the intervention from 9 to 15, and 25% of surgeries are being performed from 17 to 24. But around 5% of surgeries are being performed during night period of time from 12 p.m. from 12 a.m. to 9 a.m. Wait when something extraordinary is going to happen. Patients get their services immediately during the night. There is a great rule. There should be not two sons among those who are delivering. So the same regarding the trauma patients. During the first day, all services and all care is needed to be provided. Spanish registry, Spanish hip patients, 42%. These are the which have aged from 85 to 94 years, and these are female patients. In case we talk about in case we talk about the approaches regarding the treatment, 60% of those patients, these are the patients which have internal fixation. These are not some kind of other more expensive approaches. The mean hospital stay is 6 days. UK registry. It is being registered by the National Institute of Health, NICE. 62% of the patients, they are getting the surgery during the first or second day of hospitalization. But there is analysis. What does it provide? There are some hospitals which delay the surgery, and they show that the amount of surgeries during the first day is 14%. And this is the topic when all hospitals are going to talk about it on the national healthcare. 3/4 of the patients, they were mobilized after the first day of the surgery, but 11% of the cases, they have achieved it in less than half of the cases. Most of the patients are being evaluated regarding the presence of osteoporosis. They have osteometry, and they have prescription of osteoporotic treatment. These are the data from the registry.
And on this slide, you can see data that are combined from different registries, Sweden, Scotland, Denmark, so on and so forth. And main methods used to treat proximal femur treatment is nails or monolateral, that in the majority of cases treatment is done by the team of doctors, orthopedics, physiotherapists, gerontologists, pharmacologists. Pre-operative peripheral nerve block is done to 100%. According to operation, and removing urinary bladder catheter, day 001. Also, delirium is controlled and monitored, and 97% of patients receive anti-osteoporotic drugs. Okay, I found some data about African countries like Botswana, because with European countries, we know. And the GDP for Botswana, by the way, is $2,000 more than per capita, is more than in Ukraine. And they have more patients with age-related femur fractures. So they compare their data with adjacent other countries. So these are the data for Europe and Africa. So there is increase after 50 years. So there is some social and medical problem in the society. So estimated total number of hip and major osteoporotic fractures in men and women aged 50 and older is projected to be quite high. So Botswana data on this slide, increase in hip fracture for men and women compared to 2020. In the year 2050, they expect to have much more. Saudi Arabia also provides data from Persian Gulf countries, and also significant increase. Also, they do their monitoring. Also, they can see in elder patients, and when they first present, they do densitometry, osteoporotic drugs. And next is Swedish registry data. You can see causes leading to that are relevant for treatment diabetes, osteoporosis, and 1997 and 2007 there is increase. Danish registry also, they expect a significant increase in hip fracture, especially in females, and there is increase, as they've estimated, the increase is going to be until, according to their estimates, until 2040. So they used to have 2 fractures per 10,000 population, but 30 years later, it's 10 per 10,000 population. So there is an increase in patients with fractures, and there is increased burden to healthcare system. The registry, Danish registry, shows what kind of types of treatment used. It's screws, parallel, intramedular nails, and arthroplasty. And in femur, neck, and trochanter fractures. So the registry also shows complications, and we can understand which hospital gives more complications and what methods of treatment are associated with more complications. On the left, internal fixation, right one, and the prosthesis. The middle one is internal nails. So if we're talking about the replacement, because total and prosthesis for femoral neck fracture. So in Sweden, it's 8%, Norway 8%, Canada 4%, Australia 2.7%, although it's a very rich country. They do a lot of hip replacement, both for knee and for hip, much more compared to other countries. So 500,000 of such operations they do annually. Is twice less than Ukraine. It's a national system funded by the state. Only 1% of patients hip replacement for neck fracture. So registries are really important for us to understand what's happening when such errors happen, what are the them in order to plan how to decrease them. So the likelihood of femur fracture population 50 years of age and older. So northern countries have more fractures. In place of Ukraine, 3% of men have femur fracture, and almost 6% of women get hip fracture. So we have to be ready to be able to treat all that. So clinical data provided by the registries play a big role in evidence-based medicine. Registries also impact the management and effect of the whole healthcare system. We have all the grounds in order to start to create trauma registry in Ukraine. We just need a will for that, participation of the Ministry of Health, but also participation of the national associations of traumatologists. Thank you for your attention. Thank you for this informative presentation. So, questions? I used to have a discussion with orthopedic institute specialists with regards to prosthesis, like one-pole prosthesis, and there was a thought that it's not correct to use one-pole prosthesis, but it looks like the whole world is using that. It's not going to abandon that. My question is, so what's your attitude to one-pole prosthesis, and do you do that in femur neck fractures? What are the results, and what's your further intentions? Thank you. Yes, we do use one-pole prosthesis with bipolar head in patients who mobile all their mobilities, but of family has to buy this prosthesis. We always with regards to what's the future for the patient and what are the tasks that we have for this patient. If the patient is physically active, and what I showed in the Swedish registry, if the patient at 90 years of age, if physically active, so total prosthesis is quite possible to be used. But if it's a limited mobility and the patient usually moves only within his apartment or her apartment, some mental disorders or physical limitations, so pieces with monolateral prosthesis with a long head. Okay, but what are the figures, the rates? So in your clinic, for example, what are the numbers, specific numbers? So maybe your registry. I didn't do my registry, but maybe 20%, and usually those are elderly prosthesis, one pole bipolar prosthesis, maybe 20% of all operations. Also, I need to mention, I had an experience in 2017. We had a patient IDP from Donetsk area, initially operated in Yanakiv at 40 years of age. So the US doctors operated on him there. His prosthesis was unstable. When I looked at that, I was surprised. It was one pole. I couldn't understand that American colleagues put this prosthesis at 40, but when we do revision, yes, one pole prosthesis, and we've replaced it with total. And when I talked to patients, he told me since the moment of surgery, and that was 1990 until 2014, he was absolutely okay. And only when he was displaced from Donetsk area to imagine was really difficult. So he was carrying a lot of things. So he felt like there was a problem. But since 97 to 2014, he was absolutely okay. When I looked at the literature, I found that if it's adolescents and young people who, due to different hormonal therapies, have a septic necrosis, it's one pole bipolar prosthesis that actually used in them to avoid complications of total prosthesis. Total one is usually after 40. Thank you. Well, maybe later on. All right. All right. Thank you for your patience.
Plastic principles and war injuries. Прошу, Marco Innocenti, we're waiting for your interesting lectures.
Ladies and gentlemen, good morning. I am Marco Innocenti. I am professor in plastic surgery at the University of Bologna, and I am very happy to join you in this meeting, although I really would like to be with you in person. But I hope that in the near future I will visit you in Odessa, as I did last August in Vinnytsia and Zhytomyr. So my topic is orthoplastic surgery, and possibly to see which are the connection between orthoplastic surgery and war injuries. So this is the definition given by ChatGPT. It's a specialty which is bridging the divide between orthopedics and plastic surgery. And this is a simple but good definition. I like more what the modern father of orthoplastic surgery, Scott Levin, defined orthoplastic surgery as that surgery where principle and practice of both specialties are applied to clinical problems simultaneously. And this is also a very good definition. So the ideal orthoplastic surgeon is a surgeon, a double board certificated surgeon. Me, I am both plastic surgeon and orthopedic surgeon. But if you don't have the double background, it's very good also to organize a multidisciplinary approach where orthopedic surgeon and plastic surgeon work together, speaking the same language. Which are the features of the orthoplastic surgeon? Well, the orthoplastic surgeon is expert in any type of osteosynthesis, is more used than the plastic surgeon to emergency procedure. The damage control is in the hands of the orthopedic surgeon, not the plastic surgeon usually. It has much more knowledge about prevention and treatment of infection compared to the plastic surgeon. He knows the function and the biomechanics, which is very important when you're planning any type of reconstruction. And on the other side, the plastic surgeon is more expert in the management of soft tissue injuries, has a very good knowledge of skin vascular networks, even the smallest one, the subdermal vascular network, which is nowadays very popular after the introduction of the perforated flap. It has usually a more atraumatic surgical technique, is expert in microsurgery, and last but not least, the plastic surgeon gives some attention to the cosmetic result, which is nowadays also important. We should remember that the first orthoplastic surgeon is the hand surgeon, because the hand surgeons are able to fix a bone, to repair a tendon, they can put prosthesis, do arthroscopy, but they are also experts in soft tissue coverage, microsurgery, repair, and replantation. So the hand surgeon can create a prototype of orthoplastic surgery. This is this famous sentence by Hippocrates. I think that it is very true. And actually, the first orthoplastic surgeons in the modern history are the war surgeons. I had the honor to visit the house of Nikolai Pirogov, who can be really considered one of the fathers of orthoplastic surgery. He did really amazing things, and he even cured in this painting. I was there with my Ukrainian friends, Sergei, and it was really a very interesting visit in this beautiful house. And you see how much it did for orthoplastic surgery. This type of amputation, the Pirogov amputation, is still used nowadays. So you have a very good history, about it. And this is one example of the cases that I did together with Sergei in Vinnytsia in this case. And this is a typical situation that you know much better than me. Due to logistic amputation are delayed many weeks, and this is very bad for infection, for the tissue, which are going to be like and infected. And you see, this is a case where we had to reconstruct the popliteal fossa here, and I used a very simple procedure. So we just dissected the calf here, and we moved proximally in order to close the defect, and then we did the amputation, shortening the bone. And you see here, nice result with a very simple procedure. So I think that in a war area, we must think simple and do things as simple as possible. We are in the operating room in Venezia. I was really impressed by the perseverance of the local surgeon and also the nurse who really did incredible just with very few instruments, but I was really impressed by the quality and the perseverance of this little girl. She was maybe 23, 24 years old, but she never gave up, and she was very helpful in the operating room. And we did, again, long-standing amputation. Then this is a big defect in the tibia with the necrotic bone. We did a free flap, an empty flap, and then removed the dead bone and replaced with the seminal spacer for subsequent reconstruction with the bone transplantation technique. This is another case. This is Jitomir, and you see that we did a very nice reconstruction of the forearm, doing a one-bone forearm using the vascularized fibula. Unfortunately, the surgery went really very well. I was very satisfied by the radiographical result, but a few days later, when I came back to, I was already came back to Italy, they called me and said that this poor guy had this very severe infection in the forearm, so he had to remove the vascularized fibula. So this is a very important point. It's completely useless to do sophisticated surgery if we cannot manage infection. And infection is the main issue in your hospital. There are multi-resistant bacteria. Most of them are gram-negative. The wards are overcrowded. It's impossible to make a wound dressing in a sterility environment. There are few antibiotics, a few disinfectants. So I think that this is a major issue, maybe even more important than surgery, because if you do very good surgery but you get infection, this is completely useless. And of course, this is the way the patient stay in the hospital. It's nice because they are friends, each other, they are good mood, but it's not the best for sterility. The Bible of open fracture of the lower limb. It has been done by the British plastic surgeons, and you can find here all the protocol to be applied. So if you want to get this publication, it will be very, very helpful. I show you an ideal case. This is a traffic accident, very similar to your blast injuries in the leg. You see the severe comminution of the leg, of the tibia, a big defect in the soft tissue. So there are a few key points to achieve a success in this case. First of all, we have to evaluate the injury. Then we have to do a radical debridement. Radical debridement is the most important step in any type of reconstruction, in this case, and temporary bone fixation. Then we have to do a second look and then plan a custom-made reconstructive project, which is good for any single patient. The goal of the reconstruction are restoration and improvement of blood supply, but also stable bone fixation and coverage with a vascularized soft tissue. And then there is an intense rehabilitation program. So this is the case. This is the fracture in the emergency room. This is the angiography, and you see that she had only the anterior tibial artery working. The posterior tibia was occluded and severed very proximally. And the foot was revascularized with a reverse flow from the anterior tibial artery. Then there is a scoring system, which is called Mangled Extremity Severity Scoring System. And this is the most used. There are some parameters to be considered. And as you can see, the score of Elena is about 6, so very close at the borderline between reconstruction and amputation. But this is a younger, and so she absolutely needs reconstruction. And this is the first step, the thing that you do in the emergency room. You must debride, you must remove all the necrotic and infected tissue very generously. Then we put some cement, antibiotic cement, and we stabilized with an external fixator. And already the situation improved. You see that the fragment now is well aligned, and there is no risk of further injuries of the vessel. Then we planned a custom-made reconstruction project after 2 days. So I wanted to use the latissimus dorsi, which is very good muscle, very good to cover open fracture, and I wanted to also the descending branch to the serratus anterior in order to reconstruct the posterior tibial artery. So with only 2 anastomosis, this is the flap, we restored the blood supply to the posterior tibial artery, and we covered the defect. And you see, this is only 5 days after the injury, and this is an optimal result. A very simple external fixator. Then she went for the final reconstruction 2 months later with an internal fixation, and this is the functional result of this patient, which has been very satisfactory for us. So teaching orthoplastic surgery is not easy. We have to share operative protocol. We have to share the know-how, more importantly. We have to teach plastic principle to orthopedic surgeon and reverse. We must be aware of the need of the other specialty. So we have to coordinate our action in order to have the best result. And last but not least, we must be able to have an objective evaluation of the results. To this educational program, you see some of the meetings that we had. This one was in Rizzoli, and we have one in a couple of months incoming. So one concept, the important concept, is the timing, and this is something that it would be of paramount importance if you can follow the right way also in Ukraine. I know that it is very difficult to come from the battlefield to the second row, the third row, and so on, but the timing is important. I show you a good case before, and now I show you a bad case. And again, they did the damage control, they repaired one vessel of the forearm, but then it was referred to our institution 3 months later, so very late. And you see how this patient entered our hospital. Very bad soft tissue, skin graft partially failed, most of them directly on the periosteum of the bone. There were tendon entrapment, lesion of the medial nerve with a palsy. You see, the orthopedic job was really horrible. They put internal fixation with the rod. They locked the elbow. They locked the wrist. So we had a lot of iatrogenic problems, more than the trauma maybe. So we had to reconstruct the olecranon, which was. We have to put an external fixator with the joint and do the osteosynthesis of the forearm. And then we reconstructed the medial nerve with a 10 centimeter nerve graft. And finally, during the same operation, the reconstruction of the soft tissue with an AT flap. And you see that the result is acceptable considering we are starting from. So we had the bone fusion. We had a acceptable motion of the elbow, and even some recovery of the thenar muscle. But what changed in 3 months? So if we had this patient immediately, we could do an accurate inventory of damaged tissue. We could map tendons and nerve in order to have an easier second stage reconstruction. We could repair all what is possible immediately. More important, we can prepare the patient for the reconstructive surgery. If we have this patient after 3 months, there is infection, there is a scar, there is of the anatomical line, there are malunion, non-union, and stiff joints. And also the receiving vessels are usually very bad. So timing is of paramount importance. Know-how in osteosynthesis is also crucial. I show you just some example of osteosynthesis. This has been published recently by myself in the Journal of Orthoplastic Surgery. So you see that there are many techniques that can be to good a transplanted fibula, for example. These are some examples. I go quickly. The other thing, particularly in a war environment, is to revisit conventional procedure, which can be very useful. For example, I remind you that one bone forearm is a very old but very valuable procedure in case of reconstruction of the. And the rationale is that the ulna makes the elbow, the joint of the elbow, the radius, make the joint of the wrist. So if we put a radius connected to the ulna, we may have we may salvage both the joint. The ideal position, because the only thing we miss is pronation and supination, and this is the ideal position, 30 degrees of pronation. I show you an example. This is a tumor with the resection of both forearm bones. We used a vascularized fibula, and we did a one bone forearm with a vascularized fibula. So the elbow is moved by the ulna and the wrist by the radius. And this is a very good result. The only price to pay is the loss of pronation and supination. This is another case. No pronation, no supination already, stiff joints, elbow almost locked, no extensor tendon. So also in this case, you see the X-ray. Instead of reconstructing the ulna, which was absolutely useless, we prefer to do a one bone forearm. And you see the procedure. And then the defect, and then a wrist fusion with a plate. And this is a conventional but very good procedure to be reminded. This is an evolution of the gastrocnemius flap that I published about 10 years ago. And also this procedure is easy to do and may be useful in your hands. We know that the medial gastro is very good for the coverage of the tibial tuberosity, but it's not good if you want to cover also the patellar region. So we can elevate a propeller flap based on a small perforator supplied by the medial sural artery, and this flap can rotate 360 degrees to cover either the patella or the proximal tibia. One example, the bone was completely infected and necrotic, so we removed the bone, we put an external semen spacer, and you see the flap. This one is the small perforator which supply the skin. This is the muscle, which is horizontal in the tibial tuberosity. And then the skin is used to cover the patella, as you can see here. This is the result with an external fixator. Then we replaced the semen spacer with a prosthesis, and this is the functional result of this patient, which was actually very good with a relatively simple procedure. Finally, I want to remind you also the utility of the spare parts. Sometimes it's not good to do complex reconstruction, but you can use what is still remaining after a trauma, or like in this case, the resection of the abdomen myosarcoma. So the resection involved the MP joint of 2 fingers. So instead of reconstructing the 2 joints, I prefer to use the PIP joint of the 2nd finger together with the skin in order to reconstruct the MPI joint of the 3rd finger. So you see the reconstruction. This is the PIP joint of the amputated finger, and but this hand is a 4-finger hand, which is very functional. Joint, the new MP joint was working very well, and you see the function here. So this is something to keep in mind, because sometimes spare parts are very useful and can be useful to solve a problem. So in conclusion, orthoplastic surgery, in my opinion, belongs more to the plastic world than to the orthopedic. However, cooperation with the 2 specialties is of paramount importance, and the next step will be to have a specific educational program and guidelines to standardize as much as possible the procedure. Nevertheless, orthoplastic surgery is a creative surgery, and we don't have to miss innovation. Very much. This is the library of Rizzoli Institute, where I really would like to invite all of you to participate.
Thank you very much, Professor Innocenti, for your presentation. Now it's a very crucial themes of the Ukraine nowadays. And are there any questions? Тобто, наступна доповідь.
Okay, so the next talk is going to be delivered by... Yes, the next talk is going to be delivered by Serhiy Tertishny, Military Clinical Center of the South Region, the basic of reconstructive plastic surgery. Good afternoon, dear colleagues. I would like to thank you for this opportunity to represent our common work, which in these conditions is one of the most actual issues, not only in surgery, but also in orthopedics and surgery. In the environment, we do understand that daily during the rocket shelling or when we have attacks of our enemy, we have injured and wounded. And according to the latest statistic data, in 70% and in some cases 75%, we have damages or issues of the soft tissues or covering tissues, which are divided into major and small defects. 37% small and medium, and also 30% around major tissues. And Winston Churchill has mentioned that war is a powerful development of the reconstructive surgery. Type of wounds, depending on the type of wounds, we understand that there is no mono wounds, and in these conditions also we have the changes of paradigm of how the war is happening. We do not see the enemy, but we use shelling systems and also high energy weapons. It has a huge damaging potential. So simple damages on the level of the skin or subcutaneous tissues, it does not happen frequently. Right now, also gunshot wounds are not observed that often. And first of all, we face the wounded because of the shelling weapons which are being used. So what are the demands regarding the reconstructive surgery? First of all, we need to use the classic approach, which starts from finding the reconstruction donor site, optimization of this donor site based on the final and not on a magistral blood flow. We need to form the flap regarding the closure. We need to traction the flap when we elevate the flap and when we transfer it to the place where the reconstruction is happening. We need to moisturize the wound surface and the flap. we also need to use chemical components, which we constantly use during the long-term surgery. And as our colleagues has already mentioned, these are long-term surgeries, 10-12 hours. Also, we need to have sufficient infusion therapy. We need to prescribe additional components such as proteins. We need to have a proper drainage of the flap, which is focused mostly on the dynamic drainage, and also it is optimal for some colleagues to use negative pressure systems. And also, first of all, we need to have a strategic approach, which is being also used in case of the closure of the donor site. In case it's a spontaneous hospitalization or any kind of other hospitalization, and we also need to use the free flaps in case it is available. Optimal journey or environment for reconstruction. This is the clinical experience which each one of the practicing surgeons have, but also we need to have the knowledge of anatomy. And also in reconstructive plastic surgery, it's not a classic approach, but that's the usage of the blood flow angio knowledge theory by Ann Taylor. This is additionally might be used perforasome theory, which is actively being utilized in the reconstructive surgery, and also objective approaches of pre-planning and dynamic monitoring. So pre-hospital, additionally to the hospital thinking, to clinical thinking, there should be an objective indicator, which is going to be the background to have the final decision regarding the closure of the wound. Team. First of all, team, that's the key. And that's not just one surgeon. It is usually consists out of the couple assistants which are elevating the flap and which are preparing the surgery. The only approach regarding the flap usage, it needs to fulfill the timing regarding the surgery. Also, we need to constantly improve our skills of the surgical brigade, which allows not only to shorten the time, but also to improve the quality and functioning of the function. Also, the creation and understanding during the surgery among all the participants of the surgery, surgeon, assistant, anesthesiologist, hypotension, or immediately after the microanastomosis to control the elevated blood pressure, it is extremely important.
And also creating comfortable conditions of work is an additional component, and during a prolonged operation, 10, 12 hours, or we talked with Marco about his case, they operated for 36 hours and they had a positive result. And also strategic work, which is cooperation with global institutions. They check our clinical experience and our approach and lets us move forward. Material and technical base is very important prerequisite and has to correspond to level 3 and better even level 4 care provision. This is according to NATO standards. Medical Forces Commandment requirements. Saline has to be 36 at 37 degrees, bipolar coagulations that allows to decrease coagulation necrosis and the current spreading onto soft tissues. Hemoclips use is one of the minimal things to minimize damage, and instruments, specific instruments. Identification of perforators is one of the key components. As we see it, those are small vessels with a diameter from 1.2 to 0.3 millimeters. And this is the basis for plastic reconstruction and dynamic digital thermography, and we already use it on levels 1 to 4. Audio Doppler is also used on level 2, and if it's at the 3rd level, is the expert system that allows to objective volume and blood flow. CT angiography currently is possible for all casualties. As we understand, it's not possible to use that because the number of wounded people is very high, construction very much, so to be objective. And also using indocyanine green currently It's one of the basics of reconstructive strategy in Ukraine, but so far it's too expensive. And relevant position of perforator, assessment of anatomical variation, angioarchitectonics or architecture, calculating anatomical peculiarity, morphological transformation, and alternate plan has to be developed. That might change. Also, a choice of base and reserve components of feeding. So this is the basis for tissue transfer adaptation. Also, this is key for mobility during reconstruction. This is the monitoring of the flaps used currently by military people from the first group, level 1 through level 4, in southern region, for example, level 4. So this is a system of dynamic monitoring that allows to objectivize every clinical anatomical structure. Assessment of clinical picture, objective status shows where the key vessel is located, and we determine the rotation or transfer based on that. It allows to choose the complex of tissues with good perfusion, decrease the time of surgical dissection, and also increase the quality of reconstruction due to compensation of the volume, lost volume, functional component of active movement, and aesthetic component as well. This is reliable and clear repair of the interior part is not only for aesthetics but also for anatomy that improves the quality of life. And this is thorough preparation plan, adaptation of surgical approach. It's not a surgical research, it's a view and objectivization. And on our level, we've suggested the most reliable, the best during the military times, military activities during the war, and it good option during reconstruction, and it's good for dynamic monitoring. So these methods can be used during the reconstruction and after the reconstruction. Does not use the disposal of the supplies because it's remote and objective. First of all, objective. An example. So this is rotational flap was used and tension test, and this tension test is checked during the this thermal So currently it was done in Uman City Hospital. The first stage, it was debridement with negative pressure system, and then the internal defect or knee was done using the sliding on the posterior part of the knee. And this is sliding knee, sliding flap. This is for the shoulder. Classical monitoring was used for that. And it allows to have epithelialization in a shorter period of time and increase the functional component. So that's what's the most important for us here. And this is the gunshot wound of the left forearm and shoulder, defect of soft tissues, and the radial nerve is damaged and multiple in 1 month. You can see, and the next step of reconstruction is repair done in Italy in Grazzola Institute, prosthesis for the elbow joint. And this reverse sural percutaneous flap in the calcaneus area. Also, during monitoring, thermography and the sonography method. And this is first in Ukraine microscope from Karl Storz allowed us to do rotational reconstruction. Rotational flap was used for the defect of the external area, 10 by 5 minus 1.46 centimeters on the level of 5 days later, you can see the complete integration of the flap that was transferred to the knee. For some reason, I cannot start the video, and I'm sorry for that. This is gunshot wound of the right side, which is 4.5%. Quadriceps lost, 80% was done on our level, and then repeat. And in the Grasoli Institute reconstruction with from the left femur, the transfer was to the right femur, right thigh. I'm sorry, and this is the left forearm, pre-flap anterior lateral thigh flap was used, and that was done in Western Medical Center in Lviv, classical strategy techniques. So this the systems of pressure was used as well. And you can see very bright granulations during the contact with instruments. They start to bleed, and that allowed to use the LT flap method. And 7 days later, the patient was sent to the rehabilitation. Thus, I just wanted to mention, just like was mentioned by previous speakers, that the basis for reconstruction is the teamwork. It's the surgeon and the rest of the team. So everyone is important on all steps of reconstructive repair. So that has to be the basis, as just the Konstantin, the general, has mentioned before. So that has to be done from the first level through the fourth level. So intraoperative monitoring of vitality, so thermal scanning, sonography makes it more objective and gives more options to our clinical case, together with the international leaders, Royal College of Surgeons, Charité Clinical, Penn University, and Latvia University of Latvia. Make sure that what we do to treat defects of soft tissues and what we do is occupies a relevant place there, and it's quite good quality. So for conclusions, I would like to mention that the instruments, the main part of operation, but not number one. So it's important, but not number one, because if we have a car, it's good, but without a good driver, it's not going to go anywhere. So clinical experience and practical skills is the way to flexible reconstruction based on objective assessment methods. So in case you do reconstruction, just like you saw some of the clinical cases from professor from Germany. So in case of complications like infection, inflammation, destructive, so dynamic monitoring needs to be in place, and you have to follow the guidelines what to do. Either you have to do the repeated surgery to remove the flap, and strategic thinking what to do next for the repair of this anatomical structure. So requirements to reconstruction, repair by volume, function, aesthetics. They needs us to be creative, and of course a functional active component needs not to be forgotten. It has to be number one, because even if the functional component is decreased by 50%, still we have some servicemen who would like to still continue to be part of the army and defend our motherland, and that's the optimal way to go forward. So all possible mistakes during reconstruction, to our way, it's an experience, and we understand. So when we exchange this information, we are going to help each other, and that will decrease the number of complications and increase the overall level of reconstructive surgery. And the main component of reconstruction during the war in current conditions, it has a new meaning, and we have new monitoring, and neither Bundeswehr representatives or NATO representatives in current conditions were not looking at that option, and now when they learned about that, they believe that it's going to be strategically relevant during war conflicts, military conflicts in which NATO countries are going to participate. Thank you very much for your attention. Thank you for your presentation. Because we do not have a lot of time left, we would like to give the floor to our next speaker, and this is going to be Andrei Rusnak, providing emergency surgical care to wounded people on the pre-hospital.
Колеги,
Good afternoon, dear colleagues.
чутно?
Hopefully you can hear me. So, good afternoon once again, dear colleagues. Thank you so much for this opportunity to be part of that significant conference, to share my experience, to provide surgical care to wounded people who are based on the compilation of current Assault Brigade 3. Because there's been a lot of changes made because of the war. So there are some differences between the classical way of doing that, and we've developed something in the middle. It's working, and that's what I wanted to share with you. As you know, it's not a disputable question that the quality of care provision, surgical care provision, dependent on time from the moment that the professional medical care is provided according to the standards that our NATO partners use. Any surgical care is divided by steps. Role 1, Role 2, Role 3. Each step has its own function and provides certain standards. So that's how it looks ideally. So the time between Role 1, Role 2 and Role 3 is the standards, NATO standards. But unfortunately, during this large-scale war, this is not working, and probably it wouldn't be possible for our partners to use the same. So realities are different. So evacuation time and transferring patients from Role 1 to Role 2, except 1 hour, it's up to 8 hours, and it's not the worst to be 8 hours. And subsequent transfer timing also changes. And also with regards to availability to use tactical medical evacuation, aero medical strategic evacuation is very limited, unfortunately, and we need to adapt to the current realities of life in order to be working with wounded people as good as possible, as efficiently as possible, because time matters. And not only for long-term, but even for short-term, immediate results. We are talking about the survival. So Role 1, first step, this is what has to do with the combat field. What is the specific thing for that? The time of evacuation is quite long. Sometimes evacuation time was 48 hours, 72 hours. What it's related to, you understand perfectly well, that the massive use of artillery, different intelligence strike and FPV drones, and a significant number of anti-tank weapons, and it does not allow to get there and to use medical evacuation in the field. poor quality of roads, especially now with rain and snow. A truck cannot get or a van cannot get anywhere. So sometimes it's very difficult. And beside the poor quality of roads, also it's there is a fire control evacuation road. So from the time of injury to the time of care provision, a lot of time passes. Role 2 is basically the surgical care step, and primary surgical groups are doing that according to the standard. They're in the yellow zone, but now the limits in between red, yellow, and green zones is very relative. Why? Because again, drones, long distance strikes, FPV drones make this front line not very definitive. And considering these time intervals in order to provide professional and high quality care, our medical we've developed a stabilization station, so to say. It's not something that we have invented, but still the amount of care provided at the stabilization station is quite significant. And we locate the station usually located in the place where medical evacuation is possible from, when medical evacuation is within 30 minutes. So that's where we located. So 6 may be up to 15 kilometers from the front line. So that's where the location is, and it allows to evacuate and save the critical casualties, because even half an hour or 1 hour of extra time for them is relevant. Hospitals do not always have the possibility to use their primary surgical groups in order to provide for this time intervals. So very often this aid station or stabilization station is doing that. Can be separate, or several brigades can be united in order to provide comprehensive care, because the ability of each separate team so far is different. The stabilization point is basically the first place where professional medical care is provided. It includes anesthesiologists groups, also surgical group is there, as well as traumatology group, covering the major percentage of casualties and wounded people. Also, we have vascular surgeons who work in order to have the ability to save extremities as soon as possible.
So, the main stay in our stabilization point, it is the point between the first and second level of care, and it is located in a not really safe places. That's why patients, they stay for a short period of time. We try to have them from 15 to 15 hours, from 15 minutes to 2 hours. It depends on the situation of the patient. In case this patient is needed to be stabilized, in case it is stable, it is going to be evacuated. In case it's a severe patient who requires some kind of surgical interventions and is in the critical state, then of course this patient is going to stay there for longer. Based on what we have at this moment of time, and 20% of the patients, these are critically wounded patients, which we need to work with really. 30-40%, this is an average data. These are patients with easy and medium difficulty, and also around 50% of the patients, these are the patients with concussions. This is acute barotrauma. These are the concussions of the brain. And also 85–90% of cases of wounded patients, these are mine explosive injury, blast injury. The usage of drones, FPV drones, and other weapons. So, what do we have at this moment of time? We adhere a threat approach when we work. So we control the main functions, and also further on we need to evacuate the patient as quickly as it possible to the next zone where there is the second level of care, which is being where the primary surgical units are working to provide the care. So what does stabilization point do? That's also triage, medical triage, resuscitation and stabilization. So based on this, life, limb and function, that is something which we try to preserve and to save. In case there are indications, we initially start to perform surgical interventions, which are under the damage control approach. In case we do not have critical patients, we do not have other approaches to relieve the state, then surgery is being used. In case we have other options to stabilize the patient and to transport the patient and in the conditions of the primary surgery, then the sedation is going to be much better, and then patient moves forward. Besides that, we need to have a life support. We need to treat some kind of acute infectious, so-called septic states. That's a primary stage. Also, antibiotic prevention. Also, diagnostic approaches are being utilized. Ultrasound, X-ray, radiography, and some kind of primary blood count analysis in case it is needed. And also blood transfusions are being performed. In fact, this is the more optimal approach than blood transfusion in the battlefield, because we have an opportunity to perform this blood transfusion under the supervision of the qualified medical professionals. We use the same group blood, and in case there are any kind of transfusion complications, this is a much safer approach. And also documentation. Usually, stabilization point, which covers one sort of brigades, it's enough to have 3–4 places for intensive care unit for severe patients, which includes surgical tables and also opportunities and possibilities to have 3 surgical tables, basically. 2–3 places which are being formed for patients which are not critical, for simple patients, where we just need to have a bondage, where we need to provide analgesia, and that's it. And 6–8 places, these are the beds which we have for therapeutic places, for patients which have concussions. For patients with concussions, we have a lot of those patients, 50% of all patients, and that's why the amount of places are increased, because we need to have all of those patients. Patients with concussion, they are evaluated according to the scale. We evaluate the severity of concussion, and we have a lot of those patients. In the intensive care unit, in the surgery, what do we have? We have basically a surgeon anesthesiological brigade team, and also assistants, anesthesiologist assistant, and also nurse, operating nurse, surgery nurse, and also there is a traumatologist who is working together with a surgical nurse. In fact, this is the place where we work with severe patients. We perform different kind of interventions, which are also within damage control concept. So we evaluate the patients. We have an X-ray, portative X-ray. We perform the needed minimal diagnostic approach, minimal diagnostic evaluations, and then we decide whether the patient is going to be transported to the next stage or whether we need to work with this patient immediately in place before full stabilization. That's how it looks like, more or less, in the field conditions. And that's not the worst option for you to understand. For For patients which are not severely injured, so patients which are not critical, these are so-called places. Why do we have just 1-2 of those places? Because the time of those patients staying in these beds, it's in case it's just debridement of the wound, it takes 15 minutes and then patients move further. And also places for patients which have mine blast injury, who have concussions. There are no shelling, there is no gunshot wounds, that's just concussion. This is how it looks like. So for evacuation, for transport, we have 2 resuscitation vehicles, 2 emergency vehicles, and 3-4 sanitary vehicles, which work as basically ambulances. What is being performed? So we are under the damage control concept. We stabilize the state of the patient. We need to stop the bleeding, stop the facet. In case there is a need, we perform laparothoracosynthesis, and then we perform emergency laparothoracotomy in case it is needed, but only in those cases when we do not have other options. When it is a critical patient who has unstable hemodynamics and we are unable fully to stabilize him with the conservative approaches, then we need to stop the bleeding in those conditions in which we are. And also we use rather actively, we have it during the last period of time, we have REBOA and we use it actively. Also, we use it to have an opportunity to win and to get and to save some time to stabilize the patients and to transport the patient further on to the place where the more quality care might be provided, where the environment is much better. The principal question is the following. The principal question are limbs. Limbs and preserving the function of the limbs. What does it mean? In case we have some kind of vascular issues, main arteries issues, even additional hour which is going to be spent without the blood supply, it's not going to have a positive influence on the early recovery of the limb. And in fact, in case we're not going to recover the blood flow as quick as possible, then it's going to end up not in a good fashion for this limb. That's why the main thing which we use vascular surgery. We use temporary bypasses in those cases, or when we have an opportunity, then we use vascular anastomosis or autovenous bypass. We do not use it often. It's a frequently case. It's not frequently done, but we need to use that. Also, we stabilize the fractures, and also what I have mentioned previously about the long-term evacuation. We do have a lot of tourniquet syndromes. This is basically an epidemic which we have right now. Why? Because we have tourniquets, we have a lot of them. People have learned how to use them, but the question about conversion of the tourniquets and how to use it properly, it's hard to solve. We also lack combat medics, and also we lack some kind of medical training. And when we reveal the tourniquet, we try to reveal it in the stabilization point. Why? Because in case it's another hour from our stabilization point to another medical facility, it means +1 hour for the tourniquet, and then we do not have a lot of chances to preserve the limb in case the tourniquet is going to stay. We have around 20% of amputation of all limbs. They happen due to the tourniquet syndrome, 20% of amputations. So to perform the conversion of the tourniquet to decrease the amount of the amputee, that's an important approach. In fact, according to the standard, the tourniquet should be applied for 2 hours, but we relieve tourniquets in 2, 4, 6 hours. Right now we work with that. And one of the possible approaches, one of the possibilities, that's the development of transport hemodialysis and early hemodialysis to somehow fight with the reperfusion syndrome which appears. It's not always successful. In case there is no opportunity for us to relieve the tourniquet, we leave it. But in case muscles are alive, in case there is a possibility to get back the blood supply, we try to do it. That's basically what our stabilization point does between the first and second institution. And in the end, I have never used this in my civilian life, but right now, in most of the cases, the medical supply, it happens thanks to the volunteers. And I would like to say thanks to our colleagues from B. Brown, which for 3 years are together with us, and they constantly support us. We work with them, and thanks to them a lot. Thanks a lot for your attention. Thanks so much. There are no questions because it is rather clear and everything is understood. This is the most under the pressure point of providing care to the military personnel. Thanks so much. Dear colleagues, our work for today, according to our agenda, has been finalized. And that's why tomorrow we are going to start our work at 9 o'clock in the morning. All meetings, also in this meeting room. In this meeting room, we are going to have a session which is going to be dedicated to trauma. It starts at 9 o'clock in the morning. And also in other meeting rooms, we're also going to have meetings at 9 o'clock. Right now, everybody who is invited to have dinner, everybody else who is not invited, please, you are free and you may enjoy your evening. Have a nice evening and thanks for the fruitful cooperation.